Good morning and very warm welcome to you all in the Tamil Nadu Autism Convention 2026. We request everyone to please rise for the Tamil anthem. Thanks. Sorry, it is due to near the inauguration. Please be seated. To formally welcome you all and introduce today's convention, it is my privilege to invite Dr. Rema Chandramohan, Deputy CEO, Center of Excellence for Persons with Autism, to say a few words.
Good morning to everyone. It's my privilege and pleasure to welcome you all to this important conference on autism. Today we have gathered not merely to discuss a diagnosis, but to discuss children, families, possibilities, and the kind of future we want to create for persons with autism. Autism is increasingly being recognized in our communities, but recognition alone is not enough. The real challenge is to ensure that a child is identified early, receives the right intervention at the right time, and is supported consistently throughout childhood and beyond. As healthcare professionals, we have a unique responsibility in this journey. The pediatrician may be the first person to notice a developmental concern. The psychologists, psychiatrists, therapists, educators, and other professionals each bring a different perspective. And most importantly, parents bring an understanding of their child that no assessment can replace. Autism care, therefore, cannot belong to one specialty. It has to be a collaborative effort. So this conference is an opportunity to bring together medical professionals, therapists, educators, researchers, and other stakeholders to share evidence, experiences, and practical approaches. I hope our discussions today will go beyond theory and help us ask very important questions. As an organization committed to autism, we believe that every child deserves the opportunity to reach their potential, and every family deserves to feel supported rather than overwhelmed. So let us use this opportunity to learn from one another, challenge existing practices, embrace evidence, and above all, keep the child and family at the center of everything we do. I wish you all a very meaningful, engaging, and productive conference. Thank you and welcome once again.
Thank you, ma'am, for the wonderful welcome and overview of the day ahead. For our first session, I invite the chairperson, Dr. V. Jayantini, to the dais. Dr. Jayantini will be inviting Dr. Subramanian, Dr. Srinivasa Raghavan, and Dr. P.P. Kannan.
Good morning, everybody. A very good morning. I'm extremely happy to be here today for the simple reason this is my 50th year in the field. I entered this field in March 1977, and the first person I saw, though I know the person was my niece, but it was the first time I realized something was wrong with her, something is not normal. She's 62 now. She's a person with ASD. She's an active communicating autism spectrum disorder. At that time, I did not know anything about it. I took her to my department to be shown to my chief in GH. In 1977, they diagnosed her to be mild ID, intellectual disability. By chance, I'm telling you this because we should all know about the evolution of understanding autism right from 1943. I read an article by Leo Kanner. In 1981, I read it, but it was written in 1943. Early infantile autism, or Kanner syndrome, the Canarian autism. Our library in IMH is a treasure trove. Then something struck me there, something. Maybe this girl has got the symptoms. Then what happened? I started reading Lorna Wing's article about autism continuing in 1981. This was in 79, 81, I read that. She has written articles along with Judith God, and she is the one who coined the word autism spectrum disorder, from autism continuing to autism spectrum disorder. Kanner gave a categorical diagnosis, and Lorna Wing gave a dimensional aspect to it. And she is the one who coined the word Asperger's syndrome, though Hans Asperger wrote an article on that. He was interested in that in 1940s, but she gave this name in honor of Asperger's. This made me think, probably this girl has got that. And that's how I started gaining interest in ASD. And till today, we have not excelled Wing's criteria. The three things which she mentioned in her article: social interaction, social communication, social imagination, which boils down to restricted repertoire of activities and repetitive behavior. This is Lorna Wing's triad. Though we have added, substituted, subtracted, made elevations, the pillars are the same. And I felt you should all know about Leo Kanner, who of course thought autism was due to refrigerated mothers or cold mothers, which we do not accept now. And later, Lorna Wing's work on this, she was working on this till her age of 85. Unfortunately, her daughter had severe autism. Probably that's the reason she gained interest into it. With this, I'm going to give the mic to others to talk. Let me not take more of your time. Thank you. Now I would like to invite Dr. Subramaniam, a renowned pediatrician. Almost everyone in South Chennai, most of Chennai must be knowing about him. Autism Crusader, as Rema says, and he is very much interested in developmental pediatrics, neurodevelopmental disorders. So I'm inviting him to talk to you about your topic is neural basis of autism.
Good morning, everybody. Thank you all for being here on a Sunday morning. I should thank the Center of Excellence of Autism for many things. First and foremost, for inviting me. Second, the center is doing a commendable and phenomenal work. And of course, with Rama Ma'am at the helm, I don't think it will do anything else. I think it's filling in a lot of gaps that are there in the society, in the community, as far as Chennai is concerned, at least. And it's important that we all also contribute to this movement. Madam, இப்போ ஆரம்பிக்கிறச்சு 1977 பற்றிலாம் பேசிகிட்டு இருந்தாங்க. Sometimes God has different ways, methods of grounding us. நான் பிறக்கிறதுக்கு முன்னாடி பற்றி அவங்க பேசிகிட்டு இருக்காங்க. நம்ம இங்கே வந்துட்டு எக்ஸ்பர்ட்லாம் மேடம் அதுக்கப்புறம் என்ன பற்றி சொல்கிறீங்க. ஐ டோன்ட் திங்க் no, I don't need it. It's a very simple PPT. Don't worry. Not very difficult. So I think what is important for me was that it is with great gratitude that I stand in front of you because I have been given an opportunity to work with children first in general and an opportunity to work with children with special needs. Not every pediatrician has this opportunity to understand, the time to understand, and the what do you say, the correct setup to help him grow or her to grow. I think there are many people who are working with me, including Dr. Padmalochini, Srinivasa Raghavan, ma'am and all. So I think they will all know that we are nothing but a product of our environment. And whatever today that you're going to listen to me or whatever you think is good that is coming out of me is a product of my environment and not myself. So with that submission, let me start my topic. Change ninga yaradhu pannidringa? Is it okay? Yeah. Thank you. So I've been given the topic of neural basis of autism. That's a very tempting to think, or a neural basis. When you think of neural basis, you seem to tend to think that, okay, this is what will be there in autism. This is what will be there in stroke. This is what will be there in CP. This is what you will expect in a given condition. So it is very tempting for us to think that this is what you will see in a child with autism. But let me start with a very provocative question. I know it's very provocative. Is there an autism brain? That is the question that we all need to ask ourselves. Is there a typical autism brain that can be defined? A simple, straightforward answer is no. There is no such thing as an autism brain that you can do a scan and identify this child is most probably going to be autistic or is autistic. But a more in-depth answer will be that there is a lot of variety, and when we try to understand the depth of that answer, we will understand children with autism, we'll understand adults with autism, persons with autism. Next slide, please. So there is no single gene, there is no single brain region, there is no single connectivity pattern, and there is no single developmental trajectory that can actually define autism. And we all know that in our practice. It makes autism almost look like an mystic thing, you know. தூளிலும் இருப்பார் துரும்பிலும் இருப்பார் அப்படிலாம் சொல்லுவோம். அந்த மாதிரி அதே மாதிரி என்ன எங்கே இருக்குன்னே தெரியாமல் இட்ஸ் ஹைடிங் சம்வேர் அப்படின்னு நினைக்கிறோம். பட் இட்ஸ் நாட் ஸோ. கேன் யூ கோ டு தி ப்ரீவியஸ் ஸ்லைட்? So the neural basis of autism is real. And it is this reality that we need to understand. It's plural. It's not a single uniform, unidimensional thing. Next slide. So this is how I've divided my thought process in this talk. We are going to look at genes. Why? Because genes are the ones that determine how a given cell is going to grow, which part of the cell is going to grow, how it's going to work. And based on the genetic regulation and cell development, various synapses are being formed in the brain. And these synapses lead to brain networks, and these brain networks lead to development along with their experiences that you have in real life. And this leads to individual developmental profile. And when we look at autism at these levels, these dimensions, I think we will understand it better in terms of neurology. One thing that I want you all to understand is that it's not a linear chain. For our understanding, we have tried to build it over a period of time, but it's not a linear chain. It's always a multi-feedback thing which is very complex and very difficult to represent in a unidimensional or a bidimensional screen that is there here. So one thought that we all have as pediatricians is there a single point? In the point, what is that point of time when there is a damage hit, after which it happens? Because that's what we are used to. What is the time antenatally or prenatally that there is a hit, after which everything develops is what we think. But in autism, we can't predict a given specific localized hit, after which everything has happened. Or we can't look at a given single location in the brain after which everything happens. So when we look at children with autism and their brains, at different times, different things happen. So there is no uniform way of defining how these brains actually work. Next slide. So to give an example, they took up in a prospective study, they studied children at a higher risk of developing autism because of familial risk, and started following them up prospectively. And they found that even before symptoms develop, around 6 to 12 months of age, there is increased cortical surface area. And over a period of time, these children started developing by 2 years, started having a brain volume, or there is a brain overgrowth. All those children who showed these patterns in this cohort developed autism. So, does that mean brain overgrowth actually defines autism? Macrocephaly as we examine? No. This is only in this cohort where there is a familial risk that we find this. But we don't find macrocephaly in every child with autism. So, we need to understand the difference here, that when you prospectively look at a high-risk cohort, in that macrocephaly is a possibility. But when you look back at all children with autism, they don't necessarily have macrocephaly. So that is something that we need to understand. So just this trajectory alone cannot become an universal biomarker. That is something that we can understand from this study. Next slide. So what about genes? Let's look at genes. There are a lot of genes that have been implicated. Sometimes there are small genes that combine together and manifest as a problem. Then there are some rare inherited specific genetic mutations. I found out from ma'am, I didn't want to bore you all with the numbers, exact gene locations and other things. Just let's go through. There are de novo variants. De novo variants are variants that are not inherited from the parents. Then there are copy number variations, which is why we do chromosomal microarray. Then there are chromosomal changes. There are identifiable genetic syndromes like tuberous sclerosis, neurofibromatosis 1, Fragile X, and so on and so forth. So there is a varied genetic heterogeneity that you see in children with autism. And so they are, once again, from a genetic perspective, we are not able to fit all children with autism into one single group. Next slide. But why does this happen? How can we wrap our mind around this? This is most probably because different genes code for different things. For example, some of the genes that are affected in autism code for how other genes are exposed or how other genes are expressed, how the chromatin is folded inside the cell. Because the folded genome, the way it is folded will expose or not expose, cover certain aspects of the genetic material. So how does that happen? How does that, many of them might influence the cell proliferation, neuronal synapse formation, and neuronal communication. So there are multiple levels to which these problems can influence, and that is why you have multiple genes that affect. But there is a common form and pathway, that is the autism. Next slide. So when we look at from a cellular point of view, which are the cells that are usually involved? Whether there is any homogeneity there? No. There are a lot of studies that are started looking at single cell neurons, how they work, how they grow, how they communicate. And there are organoid study models where they have a group of stem cells that are made to differentiate into a mini area of the brain. And they started studying it. Based on, it's very interesting when you go and read how they stimulated all these things. But the conclusion is that autism-like features are found, or changes are there in multiple cells. There are neuronal progenitor cells that are affected in some cases. In some cases, it is the upper layer excitatory neurons that are affected. Sometimes it is the superficial layer of interneurons that are affected. Sometimes it is the projection neurons which connect two different parts of the brain that are affected. Then the support structure, astrocytes, microglia, oligodendrocytes, inflammatory cells, all these cells are also affected in some model. So does autism actually have a single model? No. There is no single cell that is actually affected that we can say, yes, this happens, then autism occurs. So once again, the biology is very varied. It's totally heterogeneous. Next slide. So is it the synapse? Is it synaptopathy that is causing autism? If it's not the cell. when we started looking at various studies, synapses control the signal strength. They control learning. They control the brain plasticity. They control how we perceive sensory signals. They control how different areas of the brain coordinate with each other. All these things can manifest in autism. You are right. But then there is no single synaptopathy or a single synaptic problem that can actually define a child with autism. Next slide. So, if it is not synapses, is it excess of neurotransmitters? Is it excess of excitatory and or inhibitory neurons, that imbalance that is causing autism? Because we hear children with autism have too much of excitation, that's why they are like this. Is that why this happens? No. Once again, it all depends on which brain region we are looking at. It all depends on what stage of life are we looking at. It all depends on what cognitive status the child is. So all these things also actually influence the way a child with autism behaves the way it behaves. So automatically when we look at whether it is excitatory or inhibitory, we are not able to give a single answer that it is always excitatory. Next slide. So if it is not the synapses, if it is not the neurotransmitters, is it because the network is not okay? Does autism specifically belong to any given center? Many of them talk about prefrontal cortex, some of them talk about amygdala, some of them talk about temporal regions, some of them talk about cerebellar circuits. But no single circuit, once again, we have been able to actually associate directly with autism. There are multiple systems that are involved, and many of these systems need multiple areas of the brain. So there cannot be a single part of the brain that can actually define abnormality of autism. Next slide. So could it be just that different parts of the brain don't seem to talk to each other the way they are supposed to be talking, or seems to be talking too much? Like they say, because of lack of pruning, too much of content is going into the brain and children are often confused, so they are not able to look at their foreground and background. Is that why autism happens? That is not the case. We have found that children with autism, depending on the age, depending on their cognitive status, depending on their arousal levels, have different configurations. And we can't actually simply, in a single uniform, homogeneous way, call them as either underconnected or overconnected. Next slide. What happens to sensory input that is not being processed properly? We all know it. There are two photographs there. That's what all of us see is what we see in A. But a child with autism may actually see the smoke coming out and there is a lot out of the coffee and may actually be focused on that rather than rest of the system. So sensory perception may be different for different aspects. And is that why there is a difference? Is the sensory perception, is that why this happens? When we look at one of the studies looked at autistic young children's sensory over-responsivity, and they found that it is the difficulty of many of these children's brain to habituate to a given sensory signal, which is why this happens. But can we actually generalize it to all children? Very unlikely. It happens only in some specific cohorts and not with everybody. Next slide. So how does our brain usually work? Our brain usually works with having an expectation. I expected as soon as I come to have a hall, to have AC, to have a audio-visual aid, to have ma'am there on the stage because I saw it. So there is an expectation that is built in my brain. And when I come here, I look at what is there. I interpret the present experience with my expectation. And then that leads to my regulation or dysregulation. And I work and I try to adapt to it, and then I work through it. And then this process goes on. So now I have expectation to complete it on time, and then what will happen? So I have certain expectations that is going on. This is how it happens. There was one type of definition where they say children with autism had unexpected events created an extra amount of weightage and leading to different type of response in the child. So environmental volatility, that is a change in environment which is not expected, creates an dysregulation in the child, which is why many times these children prefer stable routines. This is one of the thought process that is there. So predictive processing accounts is how they define it, is one of the ways of understanding many children with autism with some amount of rigidity. But that does not completely explain every aspect of autism once again. So when we look at different theories, they all are able to give us, look at specific aspects of a behavior or a specific aspects of a presentation rather than trying to explain the whole theory as such. Next slide. So what about social communication? The social brain of the child is affected. Is there a single social brain area which can be affected? Very unlikely. We have to, when we are social, when you're talking about it, we are looking at faces, we are recognizing voices, we are understanding language, we are providing attention, we are attaching salience to a given experience. There is memory, there is prior experience that is there, and we are trying to look at and understand the other person and trying to read between the lines. There is a lot of motor planning. All these things don't happen in a single area of the brain. It happens in multiple areas of the brain. Once again, can we reduce autism to a simple thing like the social brain is not working? Very unlikely and very inappropriate. So I don't think that also can actually define. Next slide. So autism by itself has to extend beyond the social cognition. It has to also include the cerebellar and motor system, because we know that many of these children manifest with motor coordination, early mild developmental delays, and having difficulty in adapting to a new environment. So all these things basically shapes a child with autism's behavior. So we cannot reduce the whole thing only to the social context as far as the child is concerned. Also, when you look at a behavior, there are different neural demands that can actually give rise to a behavior. You're all experts in autism and you all seen many children with autism, and we know that a given behavior can happen due to multiple background issues. So just because you know the behavior, you can't define why it has happened. And it's even more difficult for us to define the neurology of it. So, next slide. So what does neuroscience in conclusion tell us? It definitely tells us that autism is an early neurodevelopmental condition. That is for sure, because there are variations that we can see. It's a biological process and developmental heterogeneity. Yes, agreed. Multiple pathways lead to similar clinical features. Not all these pathways may be involved in a given child. There are sensory, motor and regulatory systems that are involved and they get affected. Agreed. And because there is so much of heterogeneity, individual evaluations and treatment plan or intervention plan matters a lot. It reinforces our existing belief. What does neurobiology not tell us? Definitely tell us no. It says that diagnosis of autism through routine brain scan is not going to be possible. You cannot define a child with autism based on a scan or a imaging study. You cannot identify one universal neural signature for autism. You cannot predict a child's outcome based on these neurology or this brain scan. You cannot select a therapy based on a given brain structure or a imaging. And we are not able to explain every aspect of a child with autism's behavior through one single theory or neurology. Next slide. So why should we as clinicians, we are not science, we are not researchers, why should we as clinicians know neurobiology? What is the conclusion? So basically, it is important that when we understand the heterogeneity involved, when we understand that there is so much of underground activity that is happening that is beyond our eyes, we start looking beyond the label. We understand it is biology, it is not the person who is wrong. We also have to look beneath the behavior, not try to understand every behavior with the same prism or with the same thought process. With this information, with this clinical heterogeneity, we need to look at how we can modify the environment to help these children with autism access the community and people, which is our main aim. And at the end of the day, we need to build participation. To build participation, we need to individualize the kind of care that we give for these children. So neuroscience should not be used to reduction or reduce the concept of autism. The concept of autism is plural. It's wide. We should not try to use neuroscience in the contrary to what it actually states to reduce it to a single pathology or a single neurological connection. Thank you all.
நான் கொஞ்சம் ADHD அதான் பிரச்சனை. Thank you, Dr. Subramaniam. For the youngsters, it's very, very important because parents do come and ask you, how did my child get this? Why my child? They feel guilty. They ask you about genetics. Could it have come from my wife's side or husband's side? There is a family history of schizophrenia or bipolar disorder, or my wife was on medication. All these things they will question because of their guilt, because of their anxiety, and you should be in a position to explain to them. That's what you have learned from Dr. Subramaniam now. Next, let me call upon Dr. Srinivas Rahavan, pediatrician, who is going to talk about early identification and its challenges. I know he's a wonderful speaker. I have heard him previously. Rather than identification, the challenges are going to be very, very difficult. Please take the podium.
Thank you, ma'am, for the kind introduction. So, as ma'am already said, I have come to sell coal in Newcastle. Tirunelvelike alvava appadina. We have an audience full of experts in autism, and what I'm going to talk today is about the challenges that we face and some possible solutions how we overcome this challenge. So we are going to see the pragmatic solutions, what we can do within the existing time or what we can do within the existing framework. That is what we are going to see today. So as we know, the challenges definitely abound. This is an article in 2022 in the Indian Express newspaper which says, in India, routine pediatric health visits mostly focus on the anthropometric parameters, cure for seasonal symptoms and vaccination schedule. நல்லா இருக்க குழந்தைய டாக்டர் கிட்ட கொண்டு போக யாருமே விருப்பப்படுறதே இல்லை. ஸோ வாட் டேக்ஸ் அ ஹிட்? Developmental milestone mapping is a big gap area which is largely unmet in Indian system, and that leads to undue delay in autism diagnosis. So when we have seen that this is a challenge, then they conducted some surveys among pediatricians to find out why developmental milestone is not being done routinely in a pediatric office. So what did the pediatricians have to say? I'm sure in the audience, pediatricians would definitely agree to this. First they say is, no time. அது ஒரு பெரிய போய். No time is definitely a big lie. Anybody says I have no time, you have to tell them, you have to understand that that is not a priority. No time அப்படிங்கிறது is not true. It is not my priority அப்படிங்கிறது உண்மை. First one. Second thing they say is, I'm not confident because medical training or postgraduate training did not train me in identifying developmental red flags or conducting a developmental surveillance. That is something which young pediatricians said. And third, parental acceptance is poor. கண்டுபிடிச்சி நான் சொன்னாலும் I lose the client. They don't agree with what I point out in the clinics was the third concern that pediatricians raise. And fourth thing is, they're not sure how to guide the parents after identifying red flag. Because after they have said there is a red flag, then pediatricians are not sure how to guide them. These are four common challenges which pediatricians raised. Now, in the first part, what we're going to see is how to do a simple developmental surveillance in our pediatric office practice. For this, to identify red flags of autism, remember always to start an early intervention, a robust clinical diagnosis is often not necessary. So what we are going to focus is how to identify early social communication red flag. So ma'am, in her introduction, if you remember, ma'am talked about social communication, social interaction, and all those things that the child has to develop in early childhood. If you are able to pick up during routine developmental surveillance, that itself would be enough to institute early intervention before the child can receive a formal diagnosis. So how does social communication evolve? சடனாக ஒரு வயசில் ஒரு குழந்தைக்கு வந்து கடவுள் வந்து சுவிட்ச் தட்டி ஒரு குழந்தைக்கு பேச வைக்கிறது இல்லை இல்லையா? The child evolves social communication over the period of development. So what happens? Early infancy stage, the child starts connecting with people. The child takes active interest in the social environment around, and child develops an intent to communicate. That is the first development that happens in a child. So the first intent that the child shows that I'm happy to interact with people is through the warm, responsive, social smile that the child has with the caregivers. And by the end of around 6 months of age, 6 to 7 months of age, a child can display a range of emotions directed at others by the facial expression. So without even telling, we can say that the first child is very happy, one child is curious, one child is surprised, one child is disappointed. All those can be picked up by parents just by looking at the facial reaction of a child. So can you see when the mom is talking with the child displays a warm interaction. Warm interaction, the warmth is felt by the caregivers when interacting with the child. And what happens in the later half of infancy, the child starts having pro-social behaviors. So we all talk for reason. How did humans evolve language? Manushan படைக்கப்பட்ட போது when we were living as animals, when we were hunter-gatherers, we were only communicating through sounds. But once we started living as a social setting, once we started living as a group, then we needed some tool to communicate. Initially, they tried to communicate through gestures. Then they started drawing pictures to communicate. And then, sattathukku artham koduthu humans evolved language. That is how language came. So the key driver for communication in a child itself is the social intent. And autism is not a speech problem. Autism is a social communication difficulty. That is very vital for us to understand, because that will help us convince parents that this is not plain speech delay, this is social communication delay. And one aspect for us to understand is by 9 to 12 month toddlers, the later infants and early toddlers display a lot of pro-social behaviors which we have to pick up during routine clinical follow-up. First, the child starts understanding simple commands. He knows what, when mom says no, a crawling child will stop and immediately look back at mom. He understands that there is a label for him. When somebody calls him with a term, the child turns back and acknowledges the caller. That the child understands. Then child starts copying simple gestures. He means that this is something and people around me are happy when I copy it, and child does it again. So these are emerging pro-social behaviors, and child displays emerging improved language understanding. So in the 9-month vaccine visit, what are some simple developmental milestones that we can follow? Just wave and talk to the child. The child of this age should again be happy, should smile at you and should wave back at you, should at least attempt to wave back at you. And child will have very good warm interaction with the caregivers. See if the child is interacting well with the mom as the mother cuddles the child, all those. And the child should display some amount of stranger fear with you. When you try to approach the child is initially wary of you. That is what a typically developing 9-month-old infant would often display. And assess the name call response if possible during the interaction that you have. There's a few things that will help you in the routine clinical OPD. See here, when the mother is playing with the child, when an opportunity is there, observe the child interact with the mother. A very warm interaction you should be able to pick up. And when you interact with the child by saying hi, once the child is comfortable, the child will again smile at you and show a warm interaction. And sometimes the child may be very wary as well. Some children may be quite anxious initially, but they warm up over time. Then, response to name call. By 9 months of age, the child should have very good prompt response to name call. What is prompt response to name call? When somebody calls by name, the child gets alerted and immediately turns back and look. This is a video from the website called pathways.org. Pathways.org is a very good website. It has a repository of very good videos. I encourage pediatric postgraduate psychiatry trainees to go back and look at them if you're interested in child development. Remember, the interaction component is very important. The child turns back and looks at the caregiver here. And by 12 months, child develops an ability called joint attention. What is this joint attention? When I want something, I can direct the person's attention towards that by pointing or looking at it. That is joint attention. And when somebody points at something, they are referencing to something, I have to turn back and look at them so that I'll understand what they're trying to convey to me. This is a very key social milestone. This is a very key social communication milestone because it helps further development of communication. By 12 months, a child can very clearly be able to point at some things and direct other person's attention. Now, the child has multiple wants. By 6 months, 9 months, he has understood who are all familiar people and they can be a source of help. By 1 year, if the child wants something, he need not take all the effort to reach out to them and pull them to what he wants. He just has to draw their attention and show them what they want. Remember, the finger will be directed towards the object, the gaze will be directed to the person. That is something, again, we'll have to ask the parent. When he is pointing to something, is he referencing to you? Does he direct your attention towards that? That is something we have to ask parent. A 12-month to 15-month-old toddler will be able to communicate most of his needs at least by beckoning people and directing their attention to that. And this milestone is called joint attention. By 1 to 1.5 years, the child now wants to communicate actively to people. Pro-social behaviors, if they had been good, by now he'll be able to communicate for his needs verbally. The child will be having a very good eye contact with people. He'll be able to get attention of people. For wants, for needs, he knows he can reach out to people. Now he starts using kinship terms. What are the first words that the child should use? To direct attention of people, he needs label of others. The child will start using Amma, Appa, Tata, whoever is around, child will call them and I want that. And the poruloda pero, alungloda pero, child will start calling. So child will be using kinship words purposively. Saying words and using them for communication are completely different. 8-9-month-old child can repeat whatever words the child hears. The child may be parroting out. The child may be just saying those words. The child may be labeling people just by looking at them. But what we are interested in, when we ask developmental milestone, நம்ம என்ன கேட்போம், அம்மா அப்பா சொல்றானா? And many parents say, 8-9 மாசத்துல நிறைய சொல்லிட்டு இருந்தான். அழுகும்போது அம்மான்னு சொல்லி அழுதான். All those aren't counted as social communication. Rather, what we should be specifically asking parents is, அம்மா அப்பான்ற உறவுமுறை வார்த்தை கொண்டு உங்களை அழைக்கிறானா? நீங்கள் திரும்பி பார்க்கறதுக்காக கூப்பிட்றானா? That is something we have to ask. Because many children with autism may say rote-learned words, but they may rarely use these terms for a purpose, with a communication intent. So this is something which we have to differentiate and ask parents, because many parents say, ஒரு வயசுலலாம் சில வேர்ட்ஸ் சொல்லிட்டு இருந்தான், 2 வயசுல அவன் சொல்றதை நிறுத்திட்டான். They count it as language regression. Of course, some words the child may stop speaking, but never a child who had social intent, who was calling people using these kinship terms. Rarely that child starts using those terms. So what we have to ask people is, does your child use kinship terms to make you look at him, and does he direct your attention by pointing to that object and look at you? That is something we'll have to ask between 1 to 1.5 years of age. Elaborate gestures, motor imitation, all those also emerge. And now, by 1.5 years of age, child develops one more reason to communicate. So far, the child is communicating largely for needs. Now, child would want to share interests. So, child would like to share many things that he sees with Amma Appa. Childக்கு அம்மா அப்பாவுக்கு அதை காமிக்கணுன்ற ஆசை இருக்கும். தான் ரசிக்கிற ஒரு விஷயத்தை அம்மா அப்பா கூட ரசிக்கணுன்ற ஒரு விருப்பம் child one. He wants to share whatever he enjoys with his caregiver. So, mom would have taught him ball. When the child is going through books, if he identifies ball, immediately what will the child will do? Call mother and show that object to the mother. Again, the finger will be directed at the picture, the gaze will be directed at the mother. So child will be actively communicating to share interest. So one more reason to communicate comes, and that results in expansion of language. Amma, ball. Amma, ba, like that. The child will say, and gradually language will progress. So picture book, giving a picture book to a child of this age, child will constantly be beckoning mother and show whatever he knows to the mother. He likes to share interest. So in the 1.5 year or the 18-month vaccine visit, what are some social communication milestone which we can ask? Again, name call response should be prompt by this age. Child, if you wave bye-bye to the child will again respond back to you. If you give a picture book to the child will be pointing at something and showing to the mother. You can see if the child is able to share his interest. And when you point to to a particular object in distance, child will be looking back at it. You can check joint attention. And how do you check interaction for a child of this age group? Always have a toy puppet. Always have a toy which has a key in your clinic. When the toy stops running, immediately the child has to take and seek help from you or the caregiver. So these are some simple ways to find out if the child has a communication intent in the OPD. So some of the pictures here, when you wave bye-bye, the child will respond back to you by smiling. At least the child should be shy. He should look at you, smile and turn back to the parent. And doctor pointing at something in the distance, child will immediately turn back and look. By this age, even with your gaze, the child should turn back. நம்ம எல்லாம் இருக்கோம், யாரோ உள்ள வராங்க, நம்மளாம் டக்குன்னு திரும்பி பார்த்தாலே child should turn back and see. But at least when you point, you should understand that you are referring to something, you should turn back and look. Then, pointing to body parts, he understands language better. He'll be able to point at least to 3 face body parts by 1.5 years of age. Hand puppet is a very good toy which you can use for a 1.5-year-old child to check interaction, to check eye contact. The child should constantly refer between you and the toy. It's not only looking at the toy. When you try to talk something, go near him, he'll look at you, look at the toy, look at the caregiver. Constantly he'll be referencing to people around. Child of this age will actively engage the people around him in play. And a wind-up toy. When you give a toy with a key, if it stops running, the child should take and at least try to seek out help. Ooh, like that the child will be able to give and say, can you do it again for me? And picture book, when the child identifies something familiar, he should turn back at the mother and say, look, I found something interesting. And this we already saw. Saying words and using them for communication is not the same. When the child is able to randomly say some words, even rhyme phrases, children may understand and children may just memorize rhyme phrases and may keep saying it. All those are not counted as social communication. Rather, what is a reassuring thing? What is functional speech? Using words to communicate, calling people to get their attention, asking for needs. Any word or any communicative efforts used for these things are counted as functional communication. So what questions to ask in OPD? Does your child call out to you using kinship terms to get attention? That is something we'll have to ask. We have to reframe our developmental milestone question. Does the child ask for his need? எது தேவையோ அவன் வந்து ரெண்டு வார்த்தை வச்சு அவன் சொல்றானா? It can even be pseudo words. அம்மா பிச்சி, அம்மா லாலா. Mother and child only can understand. But it can still be a communication intent. Does the child share interest? When he sees something interesting, does he call out to you and show, Amma, bus, like that? Again, the child will not be looking at the bus. Many children with social communication difficulty, when they go outside, they may say, bus, car, train, aeroplane. They may be identifying all those, but never would they turn to look back at the caregiver to see if they are also seeing what they are seeing. Again, you have to ask the caregiver, does your child show and look at you also to see if you are also seeing with him? And until this, if the pro-social behaviors have progressed well, the child's language progresses further. More needs start coming. If the child wants to ask questions, he can use question forms. If the child wants to answer some question, he may start giving detail, and gradually the language progresses. So language is closely intertwined with social development. And common etiologies for speech delay that we see in OPD are, one, we have to think of autism spectrum disorder. It could be a social communication delay due to a suboptimal environment. It could be a part of global development delay, or it could be a child with hearing impairment. Now in clinic, we have to differentiate these causes. What are 4 trigger questions that you can ask to identify some of these causes? Especially our idea is to screen a child with red flags for autism. First question is there a language delay? You use a developmental milestone checklist to find out if the language is appropriate for age or not. So first question is, language delay is there or not? If the answer is yes, go to the next question. Is there delay in other domains? If there is a motor delay as well, then it's a part of global development delay. But if motor development is okay, it is isolated language delay. Then go to question number 3. Question number 3 is there any indication of hearing loss? How do you identify hearing loss? Child does not respond to name call. Child does not react to ambient sounds. And any communicative efforts that are out of his vision, my child does not seem to respond. But if I am in his visual sphere, my child is able to respond to me. Children with hearing loss are very visually alert. So they may be constantly looking at people to see if they are making any communicative effort. Children with hearing loss still have very good communication intent. They make elaborate mimes. They make elaborate gestures by around 2 years of age. A 2-year-old child with hearing loss, when he wants water, if his pro-social behaviors are good, he'll go call mother and he may ask like this. The child may be able to direct his communicative efforts specifically and with purpose to the person. I want to communicate to you, I want to communicate to you this. The message is loud and clear, the message is directed at person. Whereas a child with autism, even people within his visual sphere, he may not be responding to them. So the fourth question is, how is the child's pro-social behavior? So the child's name call response is poor and pro-social behaviors also are delayed, and definitely that child warrants further evaluation for autism. What are some pro-social behaviors that we can quickly see? Eye contact, joint attention, sharing of interest with people. So simple in OPD, what all we should need? We need to have a toy corner, or we need to have some set of toys by which we can assess these pro-social behaviors in OPD. That is what we need to do as pediatrician. What are some things we can have? Some options are given here. One is an exciting toy trick, something that pops up. Second thing is a bubble routine or a wind-up toy or a hand puppet. Any of these things you have to engage the child and see if the child is engaging with you. Remember, all these have to be done in a well child. And when you have concerns that this child may have social communication need, then you screen further for autism. MChat is the most studied, easily, freely available tool you can use. But if you still say, I don't have time for an MChat, what you can do? There is something called as a 3-item direct observation screen. Just doing 3 things. 1, call the name of the child. Is the child responding to a name call? Point to an object at distance. Is the child responding to you? And how good is the quality of eye contact or the face regard during interaction? These are 3 things that you can use in your clinic to quickly screen for ASD. Another popular misconception is any hyperactive toddler, any toddler who seems overactive in your OPD, if he has speech delay, somehow clinicians give a label of ADHD, and somehow parents are happy to receive a label of ADHD than autism. This is again very common among society. The core clinical message that we want you to remember is social interaction, if it is good, then it is likely a dysregulated toddler. But if the child shows a lot of overactivity without being connected with people, it is likely to be autism rather than ADHD. So what you have to look for again is social interaction. Is the child engaging others? ADHD is a diagnosis which is often given in the school-going age group. The DSM-5 criteria mandates that the overactivity should be present in multiple settings. So you can't give a toddler a clinical diagnosis of ADHD until you have ruled out other similar condition. So a toddler with speech delay who seems overactive with poor social interaction is likely to be autism rather than ADHD. That is something which you have to remember. So the first challenge what we saw was no time, not confident. What is the solution for it? Simple developmental surveillance. Vaccine visit associated developmental screening. 9 months, 18 months, 24 to 13 month vaccine visit. There should be a well child visits with quick developmental screening. And focused questions and simple play with the child can help you identify delayed pro-social behavior. And 4 trigger questions when you ask in a child with speech delay, you will be able to identify children with likely risk for autism. The second challenge we saw was parental acceptance. How do we overcome this? First, parents have to understand what is typical development sequence. So we will be able to overcome this problem only when we make parents aware of common developmental milestone and common red flag. So clinic should have enough information and education and counseling material with respect to red flags and pro-social behavior. RBSK has come out with a very good booklet, Development from Birth. Even this covers a lot of antenatal period also. There is a section in this RBSK booklet called Milestone Moments. It's very good. They also have an app called Palan 1000 app. Palan 1000 app is an Android, Apple, it's there on the Apple store as well. It's very easy for parents to access, and it gives timely reminders to the parent. How to stimulate the child at this age? What are some red flags you have to identify? And CDC also gives a very good milestone checklist. What your child should be doing at this age, where you should be thinking about red flag. And as I already mentioned, pathways.org is an excellent repository where videos are available for parents to watch and understand. And challenge 3, many pediatricians feel they are not able to explain the concern to parent. How do we do that? It is imperative that we communicate red flags to parent, but what is more important is the language. We are so often used to using the term normal and abnormal. And this word carries a lot of emotional baggage. What we have to counsel is in such a way that we don't make the parents guilty. Telling that screen time, நிறைய டிவி காமிச்சதுனால தான் உங்க குழந்தை இப்படி ஆயிட்டாங்க. Parents carry a lifelong guilt when they go out with this. So rather than using the term abnormal development, what we can say is your child has certain needs in the social communication domain. Label does not matter. You start intervention. side by side, we'll start evaluation of child so that if the child needs help, he can be helped early. The message should be offer a clear way forward saying early intervention is key for your child, and that is the best help you can give. Some of the parents will ask what next to do. Simple advice is stop all unaccompanied passive screen viewing. There are very good parent training modules that you can advise to them. One is Help is in Your Hands. Help is in Your Hands.org is a website where there are a lot of video modules which parents can access and start helping the child at home until they await evaluation. Then WHO Caregiver module, Caregiver Skills Training Program, e-modules are available on WHO Academy. There are 15 modules available here which the parents can access and start going. It works on all the pivotal pro-social behaviors or pivotal skills that the parents can watch and start doing at home. So take home messages, what are the challenges we saw? No time. Solution is simple, quick surveillance that identify red flags. You need not make a clinical diagnosis. You have to identify red flags and start early intervention. Second, parental acceptance is poor. Do not agree when we point to red flag. What do? Practice effective communication. Information education materials to make parents aware. When they come out with red flags, they accept better. Third, I'm not confident doing all this. Only solution is practice. So thank you for the opportunity and patience.
You all know what a wonderful speaker Dr. Srinivas Ravan is. I'm going to quote you hereafter to my patients. Satyatukku artham. Now I have learned from you today. Satyatukku artham. We are running short of time. So I now call upon Dr. P.P. Kannan, my student, my assistant, now is a professor. Me and him have worked together for years in this field, and he has brought out a book, detailed guidelines about how to diagnose, what should be done, what are the challenges faced, not only meant for doctors, for occupational therapists, special educators, and speech therapists. I don't know whether he has brought that book today or not. If you have one, please give it to Rama also. Yes, sir. Okay. Now I call upon him to talk about the behavioral issues in autism. You all know this is the most important thing because majority of the parents are bothered about the behavioral issues. You have diagnosed, you have helped them, but the behavioral issues are something very, very difficult to manage and changes over a period of time.
Good afternoon, everybody. At the outset, I thank the Center of Excellence for Autism for providing me this opportunity. I should express my gratitude by saying that without Madam, I would not have learned anything in child psychiatry. That is the truth. Because I was less inclined toward child mental health and other things during my MD post-graduation, but once I got posted in ICH, I worked with Madam for more than 6 years. Then I learned probably all these things. That is some recognition from other people as I'm involved with child psychiatry is because of Madam only. I had written a few books meant for parents and therapists. Whatever we know, whatever we learned, just I translated into Tamil and I had written those books. Probably doctors, we can get any material from any sources. We have that technically equipped by attending a lot of conferences, whereas the parents and therapists are not having access to that. Okay, with that, coming to the topic, behavioral issues in autism. I think this is most important because most of the time it is not the delay or anything, the behavior. There is some peculiarity in a child's behavior that draws everybody's attention. Some people get embarrassed, that is parents get embarrassed. but they get used to it after some time. But some people are very adamant about making the child very normal rather than accepting, adapting, and helping the child to cope with the environment. Yes, madam. Probably I will be comfortable. So, this is about to tell about autism spectrum disorder. We all know that it is about social communication deficit and repetitive stereotypic behavior. The point I would like to say is that the previous criteria, that is the impairment in language, that had been moved out of criteria. Only now we have only 2 criteria. And in spite of this being moved out, the prevalence got reduced with the newer diagnostic system. So, another important point is it is early onset and functional impairment. If any behavior or any activity not leading to any impairment, then the purpose of diagnosis is not there. That is, you cannot make a diagnosis in psychiatry. Distress and impairment are key points in psychiatry. So, we need to establish the impairment caused by that particular behavior. The previous 2 speakers had done a very good point. One had said there is no biological brain for autism. Yes, that is a very fantastic point. We should not look at things in a reductionist manner. Second pediatrician had nicely pointed out that we have to identify red flag sign. We should not wait for diagnosis. We start helping the child by means of intervention or more interacting with the child. So, with these basic fundamentals, I repeat and I go to the point. This is one thing which we need to remind ourselves, that some amount of children exit there or lose their diagnosis. This we need to keep in mind. This because helps us. This encourages us to work with the children. And about 40% of children are having comorbid intellectual disability, and this interferes with our intervention, behavioral intervention or psychological intervention. Definitely this interferes. We frequently mention this as developmental level of the child. And another thing, the language impairment is so common among the children with autism, that is about 63 to 75% of children are having that. And as per WHO, the prevalence is 0.76, but the stricter norms used in DSM-5-TR, in which the prevalence is 1.68 as per Center for Disease Control. So there are a lot of variations. What about India? We do not have this better statistics. Probably with evolving systems, evolving institutions, we'll be able to achieve all these statistics. So coming to behavioral issues in autism, the behavioral problems are so common. Only this behavioral issues makes the parent to reach for help with a pediatrician or a psychiatrist or psychologist or other therapist. So there are a lot of variations. The behaviors are influenced by communication, sensory processing, and environment, developmental level. So the developmental level, as I mentioned, it is connected with the intellectual processing ability. And the challenging behavior, not all the behaviors are brought to the visibility of the doctor. Only the challenging behaviors are frequently noted and brought to the attention of doctors. Why? Because there is a issue called safety involved, and the learning of the child is affected, and the family functioning, social participations are not parallel to the peer group. So they are concerned and bring the child. And ultimately, the quality of life is impaired in children with autism. So, as I told, what constitutes the behavioral issues? Not all the behaviors. I told you, we also go through some anxiety, we get anger. We also sometimes we would have thrown some items when our demands are not met with our parents or even with our children. Some young parents are there. So these are all normal. Just because somebody had broken the toy or a utensil, then how many of us? We would have beaten our siblings, right? So what makes the behavioral issues to be addressed? So we can again group them into 3 categories. The behavioral issues may be part of that core ASD symptoms, that is extreme repetitive behavior, which may be a part of self-injurious behavior, or the associated behavioral difficulties, that is child is taken to a new environment where the anxiety may be overwhelming and the child may start behaving something differently. Emotional dysregulation, child asks for something and the parents refuse to say, you are manipulating, you are demanding. There are a few parents who just blatantly accuse the child of doing something. So in that case, the behavioral issues start arising. So the anxiety, I told you. So the sleep problem, feeding problem, yes, this can happen with normal people also. We need to address that, whether a child had any issues at a classroom or playground, all these need to be encountered into. The challenging behaviors, which we are going to address in this session, is about aggression, self-injury, severe tantrums, and property destruction. And it is not a one discrete episode, need to happen repeatedly, and it repeatedly draws the attention of everybody. And we have to understand the child's behavior at a much deeper layer, rather than just looking at the child as though it is manipulating or trying to draw attention, or a child is throwing tantrums. So it may be due to less sensory regulation, or it may be about concern about autonomy and control, or it may be due to excessive attachment with a caretaker, or there may be other issues also. So simply looking at the behavior and trying to label it is not a good idea. So the behavior results from interaction between the person and the environment. This is what we need to understand. Behaviors are not the expression of the child on its own. It's an interaction between the internal environment, or it can be that is a physical or medical state, or external environment. See, the person's reaction to the environment may be modified by these neurodevelopmental characteristics, communication ability, cognitive or developmental level, emotional regulation, or sensory profile. These are all variations with everybody, but in children with autism or adult with autism, there are extreme variations. The first speaker said about there are a few genes involved. In fact, there are about 16 genes had been mapped, but there are about 700 variations had been noted. So we cannot point out this biological reason, but we can say that this has biological underpinnings, which cannot be ignored as we are addressing the behavior through behavioral interventions. So the environment, demands, people, noise, crowding, transitions, predictability, all these need to be noted. And our medical state. See, every time when child cries, we have to first look at the child. Usually we all do, especially mothers do it more. And even though you give reassurance, mother will move to another pediatrician and demand that child is having something. So we should not miss this. This is very important, paramount. The common challenging behaviors we come across are the aggression, self-injury, the meltdown, that is crying for no reasons, continuously happening, and the property destruction, severe non-compliance, disruptive behavior, feeding behavior. And all these, that is disrupting the family functioning, or there is a serious risk of injury to self or others, and there is a serious risk of impairment in academic functioning or social functioning. That is called challenging behaviors. This is not a simple deviant behavior. So what makes the behavior challenging? So as I told you, I just told you, that is serious risk of injuries, interferes with education, participation in daily activities, significant distress, restricts in community participation, and creates substantial caregiver burden. This is also to be noted. When caregiver burden is something different, that is a different topic. We can easily read out slides, we can easily say something about behavioral interventions. The caregiver burden is something different. In fact, first topic should be addressing to caregiver burden, because we have to take care of caregivers, then only we have to move to the child. So, recurs in some child with the behavioral issues in need of in need of intense supervision. So, it also reduces quality of life. So, the behaviors need to be understood with this antecedent behavior consequences. We all know, most of us know that every behavior need to be described. Then we have to understand the context and what is the trigger and what happens after the behavior. All this need to be understood. So, this the motivation operation, antecedent, challenging behavior consequences need to be identified, need to be described, and we have to prepare a plan. We say it formulating a plan. Then you just try to maneuver the scenario in the antecedent or behavior or consequences. You call it strategy. So, if you focus on the antecedent, if child is playing a YouTube and the mother says, no, it's now study time, or you come and have dinner, child immediately may throw tantrums. You just understand that watching YouTube, when it had taken the YouTube, how much hours it is watching, what is the content, what makes the child gets involved with that YouTube, how other family members are interacting. And when the warning sign was given, that is, you are exceeding the time permitted, how the child reacts. When you are saying how the other parent is reacting to it, or how the other siblings are doing it, everything to be noted. I just mentioned some 10 points, but if we sit and analyze, there may be some 50 points, 100 factors may be operating. All these need to be attended to, and we have to work on it. This is a simple outlay about a functional behavior analysis, but this is a special program. It goes for 1 to 2 days. But I'm just giving you the orientation about how we have to plan behavioral interventions. Yes, as I told you, we have to consider the antecedent behavior and the consequences. We have to analyze each component. And the common functions, usually the antecedent can be grouped into 5 groups. That is, child may try to escape or avoid a particular situation, or it may be demanding for something, looking for access to a smart mobile. This is very common in all households, right? Attention or social interaction may be the reason. Sensory or autonomic, that is overwhelming anxiety or emotional dysregulation may be there. The communication, child, I told you, there are about 65 to 75% of children have a language impairment. So, when that is happening, child may be having difficulty in communicating with the caretakers or the external world. So, it may be communicating by crying or rolling over the floor or jumping or flapping fingers. We consider it as a repetitive behavior, but the beginning of the repetitive behavior may be connected with something. So, this repetitive behavior may be communicating something. So, we need to focus on that. So, behavior is a communication. This is what I told you. So, the child hits when asked to sit in a class, screams and when a preferred activity ends, that is watching YouTube. That is a very common nowadays. Whenever you snatch a mobile, child will go for tantrum. This every mother is experiencing this. Bites himself when experiencing discomfort, runs away when entering a noisy environment. Rather than instructing the child, you please stop. You just what this child is trying to communicate with us. Usually how we react, you shut up, you stop, don't do this. Rather than saying that, there may be a prompt which may be used to control a behavior. But rather than a blatant advice, we can focus our attention to what made this child to behave like this. So there may be a possible message. Help me, stop, I don't understand, I want this, I don't want this, it hurts, or this too overwhelming. So the ABC model, antecedent behavior consequences, most of the time when the demand is more, child is having discomfort. When you ask the child to read or stop the mobile, or you want to take the child out, child would avoid. It would be expressed as a challenging behavior. If it is a simple, we all mothers know they are persuasive. Some mothers are extremely persuasive. Some mothers are more than that. There is no word to say more than persuasive. What is the word there? Some people scold, some people even reprimand, some people may even give corporal punishment. Even though we consider that corporal punishment is to be avoided, banned, but we continue. We should stop. I'm just mentioning what is happening in society. So, the functional behavior assessment, we have to focus on 5 steps involved. This ABC model is expanded here. See, there are a lot of variations. It is all about the problem behavior to be described rather than saying he is aggressive. See, whenever in my clinical experience, when I talk to the mother, என்னம்மா பண்ணுறான் சார் அடிக்கிறான் சார் என்ன அடிக்கிறான் எந்த சூழ்நிலை அடிக்கிறாங்க சார் அடிக்கிறான் சார் ஏதாவது பண்ணி நிறுத்துங்க சார். They will not be able to provide more information, especially when they are from rural area, less educated background. They have less time to care the child. They bring up with simple complaints. As you try to take the mother to the points where they can do some intervention, it is very difficult to communicate to the mother. But still, we have to get exhausted as we do this. We cannot go for pills. Pills are for extraordinary circumstances. So we need to focus on how to convince the mother, or you talk to the other caretakers in the family. So ask them to describe. So for example, he hits another person with an open hand approximately 3 to 5 times when asked to transition from one task to another task. Or we can add more points, timing, when it happened, how others are reacting, in which circumstances this is happening, all this to be described. Even in my training to PGs, I will ask PGs to write about 40 sentences if somebody says something. So they should become a novelist, like, so that we can have some idea about the particular behavior. It's not a simple behavior. The context need to be brought in. So step 2, the antecedent, consequences, frequency, duration, intensity, everything. As you go for describing the behavior in the context, everything falls in line. So look for the patterns and the formulate. This is very important. As a therapist or a clinician, we need to develop our own idea of how to move forward. That is formulation. Then design an intervention based on the function. These are all steps involved in functional behavior analysis. Always rule out the medical cause. As I told you, when child cries, you always be alert. When the behavior is very sudden, you always think about medical cause in that. For example, it may be due to pain, dental problem, constipation, or GI related problem, or epilepsy, sleep disturbance, headache, or it may be due to side effect of medicines too. So the sensory and the environmental triggers need to be identified. We are all frequently talking about sensory stimulation. How many of us concerned about sensory overstimulation? So these are all some catchword nowadays in therapies, but we need to be focused on how much stimulation to be done, whether it is even some children, madam frequently says this during her classes, the noisy environment, the child with autism will not bother about it. When you do something like scratching sound, some unusual feeble sound, child may react differently. Why this child reacts differently to this feeble noise, whereas it is showing indifferent attitude for such a big noise? Even you throw a bowl or there is a cooker blast, the child will not show any reaction to it. But when you say some scratch like this, child may react differently. So we have to understand that why this sensation may be connected with some tactile stimulation, which might have got overwhelmed, child may be reacting differently. This need to be identified. So it is all about describing and understanding the behavior in that context. So coming to the difficulties and challenging behavior. So as I told you, the behavior is, probably you can, the participants can get the slides. You need not take photos. Everything would be sent to you. So the books also in open access. So you can take, just you can come up with the questions. That is more important. The deliberations are more important. So as I told you, any behavior considered to be interaction between the individual and the environment. The behavior is a kind of communication. I told you the child with ASD are having language impairment and impairment in social communication. So they communicated differently. The behaviors are the tool, they communicated differently. So the behaviors need to be interpreted and understood in the right perspective, rather than as a problem behavior or deviant behavior. So the child may be asking for help expressing pain, understanding emotional state. So the helpful strategy should be this, helping the child to learn that simple language, one instruction at a time, giving visual schedules, first then approach. That is, you do this, you get this. The good example for this is when a child returns from school, what do? They throw away the chappals, throw away the bag, go and sit, take the mobile, watch YouTube. If you say that you just remove the chappal, keep it in place, keep the bag in place, change the dress, have a face wash, then take some snacks, then watch mobile for half an hour. First this, then this. First, then approach. These are all connected with the parenting. So without this, simply advising the child would not help. Some perseverance is required on the part of parents, and there should be great consistency required. In fact, mother says no, the father says yes. So these sort of things need to be addressed. Then only we can do a better behavioral intervention. The choice making, this helps the child to reduce its autonomy, reduce its anxiety and have a better control over the autonomy. Because we should not make the decision for the child all the time. You just follow the developmental trajectory. You just allow the child to have its space appropriate to the, time up. I'm just finishing it, madam. So aggressive autism, this is the frequent reason why they are coming. Yes, madam. Yes, yes. So the aggression in autism is the main reason why they bring the child to the clinicians. The hitting, kicking, biting, pushing. So what you do, as I told you, describe what, when, where, towards whom, and you do the ABC analysis. And consider the communication difficulty, escape from the demand, access to the preferred item, sensory overload, pain, anxiety, sleep deprivation, and psychiatric comorbidity. This is more frequent in ASD children. The psychosis can happen, or OCD may be there, anxiety, panic attacks, everything are more prevalent in children with autism. Autism is a variation in normal development. It's a one expression in neurobiodiversity. And the problems, what we see in general populations are more common with ASD. So that need to be considered. For self-injurious behavior, we have to prioritize safety. Then you just consider the medical causes, sensory factors, communication, and environmental triggers. And de-escalation in crisis management is very important. De-escalation is about don't provide the triggers. Keep the environment silent. Look at what child requires. Try to address that. Ensure safety. This is very paramount in de-escalation and crisis management. You ensure that the child is not get hit or others are not get hit. Sometimes, rarely, child may express some impulsive behaviors. We need to be aware of that. And reduce the verbal communication and remove unnecessary demands, maintain appropriate physical distance, protect others and the individual, and allow recovery. Sometimes when you do nothing, just observe the child at a safe distance, and the emotion and the aggression spontaneously settles down. Rather than you talk to the child and provide more triggers for escalation, just better, we need to be calm at that time or provide minimum communication. So, antecedent-based strategies, skill building and reinforcement need to be there in our strategies. The differential reinforcement, where we should not look at positive reinforcement as black and white. There's a grading. You provide that positive reinforcement according to the need of the child, according to the context in which a child is doing that. That is called differentiated reinforcement. So, the medications are reserved for rare occasions. We should not trust to give you prescriptions, and you can always discuss with the doctor whether it is necessary, whether we have other options, whether any behavioral. People usually avoid, in my experience, people avoid medicines. but they are poor listeners. They have a difficulty in understanding the behavioral strategies we say. So these are all complicating the issues. Then what a clinician would do, he will go with medicine and behavioral intervention. What happens later? The medicines become continuous process. They come, meet doctor, get prescription and go. And this should not be the way the child need to be given a treatment. Medicines to be reserved for the rare occasion. And medical treatment, as I told you, the medicines to be started at a low dose should be titrated up slowly, and you do regular follow-up. Just if possible, you can stop it after some period of time. The challenging behavior, this is the flow chart. That is, first safety is very important. Do get involved in crisis management, rule out the medical causes, define the behavior. Rather than define, describe the behavior. That would be more appropriate. And ABC assessment. Identify the probable function. What might have caused this? Modify the antecedent environment. And the alternate communication behavior need to be taught. I told you, the behavior is a way of communicating with the environment. You just help the child to get another behavior, alternate behavior. Where there are a lot of...
Sorry to interrupt, sir. The
yes,
time,
madam.
sir.
Yes, madam. So this is a last slide. So we have to come up with an alternate way of communicating with the world. That is the learning principles are involved. Even though this slide is so simple, appear to be simple, but dealing with a child is a great challenging job, especially when we deal with the challenging behavior. So finally, you measure the outcome. This is very important. This is not about doing intervention. Whether our intervention worked or not, that need to be measured. And the key points are the communication difficulties to be addressed, which is the most frequent reason for the problem behavior. And modify the environment before modifying the child. These are all very important. I thought of discussing few cases. As we are running out of time, I couldn't do it. And thank you for patient listening.
Thank you, Dr. Kannan. Before we break for tea,
Thank you very much, PPK.
let's take a moment to thank our speakers.
Thank you very much, PPK. This is one of the very difficult topics. It cannot be discussed within a short period, but he has done his best. Since we are running out of time, we'll move on.
Thank you, Dr. Jayanthini. Before we break for tea, let's take a moment to thank our speakers. I invite Dr. Rema Chandramohan to felicitate our chairperson, Dr. Jayanthini. And I also invite Dr. Jayanthini to felicitate our three speakers of the session. Dr. Subramanian, Dr. Srinivasa Raghavan, and Dr. P.P. Kannan. We'll now take a 10-minute short break. Refreshments are served just outside the hall.
10-minute break, please. Be back in 10 minutes.
Please be back in your seats within 10 minutes, please.
அரசே உங்களோட இருக்கு. ஆட்டிசம் நிலை குழந்தைகளை பாதுகாப்பாக வளர்க்கிறது உங்களுடைய பொறுப்பு மட்டும் இல்லை, நம்ம எல்லாருடைய பொறுப்பும் தான்.
ஆட்டிசம் இருக்கிற குழந்தைகளுக்கு அதிக அரவணைப்பும் அக்கறையும் தேவை. அது இருந்தா அவங்களால எதையும் சாதிக்க முடியும்.
மறுக்க முடியாத உண்மை. அவர்கள் எப்பொழுதுமே வந்து
Kindly be seated. Kindly be seated. Thank you. It's now time for our keynote address. It is my great honor to invite Dr. Shobha Srinath, retired child psychiatrist, NIMHANS, to deliver the keynote address.
Shall we start? Yeah. Good morning, ladies and gentlemen. I want to start by thanking Dr. Rama and her team for inviting me today for this keynote address. It's always a pleasure to do a keynote address, but I see that my keynote address is preceded by 3 talks. So a lot of what I wanted to say has already been said. So what I shall do is I shall let go of those parts and spend time on the rest of the topics that I have. So all of us know many things, but practicing them in the clinic, am I audible at the back or is it echoing? It's okay. I've been trying out this new contraption for some time now because it allows me to do some walking. So practicing all that we know is tough because sometimes, for various reasons, we know what we have to do, but we can't do it. But I just thought I'll use this as a chance to recap and remind ourselves what needs to be done. So I dedicate this to all the children I have met over the years, to all the parents who have taught me a lot, to all my colleagues, because I believe that people who work with this population need to be of a particular kind of people. Not all people can work with children with neurodevelopmental disorders. So hats off to therapists and people who work to them on a day-to-day basis. Yeah? I always think that as a doctor, you can diagnose, you can do differential diagnosis, but who carries the load every day? It is the parents and therapists who have to bring about change. And that work is hard work. And I also think, I'll talk about a controversial bit, I think therapists are not paid enough. I think like primary school teachers need to be paid more than college teachers because they are dealing with children at a very, very advanced young age. But anyway, let's see how this will happen. In Finland, primary school teachers are paid more than other high school teachers. Yeah? Yeah. I also have no conflicts of interest. So, as a practicing clinician, all of us must be excellent history takers, very good listeners, observers, and diagnosticians. Because we are working in this field, we also need to have some scientific literature awareness. We must look through a neurodevelopmental lens. So lots of times doctors are not taught much on neurodevelopment. So they don't look at cases through a neurodevelopmental lens. The important point here is, I'm trying to use the pointer. Pointer doesn't work. Yeah, they told me it is a different kind of a pointer. Illa. Beda, parvagilla. Okay, so we have to have, when working in this area, we need to know about family systems. Am I standing in the way of the slides for you? Yeah. You must be trauma informed. You must know rights. You must know what the lived experience is. People who actually live that condition. You need to understand the parents and the young people. We need to understand our country's education system. And if you see one young child with ASD, you must think that ASD child is going to be an adolescent, adult, and a geriatric person. So across the lifespan, one will have to think of a person when you see a person with a developmental disorder. So when you're talking about the concept of developmental disorders, we know that in the DSM, all these are included under neurodevelopmental disorder, all these. Motor disorder or developmental coordination disorder is a disorder that is not diagnosed very often. DCD. Only occupation therapists know a lot about it because they find that there is quite a lot of incoordination in what they do. So a lot of children who have neurodevelopmental disorders have almost all of these things or many of these things. What is another condition which may be included under neurodevelopmental disorders other than this? What other condition do you think may be included? This is what DSM says. All these come under NDDs or neurodevelopmental disorders. What other condition do you think? Enuresis or bedwetting. Bedwetting is also considered as a neurodevelopmental disorder because it is a maturational effect. As the child matures, bladder control should come up, but sometimes it doesn't. Okay. Now, what is all this we know? Rationale for early intervention is something that we all know very well. But the reason I want to talk about it here is because when we talk to parents, you heard one of the speakers in the morning say that parents are difficult to convince. They'll go home and they'll say, enna kudutanga, marundu maatrai kudutangala, injection kudutangala, illa onnu illa nu sonnanga. Finished. They won't come back again. Marundu illa, maatrai illa, injection illa, operation illa. And what do we say? Appa ammakke no jaasti vela kottu kadiduvanga. They gave us more work and they sent us off. We went for help, they told us to do work. So there must be a way in which we are able to convince the parents. And I find that when I'm talking about this, it works. So what is the neurophysiological basis of neuronal plasticity? How do we explain neuronal plasticity to them? That is, you do training and your child's brain grows. They never thought that they had the power to make their child's brain grow. But how do we make them understand that their child's brain grows by training? So you'll have to give them an explanation which makes them understand. There are many anecdotes I give. One of them is, I have a fracture or my child has a fracture in this arm. It's a complicated fracture. For months they put plaster and keep it. This hand has been there like this for so long. The child works with this arm all the time. What happens to the muscles of this arm? What happens to the muscles of this arm? This arm becomes smaller, this arm becomes stronger. So the idea that if you don't use it, you lose it. You don't use something, you lose it. This arm got a lot of work, this developed. The same thing happens to your child's brain. The child, for some reason, is born not automatically getting that development, but now we are asking you to spend time training. So the cells that fire together, they will wire together. They'll become thicker, they'll become stronger, but that requires practice, practice, and practice. So if they get a feeling that they have a method of making their child's brain grow, there is some possibility. The second thing is the prevention of secondary handicaps. If you make them understand, for example, that if a child has spasticity for it, you don't do anything for the spasticity. What happens to that arm? Develop contractures. Then release of that's a big issue. So that is a secondary handicap. Spasticity was what happened first, but the contracture became a secondary handicap. What happens in children with neurodevelopmental disorders, say IDD or ASD? They are unable to communicate. All of us communicate in order to make changes in our world. If I can't communicate and make changes in my environment, I will use what? I will use my behavior to communicate. I will scream, shout, bite, scratch. When I communicate like that, people pay attention to me. So I manipulate my environment by the behavior that I have. And as we said, the more you use it, the stronger it becomes. So if I've started using behavior to communicate this kind of maladaptive behavior, then my behavior problem is big. That becomes a secondary handicap. Because I was frustrated, unable to communicate, I wanted to communicate, but I have a problem. If I'm neurodiverse, I have ASD, I have IDD, how will I communicate? So I use any method to communicate. So behavior problem then becomes a secondary handicap. So if we are able to understand, make parents understand this, then they will attempt to do early intervention because they know the end result of this is this. So there must be a way in which, in a short time that you have, you should be able to communicate what these parents need to do. Now, when I said developmental disorders, I mean that whole list, IDD, ASD, all that, ADHD. They all have some common characteristic. The first two is very well understood. I won't talk about it. The third one, autism spectrum disorder, is also on a continuum of mild, moderate, and severe, based on the kind of support they need. High support, not so high support, minimal support. IDD, we have mild, moderate, severe, and profound. For SLD, for ADHD, we don't have very clear cuts of mild, moderate, severe, and profound. We don't have clear charts which will say them. So it's hard for parents to understand. I might say ASD mild, but the mild might be communication. The social interactions might be severe. The stimming might be very much. So even along the continuum, you can get mild, moderate, and severe in each of those areas. So one diagnosis will not help me manage the child. I will have to describe the child. Developmental disorders tend to overlap. For example, all these things can happen. You can get ASD with that, this I won't say. You can have 2 or 3 diagnoses also. So what happens when young people do evaluations is that they get one diagnosis and they'll do premature closure. They won't look for the other diagnosis. So you have a child with ASD at cross-section. That's not enough. When the child comes for follow-up, longitudinally, you may find that an ASD child has SLD. So you You treat, say, for the child has ADHD. You treat ADHD. As the child is growing older, the child actually has SLD. The parent comes and tells you, not studying. You're giving medication, we are doing everything. But actually, in the course of evolution, the child developed SLD. That was not paid attention to because ASD was ASD alone. So follow-up means you also have to check for other diagnoses. So I want to say in nature, there is no clear areas. And this poem exemplifies this. Night becomes day and day becomes night in gradual shades of black and white. We humans wish that we could stop the time of light and call something black or white. Learn from the day and learn from the night that there is no true black or white. So actually, in our clinic, you will find that there are ADHD features, that there are ASD features, and that there are also SLD features. Somebody sees here and says ASD, SLD, ADHD. Parents thoroughly confused because in nature, it is all mixed. We have areas in the brain, but as we heard earlier in the morning in the first talk, there are no clear areas, and all areas are like this. One runs into the other. So with the result, we are unable to make clear-cut diagnosis which excludes everything else. So we are talking about developmental disorders tending to overlap, so you must watch out for that. They are likely to have multiple causes. There's no complete cure, but early detection and early intervention greatly improves the outcome. So a lot of people talk about it as a chronic illness model. That is, it's like diabetes or hypertension. You have to do, over time, you will have to do it. The other features are all these children with neurodevelopmental disorders, ADHD, everything, they have strengths, they have preferences, and they have sensory issues. How many of you here have sensory issues? Yeah? So, across the population, many of these traits run a Gaussian curve distribution. So, more sensory issues may be present in ASD. All of us may have less, but we do have. Take social communication. Do you think all of y'all are good social communicators? No. You plot yourselves and y'all will fall on a Gaussian curve distribution. If you're too much of this side, you're probably having some autistic kind of broad spectrum kind of features. Yeah, so how many of y'all have stimming, mild stimming? Yeah, when you're anxious, you do this. When you're this thing, you do this. All of us have different methods of soothing and calming ourselves. So a lot of these traits fall in general population. That's something parents find hard to understand. The next thing is, a lot of children with neurodevelopmental disorders have a family history of neuro. You don't ask family history straight away in the first sitting that they have. As you get to know the family, you will find that a lot of neurodevelopmental disorders, children have families who have some traits. They tend to run in families. Not always, and it shouldn't be made a big issue. And I have always found that I do not ask this history when both Appa and Amma are sitting together. Because how many Appa Ammas will share their developmental history with each other? They won't. Especially if you have a child with a neurodevelopmental disorder, you don't want to talk about it. But as a clinician, as an academician, you want to understand something, then you will want to understand whether there is any neurodevelopmental history or family history of this kind. A developmental disorder increases the risk of psychiatric disorder. A developmental disorder masks the presence of other psychiatric disorders. So, for example, okay. So I'll come to the other thing a little later. I want to make a point here that not enough time is spent on likes and assets of children. As medical students, we used to remember our cases by the diagnosis. Oh, you say, oh, that person with the hemangioma, we wouldn't remember the name, but we would, which is a very not nice way of working. So I have found that even for non-NDD or non-neurodiverse children, it is good to ask them about their likes or about their assets or about their strengths. So one of the questions that I will ask the mother or father beforehand, before I see the child, is, what is your child good at? What does he like? What does he do in his free time? And if I know what that is, then I will use that to ask the child almost the first question. Mummy told me that this, you like hockey? I'm saying hockey because I think too much importance is given for cricket. So I'm saying hockey. Yeah? So I will say, do you like hockey? Mummy said you like to play hockey. So the moment I say something that the child likes, then the child knows he's not equivalent to his illness or his disorder. And even children with autism, ADHD, or anybody will quickly understand that actually I thought mummy will only complain, but she told about this, not bad. Yeah? So we talk about something because we want to motivate the child. You look at yourselves. You all are happy to do some hard work because you know on Saturday or Sunday you're doing something nice. You're looking forward to that Saturday, Sunday. But you work very hard now and do it. How do our child with ASD or ADHD motivate themselves? They need to understand that something is going to happen. So there are high points in everybody's life, and we will have to use that to train them. So leisure time, pre-vocational, vocational activities must start early. I have seen many parents with ASD say, I'm not worried. He's now 11 years old, still 18 years old, the school will keep. After that, we will see. No. Once you know this is a life cycle approach to be taken, your pre-vocational must start at a very young age. They must know what the work ethic is, how to work, what is it to work. All right. Would you agree with this? All that I have said so far is not meant for neurodiverse children alone. It is meant for all children. Yeah? I think we don't do enough for our so-called typical children. I have found that autistic children are helping mummy at home, but the non-neurodiverse child is not doing anything at home. Now, how did this happen? That's because we somehow in our mind decided that this is to be so. Yeah. Parents and carers have a tough time understanding the concept of comorbidity and spectrum. And they have to be explained this many times. You mustn't feel upset that the parents haven't understood what you're saying. Depending on the therapist they go, sometimes they get different views. One therapist will tell them something, somebody else will tell them something. Parents get confused. So it's necessary for all therapists to understand. I've spoken about this. A point I'd like to make is non-speaking children should never be presumed to be intellectually incapable. Just because they can't speak. So if you have taught them to communicate in whichever means, including AAC, you will find that that so-called intelligence starts coming out. But just because they cannot talk, it's not that they are not intelligent. And functional impairment depends heavily on the environment fit and the support. And not all environments can support children with ASD and IDD, and so it's difficult. So I was talking about children who have ASD or children who have neurodevelopmental disorders being at greater risk for medical and psychiatric problems. So I want you to remember that all children with neurodevelopmental disorders must get medical evaluation done. They go to a special school, they go for training, but they don't go to a doctor or a dentist. And if they don't go to a doctor or a dentist, it is very hard for the parents when the child has a problem. So I believe that all neurodevelopmental disordered children must get regular medical and dental examination. They must have a regular doctor who they go to. And if they don't have a regular doctor, you must find out doctors who know about neurodevelopmental disorders, pediatricians, psychiatrists, dentists, and you must develop a network. All of you must develop a network of people whom you know who will look after these children of yours. And you must tell families, when was the last time you went for a medical examination? No, we haven't gone at all. We only go to the special school. No. So if all therapists are on the same page, then the parents will hear this from the OT, from the SLP, from the PT. So they will know that, everybody is talking about this, I better go. So they will have somebody. We know that children's mortality is higher when they have neurodevelopmental disorders. Suicide rates are quite high in children with ASD. Okay. We talk about neurodevelopment, but we don't talk about emotional development. And emotional development is an exceedingly important area. So as the brain develops, emotional regulation also develops. If the brain neurodevelopment doesn't occur adequately, emotional regulation also will not occur adequately. How will it occur? So they have more meltdowns, more temper tantrums, more anger, can't control themselves because their neurodevelopment also has not occurred. So they go hand in hand. Do you think children with neurodevelopment suffer more adversities, more trouble, more abuse, neglect? Yes, children with neurodevelopmental disorders suffer more neglect. They suffer more abuse. They are hit more often. They are sexually abused more often because they are vulnerable. So they are at risk for adversity. What does this naturally mean? That if a child has got adverse living conditions, how can the nervous system develop? The child is all the time frightened and troubled. How will learning occur? For learning to occur, the old brain, the limbic brain, or the brain which remembers a lot of this trauma, that must become calm. Then your forebrain, which is your thinking brain, has place to work. If the limbic brain and the old brain is always frightened, what will happen next? Who will beat me? Who will kick me? Where is the question of that upper brain learning anything? So you need to be aware that these children are at risk. This is a book that is very difficult to read. It's a big book, but you all can take areas that you would like to read. It's about Bessel van der Kolk is a very, very well-known person who works in trauma. So as a regular practice, all of us who work with children must be aware of adverse childhood experiences. They are called ACEs, ACES. Adverse childhood experiences are neglect, abuse, domestic violence, incarceration of parents, parents who have mental illness, substance abuse. When these kind of things happen at home, the child is facing adverse childhood experiences. These kind of children have difficulty in developing normally. They are at risk for developing mental issues. So linking emotional and neurodevelopmental trajectories is something that is mandatory. You will have to ask even our NDD children, who's child most attached to? Whom does the child miss? When the child is crying, whom does the child go to? You will find that the child likes the grandmother. This ASD child is attached to the grandmother. Grandmother dies. What happens to this child? So then learning goes, child is grieving, and ASD high support needs child grieving. What do we know how it will grieve? Stops eating food. They bring the child there. You haven't asked about caregiving, so you don't know the grandmother died. So there is a great need to understand attachment. Okay. So besides just making a diagnosis of ASD, the workup should have all this. And this is not just for ASD. This is for all NDDs. developmental history must be good, sensory profiling must be good, comorbidity screening must be good. So this is a complete evaluation if need be. So the clinician must be aware of interventions at different levels of evidence. Applied behavior analysis has the highest level of evidence. A lot of studies are there. Then there are a whole lot of other kind of treatments, and the naturalistic developmental behavioral intervention is a very commonly used model. Then you have speech language therapy, under which you also get ASC, occupational therapy, and CBTs. So these are at different levels. There are many structured interventions in India, also at different levels of evidence, also for different age groups. So you have all these, and there are inpatient programs also in places like CMC, Vellore, and NIMHANS, and many of you must be having your own programs. So, but they're all at different levels of evidence. And so you must be aware of what is that evidence and aware of what parts of it you all are using. We heard about pharmacotherapy, so I won't talk about it. Medications have got their uses, but there is no medication which deals with the core deficits. There is no medication. So all of them help in the rehabilitation process. So sometimes we need to convince families about why they need to give medication, maybe for a short duration of time. Small doses must be given, and then withdrawing, as the doctor said, once a medication is started, withdrawing is a big challenge. Most doctors won't want to withdraw. So forever and ever the child is on medication. So before you start, one has to be careful. It has also been found that as children grow older into adolescence and adulthood, more and more of them get psychotropic medication. As they are older and older, they are on more medication. Importantly, you have to avoid the use of medication to compensate for these kind of issues. That is, the psychosocial training is inadequate, we give medication. No. Parenting issues are a problem, we give medication. It can't be. So you cannot use them like that. A clinician also must know when not to over-medicalize what is normal neurodiversity. When I say normal neurodiversity, it's like an oxymoron. Normal neurodiversity, yeah? So, on the other hand, a clinician must not miss significant disability. I have found very often that a child is brought saying he's ASD, not doing well in school. Very bright, not doing well in school. But actually the child does no self-help skills. Doesn't wash his bottom, cannot look after himself. And you will find that nobody has told this parent about toilet training. The child is 17 years old, doing calculus at college level, but is not washing his bottom and not eating his food. Now, this is a significant disability, and who do you think is looking after it? That poor mother. The mother's already 45 years old. She goes with him to the toilet, washes him, and he's doing calculus in college. So clearly something is not right here. Yeah? So somebody didn't spend time checking on what are the issues that must be. Okay, I want to spend a little time on complementary and alternative medicine. Usually CAM is used for all these reasons. How many of you here use complementary and alternative medicine? Come on. I expect more hands. You all are not doing kashayam and home remedies at home for cough, cold and all that. Everything is that. So a lot of people use complementary and alternative medicine. You think they come and tell the doctor that they are doing that? No, they won't tell the doctor that they are doing that. So what are the types of CAM treatments? Natural products, mind and body practices, music, yoga, other biomedical treatments like stem cell therapy and all that. So these are all different types of CAM treatments. It has been found that many chronic illnesses, parents of many chronic illnesses and NDDs use CAM treatments. Routinely they use. And these are the kinds of CAM treatments they use. All kinds of things. So all of us who deal with these children must be aware of dangerous products that they should not be using, must be aware of what to tell parents. So there are places where you can get potentially dangerous ASD kind of treatments and therapies. Have a look. Now for all experimental treatments, I usually advise this, and all of us, physicians and therapists, must be aware because parents may ask you, or you may ask them. And so you must know something about CAM treatments. What I generally do is I will tell them that is experimental. I will tell them that the safety of many of these are not known. We do not know whether they are safe. Not enough research is done. Sometimes the cost is prohibitive. We know families who sell a piece of land in order to do a treatment which is of not much use. And they have jeopardized their future and their other children's future by doing such a thing. Find out who the practitioner is, how the advertisement was known, who used it. Have you met another family who has used the same treatment? Have you met that person? And many times I ask them to read all this. Like, for example, they tell me Ayurveda and homeopathy. Now, I am not a doctor of Ayurveda or homeopathy, but I ask them, who are they going to? Have they met others with whom? And they have, yes, then go to people who are knowledgeable. But if they say they have to sell a piece of land for some treatment, then I will say, no, you better be careful, better check it all over again. So other kinds of exclusive diets, casein-free, gluten-free, there are all kinds of experiments. For those, I tell them to conduct an experiment of one. Your child is the person on whom you're conducting the experiments. So you want to do temper tantrums, sleep, or whatever. Find out before you start what the problem is. Then for 3 to 6 months, give the treatment. Then find out how the temper tantrum, how the sleep is, how whatever it is. Then stop it. Then look again what happens. Did the old problems come back again? Or nothing happened? Nothing happened. So if it came back again, then you know that for your child, excluding milk is good. You're not advocating it for every autistic child, but you have done it for your child, and you know that when your child eats wheat or when your child drinks milk, the child has an issue. For your child, this exclusion diet works because you did an experiment. So it is necessary for you to give parents an idea and to be involved in their decision making up to a point. So there are many innovations for care. There are low-cost models, there are telehealth. All of you here can innovate, can think of having models of care that are slightly different from what is happening currently. The point I would like to make is that co-production with families and individuals with lived experience. If you're writing a project, if you're doing a project and planning something, then take a high-functioning autistic individual also and consult. Ask that person, say, we are planning like this. But sometimes high-functioning individuals will think about the way their life is. They may not be able to understand about all other autistic individuals, but there is no harm in talking to young people who have the experience, talking to parents and caregivers of autistic people or IDD people to talk about your research plan and to see if it makes sense to them. So include them. So this is one of the biggest gaps globally, that transition from adolescence to adulthood, what are all the issues that occur? That is something that not enough attention is paid. And I would expect that a center of excellence like the one you all are working in must take a lifetime approach, and you all do take a lifetime approach to look at all these possibilities. So we talking about puberty, sexuality, consent, all gender. Many of the autistic individuals have gender identity problems. Many of them have sexuality problems, masturbation problems. Many parents have great difficulty with IDD and children with ASD with masturbation. They don't know where to talk, whom to talk about it, and it causes significant trouble for adolescent people. Yeah, so this is an area of transition that everybody must pay attention to. Okay, so remember that self-help skills can be anyone's, it's not anyone's agenda. Doctors may not take, teachers may not take, therapists may not take a great deal of interest. Household skills and cooking can be taught. I have noticed that children with ASD, IDD like to cook because cooking follows a certain structure. You have to do this, to do Uppitu, you have to do this, this, and this. Once it's stuck in their head, they know how to do Uppitu. So many of them like to create something because it is so routine. And therefore, these kind of skills can be taught so that you normalize the child in your house. The child might be odd, unusual outside, but the child at home is normalized because the child follows a routine and does things for himself and the family, and therefore is a useful member of the family. Behavior modification is not overrated. All of us use behavior modification, knowingly, unknowingly. And if you know the principles of behavior modification, it can be well used. I've said families are very good therapists. The other thing that I find not enough time is given is parental and sibling needs. Not enough time is spent on caregiver needs and sibling needs. There is a great need for relatives and neighbors to be a part of the network. I think for typical children or non-neurodiverse children also, we must develop a net. And a nuclear family is not enough of a family. You need to have a neighbor, you need to have an aunt, uncle, everybody. But once a child is neurodiverse, the family actually shrinks. They won't take the child outside, they won't go outside, they won't be a part of a community. That all therapists and people, caretakers who work with children with NDD, you must advocate, you must say, necessary, when was the last time you went out? I knew a doctor who's an orthopedician who dealt with spastic children who would tell the parents, I want both of you to go for a movie. Next time you come, you must bring the movie ticket to show me. Why did he say that? He said it because he found that parents never got together. They were so busy looking after the child with a neurodevelopmental issue that they lost their own life. And so there's a great need for all of us to remember that caretakers have needs and caretakers suffer significantly. What after me is an annoying and a very deep concern. The what after me business must be started very early. And y'all must proactively start. The parent won't say, the child is an adolescent, you must start about sexual needs. The child is growing older, parents are growing older, you will have to raise the issue of what after me. They may not. It's a very busy slide, but this is how to schedule activities wisely. Sometimes I listen to children with ASD and IDD, and if I look at their timetable, I am tired. Just hearing their timetable, I am tired. The mother is driving them there, then she's coming back, then the father is taking the child there, then they're coming back. Child is eating in the car, sleeping in the car, going from one therapist to the other therapist. I mean, what kind of a life is this child leading? The child will burn out. Parent also will burn out. So there is a great need to plan. In between the busy day, there must be downtime. In fact, I advocate that you give the child some time for stimming. You say, this is your stimming time, go stim. Because it means that you have understood that the child needs some time to be by himself, to unwind. Don't all of us need some downtime? We close the door and sit for some few minutes away from the family, doing the stupidest thing. Yeah, nobody knows that we are doing stupid things, but we will do it because we need some time for ourselves. So there's a great need for children to have their daily timetable looked after, because you have to take into account that they also get frustrated, that they also get depressed, that they also get upset, that they need some downtime. Academics, I'll come to academics in a minute. Okay. I believe a pediatrician is the first responder and he is the continuity anchor. She remains the continuity anchor because families go to the pediatrician ever so often. I know adult 28-year-old ASD with IDD child is still going to a pediatrician. Why? Because that lady has seen this child from such a young age. All decisions are taken along with the pediatrician. So everybody must have an anchor, and usually a medical person or a therapist whom the child knows for a very long time. All right. So Dr. Rama, in her first introduction, said that autism care is always multidisciplinary. So no single discipline owns this care. What are the challenges of working in a team? Lot of challenges working in a team. How to refer, whom to refer, ego issues, hierarchy issues, I am better than them issues, therapists who say, enough if you come here, no need to go anywhere else. All that is a big no-no. Who acts as the coordinator or the case manager? Usually it is a parent who's the coordinator of this whole thing. So I usually tell parents to keep a logbook, because we know that a child with ASD, IDD, ADHD is a chronic illness kind of a model. Things will get better. Things will get better. A small number get out of the diagnosis. They can no longer be diagnosed autism at a certain age, but they still have troubles. Don't all our children, typical or non-typical, have troubles? Everybody is very fine? No, everybody has troubles. So there is always something to do. And when the child has NDD, it is better if the parent keeps a log, because the log is necessary, because you need to know what medication or what treatment or what problems or which therapist, all this is necessary for a long-term care. Oh, what happened? Oh. Thank you. How many of you were watching my shawl fall? So you see how we get it. This you could have told me earlier now. So I'm shooting the messenger. Okay, so most often the parent is the case manager. The parent takes the trouble of doing all this. It is difficult but not impossible to bring together a good team to work for neurodevelopmental disorders. And here in CoE, you have a good team. To work in a good team is a pleasure. To work in a good team is such an advantage for the family, because they get everything in the same place. So hard for the family to go from place to place. So whatever you all do, try to get a good team together. A major shift in autism care in the past decade has been about neurodiversity. Neurodiversity is a big issue. So supportive frameworks like the biopsychosocial model, it is not only social model, medical model, they are not adversarial. They are not fighting against each other. Doing it together focuses on meeting the individual's goal, being respectful of caretakers, being respectful of the child's own goals and own needs. Because autistic people, IDD people, they have their own goals, they have their own likes. You can't kind of like a tyrant do things with them. You have to take their needs also into it. All right, I want to do this academic pressure before my time is up. Academic pressure overwhelms neurodivergent needs. If a child is mildly okay in studies, parents want to keep them in a regular school. And the amount of trouble it takes for the young person to be in a regular curriculum is immense. I have found time and again that the child reaches 9th standard, 10th standard, child is neurodiverse, ADHD or IDD or ASD, and the parents are pushing them for finishing 10th standard. The behavior problems are immense. The anger against the mother is immense. The child finishes 10th by hook or by crook and never touches the book again. Completely shot to pieces relationship with mother. Won't listen to mother about anything else because so much of trouble over academics. So please be able to counsel families about this great need to finish academics at any cost, just about at any cost. The child is miserable but must finish. So NIOS, the kinds of things that are possible in NIOS, the kind of education they can get otherwise, all of that, all therapists should know. I want to end by talking about a parenting riddle. Can you be what I want you to be, or I want you to be what you can be? And that's the decision parents have to take. Otherwise, they will not agree. Yeah. Thank you. I want to talk about this. Those of you, IACAP textbook is a free source. They have all kinds of things in this. You can use it, you don't have to quote it, they have slides and everything like that. This is another book, this is the one where there is no child psychiatrist, that's published by the Royal College. The Disabled Village Children is also available. These are books that you will find it very useful. I want to end by talking about, according to the theory of aerodynamics, and as may be readily demonstrated by laboratory tests and wind tunnel experiments, the bumblebee is unable to fly. This is because the size, weight, shape in relation to total span of the wing makes flying impossible. But the bumblebee, being ignorant of these profound scientific truths, goes ahead and flies anyway and manages to make a little honey every day. So we are in a position to do a lot of what we can and hope that things will work for the best for our neurodevelopmental disorders children.
Thank you, Dr. Shobha Srinath, for that very, very deep, insightful keynote. I now invite Dr. Rema Chandra Mohan to felicitate Dr. Shobha Srinath. We now move to the inaugural segment of today's convention. We request everyone to please rise for Tamil Thai Varthu. நீராரும் கடலுடுத்த நிலமடந்தை கிழிலொழுகும் சீராரும் வதனமென திகழ் பரத கண்டமிது தெக்கனமும் அதிர் சிறந்த திராவிடனன் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம் வியந்து செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே. I now invite Dr. Rema Chandra Mohan to felicitate Mr. R. Sudan, retired IAS, Chief Executive Officer, Center of Excellence for Persons with Autism. State Commissioner for Persons with Disabilities. I also invite Mr. Anish Shekhar, Managing Director, National Health Commission. I also invite Dr. Anuja Joshi, Social Policy Specialist, UNICEF.
Dr. Vinesh, Dr. Anurag. Good morning to all of you. It's my great pleasure to welcome you once again to this conference on autism and to see under one roof pediatricians, psychiatrists, psychologists, therapists, educators, researchers, and other professionals who share a common commitment, that is to improve the lives of children and adults with autism and their families. For us, this conference has a larger purpose. Tamil Nadu has had the opportunity to build a model of autism care that is accessible, evidence-based, multidisciplinary, and scalable. The Center of Excellence is envisioned not simply as another center providing services, but as a hub of excellence, knowledge, and innovation, a place where clinical care, training, research, and technology come together. Our vision is to create a continuum of care which begins with early identification in the community, moves through accurate assessment and diagnosis, provides appropriate intervention and family support, and continues through education, adolescence, adulthood, and independent living. But a center of excellence cannot function in isolation. Its real strength will be in the network it creates with government hospitals, medical colleges, district health systems, primary healthcare services, Anganwadi centers, schools, therapists, special educators, and most importantly, families. We want to build capacity across the state so that expertise does not remain concentrated in one location. The center should be a hub, but the services must reach the child. Equally important is our commitment to evidence-based practice. Autism care is an evolving field. We need to continuously evaluate what works, adapt international evidence to the Indian context, generate our own data, and ensure that families are protected from interventions that are expensive, unproven, or potentially harmful. Training will therefore be a major pillar of our work. We've been training pediatricians to recognize developmental concerns early. We have trained healthcare workers, psychologists, therapists, special educators, and teachers. And we are now equipping parents with caregiver courses and parent workshops, which will provide them with the much needed knowledge and practical skills so that they can become partners in intervention rather than being passive recipients of care. The CoE is also evolving as a center for research and innovation using technology, digital tools, telehealth, AI, and new models of service delivery, which always will ask the fundamental question, does this make a difference to the child and family? And finally, we must remember that autism is not only about diagnosis and therapy. Our ultimate goal is participation, inclusion, communication, independence, dignity, and quality of life. As we begin the conference, I hope we will think beyond individual disciplines and individual institutions. Let us think about what we can build together for Tamil Nadu and potentially create a model that can be adapted across India. I invite all of you to contribute your expertise, your experience, and equally important, your questions and ideas. Let the CoE become not just a building, but a movement towards earlier identification, better care, stronger families, and a more inclusive society. With that vision, I once again warmly welcome you all and wish you a stimulating and productive conference. Thank you.
I now invite Dr. Rema Chandramohan to felicitate Mr. Sudan. I invite Mr. Sudan to felicitate Anish Shekhar, Managing Director, National Health Commission. I also invite Mr. Sudan to felicitate Anurag Joshi, Social Policy Specialist, UNICEF. I invite Ms. Saranya, Assistant Chief Executive Officer, to felicitate Dr. Rema Chandramohan. I now invite Mr. Sudan to address the gathering with few words.
Quick words. It's a fantastic event, wonderful day. Well, I really want to congratulate my own team for having organized this. And the experts who have come all the way here. நான் என்னெல்லாம் சொல்லணும்னு நினச்சனோ everything Dr. Rema has said. It is a informal, I see it more as a family event. The way Center of Excellence has been structured, we have vision, and we have support at all levels. I can very confidently tell the presence of Mr. Anish here, the NHM director, and the presence of veterans, the presence of experts, it gives us a message that the Center of Excellence, in its constant pursuit, very consciously we are developing a support network. The whole event today, purpose is let us all join hands. Administratively, I can tell Center of Excellence is a baby. We have started it. Slowly, we are structuring it. We really want to achieve, we want to make it a true Center of Excellence, and that will take little more time. And that can happen only if all of you support, all of you become part of this journey. And that is not going to happen very easily. And inauguration, Abdina, I see it as an inauguration of a long-term engagement between all of us. And it is not a one-off event. And anything and everything that's happening here, that is going to happen here, I think it has to go down, it has to percolate, it has to touch the villages of Tamil Nadu, the blocks, the districts. In the entire hierarchy, entire pyramid of caregiving institutions, whatever we speak today, whatever good ideas that come here, in a small way, it has to start touching all the levels. That is the idea, that is understanding. And my sincere thanks to UNICEF, Mr. Joshi. UNICEF has been constantly supporting us. From the beginning, I'm saying, in each and every event, they knock our doors, they ask us, what is the support you need? So, I'm so proud, I'm so happy. More such events should happen. More such events should happen. And whatever great practices, great thoughts, great ideas which emanate, which originate here, it all should go to all levels, as I said. And in that regard, I think the presence of the NHM director is really going to help us. Once again, my best wishes to all of you. My great thanks to the experts who have come all the way here, the doctors, the therapists, and my sincere appreciation to the fantastic work my team has undertaken. And thank you. Nothing much to say. Thanks a lot.
Thank you so much, sir. I now invite Social Policy Specialist, Mr. Anurag Joshi, to address the gathering.
Good morning, everyone. Respected MD sir, respected Susan sir, respected Ms. Reema ma'am, and respected participants. Why I'm saying respected participants? Because I can foresee that something which has been developed, created, communicated here will go to the community, and the community will get benefited from all the efforts good efforts has been taken by CoE. Because discussing about the issues related to neurodevelopmental issues is something which is the right time. Why I'm saying is, we're aiming for the 100 year of Indian independence at 47. Right now we are at 2026. The child born to this month, in August 2026, will be 21 years of age in 1947. So now we are building the foundation of the developed India, developed nation. And by doing such a wonderful effort, I believe we can achieve it. Because surviving of a child we have worked a lot about surviving a child. Now it's time to thrive a child. And UNICEF is committed for survival as well, thriving of a child. So thank you so much for having us on board. And I look forward and congratulate Reema ma'am for the wonderful work and under the guidance of Sudan sir. And look forward to another achievement and another more milestones to be achieved under leadership. Thank you, sir.
I invite Dr. S. Anish Shekhar, Managing Director, National Health Mission.
Good morning to all. First of all, I would like to thank Center of Excellence team here, CEO Sudan sir and the Rama ma'am for inviting me to this very, very useful and novel initiative. Center of Excellence itself is very noble initiative, and now coming out with this convention, I believe is one of the unique kind of or a path-breaking kind of an initiative that is getting started here. So to become a part of that, I'm really happy to be a part of this effort that is being taken to bring autism and the connected spectrum disorders to the forefront and bring the best of people from around the world. I mean, we have the best of resources in our own country. So they are here. So it is no mean effort that has been put to bring such I can call a galaxy of specialists. I was really thrilled to see the kind of people who are speaking here today. I had a chance to listen to Madam Shobha speaking here. I was really, amazed to see the kind of perspective that she could bring to the audience. Only we are at a loss because of time. She had to cut short her presentation in between. The loss is only ours. And the people who are lined up also, they are really the best in the business, and the areas that need to be discussed have been brought for discussion. That is more important. That's how meticulously the event has been curated by the organizers. So I think we should all put our hands together for the organizers for bringing this together. And for me also, this is again, I feel it is a great opportunity to partner with Center of Excellence, because from NHM, we have this mandate, and I'm also the Commissioner for Maternal and Child Health. So from there also, my responsibilities flow towards ensuring that all children get the best possible childhood. So early childhood development is now seen as the most important investment any country can make for their future. Yesterday I was having a discussion with one of the senior officers from Meghalaya, Sampath Kumar IS. So he was bringing to my attention that there are studies which say that there is a 17x returns that you get by investing in early childhood. And when it comes to children with special needs, children with difficulties, I believe early intervention is not just 17x, I think it is 170x. If we can bring in early intervention and continued follow-up. It is not just screening and finding, but tracking and following up that is going to give us results. So there are a lot of confusing theories that is there whenever you have a child with special needs. Being a parent myself of a child with autism spectrum, I have also gone through this, wherein you don't know what exactly is the right thing to do. So it is very important that we empower the caregivers, like was discussed, and give at least a little bit of clarity on what is the way ahead and what are the things that you can do towards the last slide that we saw when Dr. Shobha was showing. It is not about meeting our expectation, it is about where the child can reach and how to support the child reach there. A lot of divergent theories, lot of therapies, lot of different options that is put before you. So it is only if I could get exhausted, if I could get, confused. Being a doctor myself, I am a medical graduate and had experience in public health also. Even at my level, imagine what person who doesn't have any exposure to medicine, etc., will have to go through, or with a little bit lesser financial background also. Being in government service, you have that kind of a support system. But that even if at my level itself, I had to go through so much of conflicting thoughts. So I can imagine what a normal, regular parent would go through when they have a child with special need. Especially on a child with autism, where you don't know what exactly is the right thing to do. Even today, we talk about evolving therapies, evolving interventions. Nobody knows what works fully, because everybody comes with a caveat that maybe it will work for your child, maybe it may not work for your child. It is a trial and error. That sometimes can be a little bit of a exhausting experience. So, because as a parent, you also want to do the best for your child. So sometimes you feel like, am I doing enough? Am I doing the right things? These areas can become a little exhausting for a parent, for a caregiver. So it is important that I feel we bring that clarity to the parents also, and give them that opportunity to give the best for their child. Not everybody will be having the financial muscle to do that. So that is where we come in from the government. Today we have a very robust system. Earlier we may not have had that infrastructure. Now we have the Center of Excellence here as the Apex Center, which is helping children. Down the line also, from the Anganwadi up till Center of Excellence, we need to build that network. We need to build a network around early intervention centers operated by multiple departments. Health department operates early intervention centers. Differently able welfare department also operates early intervention centers. School education department also operates early intervention centers. To bring them all together on a platform and to give clarity to the child and clarity to the parent as to what is happening to them and what is the path ahead of them. A lot of areas which are coming up for discussion today. So I wouldn't adventure into all that. That is what, seeing the list of speakers itself, it is a humbling experience, and I shouldn't have talked this much even, because a lot of reputed speakers are going to come and give insights on various issues before us. So once again, I thank you all, and I also give my full commitment from Health Department, from NHM, to be a part of this exercise. And once we all walk together, once we all come together with the single-minded focus of giving our children the best that we can, our futures also will be right. One more thing I will say, I feel a little bit of hope with what is happening today in the world. Today, intelligence is becoming a commodity. If you see what's happening around us, intelligence is going to become a commodity very soon, going into the future. So what is going to differentiate human beings is not how intelligent you are, not your IQ. It is going to be something else. And that is where I think our kids have a differentiating advantage. Thank you.
Thank you, sir, for those inspiring words. I invite Dr. Rema Chandramohan to give the vote of thanks.
Here I am once again, but this time I'll be a little brief. I have to deliver the vote of thanks because there are a lot of people whom I have to thank for making this event happen. So, starting with the government, our Honorable CM is directly in charge of the welfare of differently able. So, start with him. I'm grateful to the Department of the Welfare of the Differently Abled. The Commissioner was not able to come here today. We are very grateful to them for giving us the go-ahead sign to conduct this conference. The Health Department for supporting us in all our ventures. NHM, thank you so much, sir. We had the setup, which I came into about 20 months ago, was done by NHM, and they're continuing to support all our efforts. UNICEF, who have single-handedly sponsored the entire event. Dr. Anurag and Dr. Pooja, we have troubled her no end, and so that's why we were able to allow a free registration for everybody. Thank you. And Pooja, you can get up. And yeah, thank you so much. Now, thank you. Now to my own team, starting with the head, Tala, Sudan sir. Normally, women are supposed to be multitaskers, but here you have a sir who's our CEO, member secretary of Model School, and the State Commissioner for Persons with Disabilities, and each department is given equal importance, and he is a tough taskmaster. He's got a phenomenal memory. He will remember at what stage that particular project is and is it with whom, and so you better be on your toes if you have to work for sir. So thank you for all that support. It's a blessing and certainly a pleasure working with you, sir. So the doctors, Dr. Sivalingam, Dr. Satyaprabha, Dr. Kabilan, and Dr. Vijay Lakshmi, all of them have supported us in not only today, we had a parent workshop yesterday where 60 parents were empowered with we had an AAC, ADL, sensory integration, and an ABA workshop. And the parents were stupefied, to say the least. We put them in groups of 15 and trained them. We had a team from, Jayamina was there, and we had a team from outside. Everybody came together, and it was a phenomenal experience. I'd like to thank the therapists. I'm unable to mention each of them by name, but they are passionate and empathetic, and that is the reason they are part of our team, and that is the reason we are doing well today. Thank you each and every one of you therapists who have been supportive. I'd like to thank the front desk, tortured for appointments, but they don't lose their cool. They interact very well with the parents. Thank you, nurses and the front desk managers. I'd like to thank the project management. Saranya, thank you very much. Saroja, she's senior by age, but certainly a junior when it comes to her energy levels. Thank you. Sindhu, in charge of CSR, she can get money from a rock if she squeezes hard enough. Then we have our dear Ganesh, a wise head on young shoulders. Where's he? Okay. I thought you should all see him. Ganesh, Surender, his word, he talks as much as he works. Thank you. Our content team, can you just put up your hands? They've done a great job for all of us. Vijayanand, then our media, Balabharati and co. Charles, thank you. We've also put you on tenterhooks. So, and our NGOs, Madhuram Narayan and our VXL. And if I am failing in my duty, if I don't thank today's faculty, thank you, especially Dr. Shobha and Dr. Satya and Srinivas, who have come from far off, I mean little at least. And thank you all for being here, chairpersons, all the faculty members, especially the delegates who have spared. Sunday is very precious for all of us, and in spite of that, you're all here. Thank you so much for making this event a grand success. If I have missed out, thank you, Radisson Blue management for being with us. Thank all of you for making this program a success. Thank you once again.
Thank you so much, ma'am. That brings our inaugural session to a close. For our next section, I invite our moderator, Mr. R. Sudhin. Sir, a few words to open this session, please.
Yes, I would request Hanish and Mr. Joshi, yeah, you can take seat there. I don't want to leave. Thanks. Thank God, thanks. Would want Dr. Devagi and Mr. Balabharati also to come on the stage. In the session today, what is the topic?
Sir, it's Journey of a Child with Autism.
Right. Yes, either you can keep it like this. So, in the Talaipu, from a parent's perspective, I am a special parent, and my only child, my son, he's autistic. He's now, he's about to be 12 years old. And I'm also the Chief Executive Officer of this Center of Excellence. இதுலேயும் தலைமை பொறுப்பில் இருக்கிற காரணத்தினால என்னுடைய அனுபவத்தை நான் பகிர்றேன். இதில் வந்து ஆடியன்ஸில் ரெப்யூட்டட் டாக்டர்ஸ் இருக்கிறீங்க, தெரபிஸ்ட் இருக்கிறீங்க, பேரண்ட்ஸும் இருக்கிறீங்க. ஸோ இந்த செஷனுடைய நோக்கம் என்ன அப்படின்னா, ஒரு பெற்றோருடைய பார்வையிலிருந்து ஆட்டிசமை வந்து எப்படி வாழ்க்கை அனுபவம் எப்படி இருக்குது, இதில் வந்து உங்கள் எல்லாருடைய பங்கு, டாக்டர்ஸுடைய பங்கு, தெரபிஸ்டுடைய பங்கு, மற்ற பேரண்ட்ஸுடைய பங்கு, கம்யூனிட்டியுடைய சப்போர்ட். When I mean community, as Dr. Shobha rightly said, nuclear family is not a family enough. There is need to get support from neighborhood, from sibling, from the larger family circle. All that should happen, which is unfortunately not happening in a nuclear family setup. So, இதை எப்படி வந்து ஃபர்தராக ஸ்ட்ரென்தன் பண்ணுறது, இதுதான் என்னுடைய பார்வையிலிருந்து. ஸோ I will just begin by saying that I belong to 2006 batch of Indian Administrative Service, and my wife is a doctor. எங்களுக்கு though we knew something about autism, I never thought that autism will be part of my family and I have to live with autism. அந்த மாதிரி நான் நினச்சி பார்க்கவே இல்லை. எனக்கு சன் பிறந்ததுக்கு அப்புறம் ஆட்டிசம்னு தெரியாது. அப்போ வந்து எந்த மேனிஃபெஸ்டேஷன்ஸ் எதுவுமே இல்லை. ஒரு 1 year போனதுக்கு அப்புறம் குழந்தை விளையாடும்போது சைக்கிளை திருப்பி போட்டு சைக்கிள் வீலை சுற்றி சுற்றி பார்த்துட்டே இருப்பான். ஸோ அப்போ தான் என்னுடைய ஒய்ஃப் வந்து என்ன சொன்னாங்கன்னா, வந்து தெர் இஸ் சம்திங் மிஸ், நம்ம வந்து லெட் அஸ் கன்சல்ட் டாக்டர், ஒரு டெவலப்மெண்ட் பீடியாட்ரிஷனை வந்து கன்சல்ட் பண்ணுவோம். ஸோ தட் இஸ் வென் வி ஸ்டார்டட் ரியலைசிங் தேர் இஸ் அ ரெட் ஃப்ளாக் அப்படிங்கிற மாதிரி. ஸோ தட் இஸ் ஹவ் இட் ஸ்டார்டட். அப்படி தான் ஆரம்பித்தோம். அதுக்கப்புறம் ஒவ்வொரு ஸ்டேஜ்லேயுமே ஆஸ் யங் பேரண்ட்ஸ் இட் வாஸ் வெரி வெரி ஓவர்வெல்மிங். அண்ட் ஃபார்ச்சுனேட்லி we have a very good family support, ஒரு institutional support இருக்குது. Every stage as it unfolded, ஒவ்வொரு லெவலாக தாண்டி வர we found that we got very good support. டாக்டர்ஸ்ட்டு வந்து சப்போர்ட் இருந்தது, தெரபிஸ்ட்னு சப்போர்ட் இருந்தது. பட் ஒன் திங் விச் வாஸ் ஆல்வேஸ் கோயிங் ராங், எது வந்து நடக்காமல் இருந்தது அப்படின்னா, நாங்கள் ஒரு இடத்துல ஆக்குபேஷனல் தெரப்பி கொடுக்குறோம் அப்படின்னா ஒரு 10 kilometer வண்டியில் பையனை கூப்பிட்டு போய் பிஹேவியரல் தெரப்பி கொடுக்க வேண்டியிருக்கும். எல்லாமே ஒவ்வொரு கார்னரில் இருக்கும். And time was always running out. Anxiety was always building. ஸோ இந்த மாதிரி நிறையா சிக்கல்களும் இருந்தது. அண்ட் தட் வாஸ் ஒன் ரீசன் கவர்மெண்ட்டுடைய விஷனில் சென்டர் ஆஃப் எக்ஸலன்ஸ் ஒரு அம்ப்ரல்லாக்குள்ளே ஒரு ரூஃபுக்குள்ளே வி ஷுட் ஹேவ் ஆல் தெரப்பீஸ் ஆல் சப்போர்ட் ஒன்றா வரணுங்கிறதுக்கு தட் வாஸ் ஆல்சோ ஒன் ரீசன். ஸோ கம்மிங் பேக் டு மை ஸ்டோரி. ஸோ இந்த மாதிரி ஒரு டிஸ்பர்ஸ்டு ரிசோர்ஸ் சப்போர்ட் சிஸ்டம் இது வந்து வாஸ் கான்ஸ்டன்ட்லி பாதரிங் அஸ். ஆஸ் அ பேரண்ட் இன்னுமே வந்து ஐ கேன் டெல் தட் எவ்ரி டே சம்திங் நியூ இஸ் ஹேப்பனிங் அண்ட் எவ்ரி டே வி ஆர் லேர்னிங் சம்திங். இட் வுட் பி பெட்டர், நான் வந்து த ரெக்வஸ்ட் ஐ வுட் பிளேஸ் பிஃபோர் த ஃபோரம் அண்ட் பிஃபோர் தி அதர் பேரண்ட்ஸ் என்ன அப்படின்னா, கைண்ட்லி ஷேர் யுவர் எக்ஸ்பீரியன்ஸ் அண்ட் டெல் அஸ் ஹவு ஓவர்வெல்மிங் இட் இஸ். ஒரு பேரண்ட்டாக நாங்கள் வந்து டாக்டர்ஸையோ தெரபிஸ்டையோ பார்க்கும்போது we listen to lots of advices, to-do list. இதை பண்ணுங்க, டாக்டர் ஷோபா சொன்ன மாதிரி வீட்டுக்கு போகும்போது இதை பண்ணுங்க இதை பண்ணுங்க இதை பண்ணுங்க இதை பண்ணுங்கன்னு கம்ப்ளீட்டாக ஒரு லிஸ்ட் எடுத்து கொடுத்துட்றாங்க. அது எப்படி பண்ண முடியும்னு எங்கள் பெர்ஸ்பெக்டிவில் பார்க்குறது யாரும் இல்லையோ அப்படின்னு ஐ யூஸ் டு ஆல்வேஸ் ஒண்டர். அண்ட் தென் when I talk to other parents, they also share the same experience. Now I would want Dr. Devaki herself, she's a doctor. Madam வந்து she works with Sebastian and Mr. Balabhardi sir வந்து is a Sahitya Academy I think Puraskar winner. So luminaries are here on the stage. நீங்கள் உங்கள் அனுபவங்களை பகிருங்க, நீங்கள் என்ன சொல்ல விரும்புகிறீங்க, உங்கள் பார்வை என்ன. டாக்டர் தேவகி ப்ளீஸ் ஸ்டார்ட் and I would want to moderate as it goes. Thank you.
Thank you. Welcome all of you for Center of Excellence, and I am the proud friend of Dr. Rema Mohan. She's my classmate. Thank you, Rema, for inviting me as a parent. என்னோட குழந்தைக்கு 31 வயசு ஆகுது. 31 வயசு பேரண்டல் ஜேர்னியை 15 நிமிஷத்தில் சுருக்கி சொல்லணுங்கிறது வடிவேலு பாஷையில் சொன்னால் என்ன வில்லத்தனப்பா இது அப்படின்னு மாதிரி இருக்குது. பட் I'll try, okay? Right? Because there are many speakers. Anyhow, you can always contact me anytime for my journey to learn things. When I became a mother in 1995, when my son Sachidanandan was born, a cesarean delivery in Chennai Kaliyappa Hospital, where I was working as a duty doctor, and my husband, Dr. Sathapan, who's an occupational health physician, retired from L&T, and he's now an occupational health physician professor in Ramachandra Medical College. So when this little boy was born, he was 3.25 kg. We both were overwhelmed. We both were overjoyed. Mainly my husband was overjoyed because he was fair and pink in color, unlike my color. So the first thing when the doctor said, உனக்கு பையன் பிறந்திருக்குடா அப்படின்னு டாக்டர் ராதா பாண்டியன் சொன்னப்ப, வெள்ளையா இருக்கானா கருப்பா இருக்கானான்னு கேட்டார். அடி அப்படின்ட்டாங்க மேடம். ஸோ he was such a darling when he was born. As a mother and as a father, we had lots of dreams about him. The journey was first happy, then slowly there was denial, there was grief, there was challenges, there was confusion, there was exhaustion. I was tired, I was hopeless. But at times there were happiness, fulfillment and victory. 1997, 2 years after my son was born, he was diagnosed with autism by the article written by Mangayar Malar, which was told to me by my friend. Sir சொன்ன மாதிரி காரை கொடுத்தாலோ சைக்கிளை கொடுத்தாலோ தலைகீழா போட்டு வீலை சுற்றுவான். அப்புறம் எந்திரிச்சு நின்றுட்டு நம்மளால அப்படி சுத்த முடியாதுங்க. இப்படி நின்றுப்பான், இப்படி காலை நீட்டிப்பான், அப்படி கண்ணை மேலே பார்த்துட்டு அப்படியே சுற்றிக்கிட்டே இருப்பான் 1/2 மணி நேரம். உங்களாலேயோ என்னாலலாம் சுத்த முடியாது. நான் அதை விளையாட்டுன்னு நினச்சேன். பட் அது ஆட்டிஸ்டிக்கோட பிஹேவியர்னு எங்களுக்கு அப்புறம் தான் தெரிஞ்சுது. அதுக்கப்புறமா we were running from doctor, psychiatrist, pediatrician, therapist, ஜோசியர், குறி சொல்கிறவன். எவெல்லாம் குறி சொல்கிறானோ அவங்கிட்டலாம் ஓட வேண்டியது. See, in this attire, I like to tell about my family. Sudan sir சொன்ன மாதிரி, I'm blessed with a wonderful family. My great-grandfather, அவரோட பேரை தான் ட்ரிச்சி மெடிக்கல் காலேஜ்க்கு வச்சுருக்காங்க, கியாபே விஸ்வநாதம் பிள்ளை in Trichy. My father is from Trichy. And I have an extensive family of my father's side with lot of cousin brothers and cousin sisters. Same goes to my mother's father, Mr. Periyana Pillai, who was the first fleet owner in Namakkal, running a bus from Salem to Trichy. He was the first man. So the old people who are 95, 96 years in TVS will know him. So Namakkalna, it is Ramajayam Transports. And I am the first granddaughter. So என்னோட family background வந்து எனக்கு ரொம்ப நல்லா அமைஞ்சுது. ஸோ அதனால என்னோட எங்கள் அப்பா ஒரு advocate. He was a lawyer. And till today, he is no more. But till today, he is my godman, mentor, guide, everything. So when Sachin was diagnosed from the article, I didn't know what to do. ஏன்னா நான் பார்த்த முதல் ஆட்டிசம் குழந்தையே என் குழந்தை தான். நான் என்னோட ஓபி காய் பீடியாட்ரிக் டெக்ஸ்ட் புக்கில் போய் பார்த்தா ஆட்டிசமே இல்லை. ஆட்டிசம்னா என்னன்னு தெரியாது. 1997, internet was not so prevalent, so I didn't know what is autism. So I had to go to a speech therapist to know what it is, because the psychiatrist was said, அது அவ்வளோதான், அது ஆட்டிசம்னா இப்படி தான் பண்ணுவான், மருந்து கொடு, ஹைப்பர் ஆக்டிவாக இருப்பான், மருந்து கொடு, இதை கொடு, அதை கொடு. See, this was very, very traumatic for me, because நம்ம எல்லாருக்குமே சைக்கியாட்ரிஸ்ட்டை போகிறதோ சைக்காலஜிஸ்ட்டை போகிறதோ ஒரு பெரிய சோஷியல் ஸ்டிக்மாவாக இருக்கும். ஸோ இட் வாஸ் வெரி ட்ரொமேட்டிக். ராத்திரியில் தூக்கம் வராது, அழுதுகிட்டே இருப்பேன், என்ன பண்ணுறதுன்னு தெரியல. அட் தட் டைம், லைக் அ பிளெஸிங் இன் டிஸ்கைஸ், I had to take a patient to Dr. Rangarajan, psychiatrist, because my patient was a little anxious and had some depression. So நானே கூட போயிருந்தேன். He's a Malaysian. So when I told, and I had taken my son, because அப்பெல்லாம் I had to take Sachin wherever I had to go, even for work. I used to take him to Kaliyappa Hospital, put him in my duty doctor's room with the caretaker. My MD, Dr. Padmanabhan, was very, very affectionate towards me. So I used to keep the child and I used to work. Then I met Dr. Rangarajan. So the moment he saw my son, he said, "Is your son autistic?" I said, "Yes, sir." Then you go to NIMHANS. I was just talking to Dr. Shobha about my journey in NIMHANS. I went in 1997 to NIMHANS. இப்போ ஆட்டிசம்க்கு சென்டர் ஆஃப் எக்ஸலன்ஸ் இருக்குது, என்னென்னமோ இருக்குது. என் குழந்தைக்கு எதுவுமே இல்லை, நான் மட்டும்தான் இருந்தேன். டாக்டர் சேகர் சேஷாத்ரி இருந்தார் எனக்கு மென்டாரா, கைடா, எல்லாமே. எனக்கு ஆட்டிசம்னா என்னன்னு தெரியாது. There was no books, there was no net, nothing. But he was my mentor. I always tell my brother Bala, டேய், அவர் எனக்கு வேப்பல் அடிச்சாருடான்னு சொல்லுவேன். This is the word I say. He kept me for 10 to 12 days in NIMHANS with Dr. Biju Sunny's support, who was the PG graduate to take care of my son. And extensive research and extensive work was done with my son, me and my husband. And 3 days, they were asking questions only to me and my husband, what we were doing, what was our childhood. It was an extensive research study. And finally, they came to a diagnosis of autism after 12 days. Believe me, I was in NIMHANS for 12 days, not as an inpatient, but I used to go there at 8 and come back by 6 o'clock. We were staying in a hotel nearby. Financially, I was sound to take care of my son. So then, no normal school was accepting him. So we had to put him in a special school called Vidyodaya Learning Center. And this journey is a very, very interesting journey after he went to school. All of us think intelligence comes only to doctors like us, or engineers, or therapists, or occupational therapists, physiotherapists, speech therapists. No. Believe me, intelligence does not come like that. It comes by passion. It comes by common sense. These two things are essential to take care of an autistic child. This was present in his teacher called Raji, who was just a 12th standard Malayali graduate. She was just a 12th standard. She molded him from 4 years till his 12th standard. She made him read and write. Believe me, she's not a special educator. She made him read and write. She made him study materials. She made him sing. And one beautiful thing, I said there was moments of victory, happiness, and fulfillment. Those moments were music. Rema knows she's a good singer, I'm a good singer. So music is in my gene. It's in my husband's gene, but அவர் பாட மாட்டார். அவருக்கு கேட்க தான் தெரியும், பாட முடியாது. பாடினா கஷ்டமாக இருக்கும். ஸோ அதனால் my son started singing before talking at the age of 2.5. And he was a good percussionist. This was diagnosed by Dr. Shekhar Sheshadri because he was a good percussionist. He was a mridangam player. So when my son took Shekhar Sheshadri's key, the car key, and he started percussing on the table. So the moment Shekhar heard that, he stopped everything and he spent 1 full hour with him doing only percussion. And then he said, Devaki, அவன் ஆர்டிஸ்டிக்காக தான் இருப்பான், வாழ்க்கை பூரா அப்படி தான் இருப்பான், ட்ரைட்ஸ் இருக்கும், வளர வளர கொஞ்சம் வரும் கொஞ்சம் போகும், பட் மியூசிக் வில் பி ஹிஸ் ஸ்டேட்டஸ். நவ் my son is 31 years. He has completed his 12th steps. We didn't have பாலாக்கு கிடைச்ச மாதிரி எனக்கு நார்மல் ஸ்கூலிங் கிடைக்கல. So we had to put him in NIOS because he could read and write. So he finished his 12th. After 12th, என்ன பண்ணலாம்? காலேஜ் போகலாமா? வேண்டாம், நான் போக மாட்டேன். This was my son's reply. சரி, என்ன பண்ணலாம்? பாட்டு கேட்கலாம். வேற என்ன பண்ணலாம்? பீச் போகலாம். வேற என்ன பண்ணலாம்? டாட்டா போகலாம். These were the 3 things he said. ஸ்கூல் போகலாம் சச்சு, காலேஜ் போகலாம், முடியாது, நான் வல்லே. See, I said he can talk. So he said, நான் வல்லே. Then we forced him. We tried, as Dr. Shobha said, when we tried to make him do something in academics, that was a bombshell for me. That was from 17 to 23 years, nightmares, night meltdowns. He would scream and yell at 2 a.m. in the morning till 5 a.m. in the morning. We didn't know what it was. இன்னைக்கு வரைக்கும் அதுக்கான டயக்னோசிஸை கண்டுபிடிக்க முடியல. I just let him scream. I just let him cry. It was a big burden for me, not only for me, for my neighbors. So what I did, again I told you I'm financially blessed. So I covered my house with soundproof doors so that the sound cannot be heard by others. And இது எனக்கு சாத்தியமாக இருந்தது, ஏன்னா என்கிட்ட காசு இருந்தது, எனக்கு வசதி இருந்தது. ஆனால் வசதி இல்லாதவங்களுக்கு, நான் ஸ்பாஸ்டன் போகிறேன், I do a lot of service there. என்னோட ஸ்பாஸ்டன் தெரபிஸ்ட் கிட்டேயும் பேரண்ட்ஸ் கிட்டேயும் என்ன ஹெல்ப் வேணாலும் நான் செய்ய தயாராக இருக்கேன். ஏன்னா என்னுடைய அனுபவம், my experience with my son has taken me to this journey to sit in front of you and talk. See, you can't read autism in nets. You can't read by visions. You can't read by classes. You can read by they are all materials. You learn autism by experience. My son, Sachidanandan, taught me autism. My children in Spaston taught me autism. I am boldly saying this. I am not accusing any of you. I am not accusing any curriculum here. But we are the people who are with the children 24/7, looking at their behaviors, looking at their emotions, looking at their physical growth. Okay, when the son becomes adolescent, say 17 years of age, what happens? Shobha ma'am said, masturbation is a big problem. Yes, we face that. Not only me, many parents like me, we face that. We give them the space. You want to do it? Go to your room, go to your toilet, do it, finish it, wash your hand, come back. We never prevented it. The prevention you give to stop it is going to create a bombshell for you because he does not know or he does not understand sexuality as other people can. Normal children has ways to learn it from others, from friends, from movies, from nets. But we don't give our children that because we are very scared, because they can be easily abused, because they are very vulnerable. So this was something which I faced. The adolescent age between 17 to 23 was the worst part of my parenthood, which I sailed with 3 points which Dr. Shekhar told me: patience, 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 and nothing else. It was only patience and only acceptance. He said, you cannot redo or you cannot help his behavior. It is his tantrum. It is his hormonal issues. Leave him, understand him, help him. So I helped him. Then, as he grew, there was new victories, there were new behaviors, new challenges, and there were some times when there was sleep disturbances, so we had to give him melatonin to sleep. And sometimes during 18 to 19 years was the very toughest time for me. And so we were taking him to psychiatrist to get him medicines. Of course, there was a list of medications. Sorry, my friends, nothing worked. It didn't help him. Then finally I landed with See, I have a wonderful batch of 82 friends who are very affectionate and passionate towards me to help me in all my endeavors and all my difficulties. My own classmate, Dr. GB, said, stop all the psychiatric medicines. We'll just give him a small dose of anti-epileptic. Let's see if it works. It worked. I'm not saying psychiatric medicines don't work. It didn't work for my son. It does work for other children. The same anti-epileptic will not work for another son. But a psychiatric drug like risperidone will work. And Sachin was not on medications till 18 years until I had that trouble. Only in that 1 year, and none of the medicines, risperidone was working, aperisol was not working, Oleans was not working. Nothing was working on him. His brain wire is totally different. I don't know. But a small dose of anti-epileptic worked. His behaviors changed. He started listening to me. And now he is a wonderful adult who is very happy child. I won't say child, happy adult who has a wonderful caretaker to take care of him. He can do his work on his own, but he cannot stay in his house alone without me or my husband. So we appointed a Nepali caretaker, God bless. He's a very good, So we got a very good caretaker to take care of him. And now he is a very happy adult who performs in stages where he can go and sing and he can drum and he gives performances in our Spaston. And we have a music group where we have children who can only sing, the autistic children who can only sing but can't do other things. So he goes and sings there and he sings in temples. He sings with karaoke, all that. So now he's an excellent, happy musician with his own computers and with his own music. So this is the journey I have come along. And I would like to end by saying that spend some more time with the parents who have children with any special need, not only autism. Spend extra time with them because you are the pillars. You pediatricians are the pillars who are going to, because if any lay person says he's autism, it is not understood. Any school, any examination, they need a certificate. That certificate comes only from you doctors and therapists and psychologists. So you're all a team. So anything you want, any help, please get to us. We are willing to help you from a parent perspective. Thank you for this opportunity.
Thank you, madam. I think straight to the point. This dose of reality really required I think conventional to put things in perspective. I would request Mr. Balabharati, you kindly share your experience. நீங்கள் என்ன சொல்ல விரும்புகிறீங்க அப்படின்னு சொல்லுங்கள். தேங்க்யூ.
எல்லோருக்கும் வணக்கம். எனக்கு தமிழில் பேசுகிறது இலகுவாக இருக்குங்கிறதுனால என்னுடைய உரையை நான் தமிழ்லேயே தொடர்றேன். சிரமமாக இருக்கிறவங்க பக்கத்தில் இருந்தால் கேட்டுக்குங்க. என்னுடைய காலகட்டத்தில் நிறைய குடும்பங்களில் அதிகப்படியான குழந்தைகள் இருக்கும். அப்படி என்னுடைய குடும்பத்தில் 10 பேர் கொண்ட குடும்பத்தில் 8ஆவதாக பிறந்த ஆள்னா. என்னுடைய சின்ன வயசில் எனக்கு ஒரு ஏக்கம் இருக்கும். எனக்கு ஒரு புதுச்சட்டை எடுக்கிறதுங்கிறது தீபாவளிக்கு மட்டும்தான் எடுப்பாங்க. மற்ற நாட்களில் எடுக்கணும் அப்படின்னா மூத்த ஒரு சட்டை இருக்குல்ல, அதையே திருப்பி போடணும். அவன் ஒரு 4 வருஷம் போட்டு கொஞ்சம் பழுப்பானவுன்னா எங்கள் ஊரில் ஒரு டைலர் இருப்பார், அவர்கிட்ட கொண்டு போய் கொடுத்து அதையே போட்டுக்க அப்படின்னு சொல்லுவாங்க. இப்படி மாறி மாறதும் எனக்கு முன்னாடி வந்து ஒரு 6 அண்ணன் இருக்கான். அத்தனை பேரோட சட்டையும் எனக்கு வரும். அவங்களோட தொலை பேண்டெல்லாம் எனக்கு வரும். நான் வந்து அந்த காலத்தில் ஒரு குட்டி காமராஜர் மாதிரி எல்லாத்தையும் இவ்வளோ பெரிய சட்டையை போட்டு நடப்பேன். அப்படியே அது அரக்கையும் இருக்காது, முழுக்கையும் இருக்காது, இப்படி தான் நடப்பேன். இப்படியான இயக்கங்கள் இருக்கும். நான் ஒரு ஆவரேஜ் ஸ்டூடெண்ட். நிறைய அடி வாங்குவேன் வீட்டில். தெருவில் ஒரு சின்ன விளையாட்டு இருந்தால் எவனாவது தள்ளி விட்டோம்னா வீட்டில் வந்து பொழந்துக்கிட்டுவாங்க. அதுவும் அண்ணன் மாதிரிலாம் மாறி மாறி அடிப்பாங்க. அவன் பிள்ளையை தட்டினியாமே, அவன் பிள்ளையை தட்டினாமே, மாறி மாறி அடிப்பாங்க. இப்படி அடி வாங்கிட்டே வேற இருப்பேன். அப்போ எனக்கு ஒரு ஏக்கம் இருந்துகிட்டே இருந்துச்சு. இந்த அடிங்கிற இந்த வன்முறை வந்து நாளைக்கு நமக்கு திருமணம் ஆச்சுன்னா, ஒரு குழந்தை பிறந்துச்சுன்னா அந்த குழந்தைக்கு நம்ம கொடுக்கவே கூடாது. அந்த குழந்தைய நம்ம அன்பாக பார்த்துக்கிறணும். நம்ம வீட்டில் ஒரே டார்ச்சர். அவன் படிக்கிறானே, நீ படிக்கலையே, நீ ஏன் கவிதை எழுதிக்கிட்டு இருக்க, நீ ஏன் பாட்டு எழுதுறான்னு அதுக்கு வேறு அடி விழும். இப்படி எல்லா விதத்துலையும் நம்ம வந்து துன்பப்படுத்திகிட்டே இருந்தோம்ல. நம்ம குழந்தைக்கு நம்ம எதுவும் டார்ச்சர் பண்ணக்கூடாது. அவன் போக்கில் வளரணும், அவன் மகிழ்ச்சியாக இருக்கணுங்கிறத தவிர நமக்கு வேறு எதுவுமே இருக்கக்கூடாதுங்கிறதான் எனக்கு ஆசையாக இருந்தது. என் மனைவியிடமும் அது பேசும்போது என் இணையரும் அதை ஏற்றுக்கிட்டாங்க. அப்படியான ஒரு சூழலில் என் மனைவி கருவுறாங்க, குழந்தை பிறக்குது. அந்த குழந்தைக்கு இவங்கெல்லாம் சொன்ன மாதிரி குடும்பத்தின் சப்போர்ட்லாம் இவங்களுக்குலாம் இருந்துச்சுல, எனக்கு யாருமே கிடையாது. என் தரப்புலேயும் ஆள் கிடையாது, அவங்க தரப்புல ஆள் கிடையாது. நான் மட்டும்தான் அவளோட இருக்கேன். நியூபார்ன் ஐசியூ கூப்பிட்டு போனோம். குழந்தை பிறந்தது நங்கநல்லூர். நியூபார்ன் ஐசியூக்கு சூர்யா ஹாஸ்பிட்டல் வடபழனி கூப்பிட்டு போயிட்டாங்க. ஆம்புலன்ஸில் கூப்பிட்டு போகிறாங்க. எனக்கு அழுகிறேன், தூக்கிட்டு வாங்குறேன். என்ன குழந்தைய தூக்கவே பயமாக இருக்குது. நான் தூக்குனதே இல்லை. குழந்தை அழுதுகிட்டே போகிறேன். அப்படி போய் அங்கே போய் விட்டு அங்கே ஒரு 3 நாள் உட்காந்து, அங்கேருந்து திருப்பி 3 நாள் கழிச்சு இங்கே கொண்டு வந்து தாயிட்ட பிள்ளை கொடுத்து அந்த அந்த வாழ்க்கை என்பது ஒரு பெரிய துயரமாக இருந்துச்சு. அப்போ வழக்கமாக டாக்டரை பார்க்க போகிறோம். எல்லா விஷயங்களுக்கும் போகும்போது என்னுடைய ஃபேமிலி டாக்டராக நங்கநல்லூரில் இருக்காங்க, லதா சந்திரசேகர் அப்படின்னு. ஸோ அந்த டாக்டரை தான் பார்த்தோம். ஒரு 1.5 வயசில், ஒரு 1.25 வயசில் ஒரு ஏதோ ஒரு விஷயத்துக்கு போகும்போது அவங்க குழந்தைய பார்த்துட்டு, உங்கள் குழந்தைக்கு பிடிடியாக இருக்கும் அப்படின்னு சொன்னாங்க. பிடிடின்னா என்னன்னு தெரியாது நமக்கு. அப்படின்னா என்னது அப்படின்னு கேட்டோம்னா ஆட்டிசம் அப்படின்னு சொன்னாங்க. அப்படின்னா என்னது? அது வரைக்கும் எனக்கு ஒரு கர்வம் இருந்துச்சு. நான் நிறைய படிக்கக்கூடிய ஆள், நானும் என் மனைவியும் நிறைய படிக்கக்கூடிய ஆள், புத்தகம் படிக்கிறோம், நிறைய அறிவோடு இருக்கும் அப்படின்னு நினச்சோம். இந்த வார்த்தையே புதுசாக இருந்துச்சு. அப்போ அவங்க என்ன சொன்னாங்கன்னா, இது ஒரு டெவலப்மெண்ட் டிலே மாதிரி இருக்கும், நீங்கள் ஒரு டாக்டரை பாருங்கன்னு ஒரு சைக்காட்ரிஸ்ட் டாக்டருக்கு எழுதி கொடுத்தாங்க. அந்த டாக்டருக்கு அப்பாயின்மெண்ட் வாங்கினா அவங்க ஒரு 35 நாள் கழிச்சு தான் அவங்க அப்பாயின்மெண்ட் கிடச்சிச்சு. உடனே அவங்கள போய் பார்க்க முடியல. சரி, அந்த 35 நாள் காத்து கிடந்தோம் அவங்கள போய் பார்க்கறதுக்கு. 35 நாள் கழிச்சு அங்கே போனால் அவங்க அப்பாயின்மெண்ட் 5 மணிக்கு கொடுக்குறாங்க. ஒரு 10க்கு 12 இருக்கக்கூடிய அறை. 5:30க்கு எங்களுக்கு அப்பாயின்மெண்ட்டு. அங்கேருந்து ஃபோன் அடிச்சு 5 மணிக்கே வந்துடணும் அப்படின்னு சொல்லிட்டாங்க. நாங்கள் அடிச்சு பிடிச்சி கிளம்பி போயிட்டோம். அந்த அறைக்குள்ளே ஒரு 15 பேர் ஏற்கனவே இருக்கான். எல்லா பேரும் பிள்ளையோடு உட்காந்துருக்கான். எல்லாம் குட்டி குட்டி குழந்தை. 1.25 வயசு என் குழந்தைங்கன்னு யோசிச்சு பாருங்க. நிற்க மாட்டேங்கிறான், பெட்டையிறான், அப்படியே நெளிகிறான், உட்கார வச்சா அப்படி வலிக்கிட்டு போகிறான், இப்படி தூக்குனா வலுக்கிறான், உட்காரவே மாட்டேங்கிறான். எனக்கு முன்னாடி இருக்கிற பெற்றோரும் இதே மாதிரியான துயரங்களை அனுபவிச்சுக்கிட்டு இருக்காங்க. பக்கத்தில் உள்ளன்ட்டு உனக்கு எத்தனை மணி அப்படின்னு கேட்டேன். நான் 4 மணி. டேய் என்னடா இது, 4 மணியில் நீ காத்துக்கிட்டு இருக்கியா, நீ எத்தனை மணிக்கு நீ உள்ளே போவேன், நான் எத்தனை மணிக்கு பார்த்தேன். கடைசியில் எங்களுக்கு உள்ளே போகிறதுக்கான நேரம் கிடைத்தது 7:30 மணி. கொஞ்சம் சிந்திச்சு பாருங்கள். ஒரு ஏடிஎஸ்டி குழந்தை, ஒரு ஹைப்பர் ஆக்டிவான ஒரு குழந்தைய வச்சுக்கிட்டு 10க்கு 12 அறைக்குள்ளாக எவ்வளவு மணி நேரம் நாங்கள் துன்பப்பட்டிருப்போம்னு மட்டும் யோசிங்க. அவ்வளவு பெயினாக இருந்துச்சு. ஏன்னா உட்கார முடியாது. என் மனைவியை உட்கார வச்சுட்டு நான் தெருவில், அவங்க இருந்த அந்த கிளினிக் இருந்த தெருவில் எல்லாத்திக்கிட்டே இருப்பேன். கொஞ்ச நேரம் எனக்கு ஷோல்டர் வலிச்சிடும். என் குழந்தை வந்து 4 கிலோ வெயிட்டில் இருந்தான். தூக்கி கொண்டு என் மனைவிட்ட கொடுத்துட்டு அவள் சுற்றிக்கிட்டு இருப்பா, நான் போய் உட்காந்துருப்பேன். எப்போ கூப்பிடுவாங்க அப்படின்னு உட்காந்துட்டு இருந்தோம். இந்த துயரங்கள் இருக்குல்ல, இந்த துயரத்தை 7:30 மணிக்கு உள்ளே போகிறோம். உள்ளே போன உடனே டாக்டர் அப்படி பார்த்து அடுத்த நிமிஷத்தில் அவன் பையனுக்கு ரொம்ப சிவியரான ஆட்டிசம் அப்படின்ட்டாங்க. என்னது ஆட்டிசம் தானே அவங்க சொன்னாங்க, இது சிவியரான ஆட்டிசம் ஏதோ சொல்கிறாங்களே, ஒன்றுமே புரியலை எங்களுக்கு. அது அப்படி தான். நான் இன்னொரு டாக்டரை போய் இன்னொரு ஆளை எழுதி கொடுக்குறேன், நீ அவன்கிட்ட போய் அசஸ்மெண்ட் எடுத்துகிட்டு வா போ அப்படின்னு வேற ஒருத்தவங்கிட்ட கொடுத்தாங்க. அவங்க கிளம்பி நான் இங்கேருந்து ஆலந்தூர் ஓடணும். திருப்பி ஆலந்தூர் போனால் அவங்க ஒரு வாரம் கழிச்சு தான் வர சொன்னாங்க. இப்படி மனசில் பயம் வந்துக்கிட்டே இருக்குது. எனக்கும் என் மனைவிக்கும் இன்னைக்கு தேதி வரைக்கும் ஒரு நல்ல பழக்கம் இருக்குது. செல்ஃப் மெடிசன் எடுத்துக்கவே மாட்டோம். மருத்துவர் கொடுக்குற ப்ரிஸ்கிரிப்ஷனை தாண்டி நாங்கள் மெடிசன் எடுத்துக்க மாட்டோம். நாங்கள் கூகுள் பண்ணவே இல்லை. என்னவா இருந்தாலும் சரி மருத்துவர் சொல்லட்டும், நம்ம பார்த்துக்கலாம் அப்படின்னு. அப்புறம் இன்னொரு ஆள்கிட்ட போனால் அவங்க ஒரு அசஸ்மெண்ட்லாம் எடுத்துகிட்டு எல்லாத்தையும் எடுத்து பார்த்துட்டு, எஸ் உங்கள் குழந்தைக்கு என்னென்ன தெரப்பிகள் கொடுக்க வேண்டியிருக்கும் அப்படின்னு சொன்னாங்க. தெரப்பினா என்ன குழந்தை பார்க்க ஆள் லட்டு மாதிரி இருக்கான், உருண்டையாக இருக்கான், அழகாக இருக்கான். ஆனால் டாக்டர் சொல்கிறாங்க ஐ கான்டாக்ட் இல்லை அப்படின்னு. எங்களுடைய ஃபேமிலி டாக்டர், எங்களுக்கும் என் மனைவிக்கும் ஐ கான்டாக்ட் இருக்குது. ஸோ எங்களால் அது ஃபேனை சுற்றுறதை பார்க்குறான், காரை கவுத்தி போட்டு சுற்றுறான், சட்டையை கவுத்தி போட்டு சுற்றுறான், எல்லாத்தையும் சுற்றுறதுல வேலை செய்கிறான். தேவகா சொன்ன மாதிரி நின்றுக்கிட்டு ஒரு சுற்றுறான் சர்ன்னு. திருப்பி அந்த அசஸ்மெண்ட் எடுத்துகிட்டு அந்த செக்ரட்டரிஸ்ட் டாக்டர் போனால் திருப்பி 1.5 மாதம் கழிச்சு வாங்குறாங்க. அப்பாயின்மெண்ட் உடனே கிடைக்கல. நம்ம ஏற்கனவே பார்த்துட்டு வந்துட்டோம், அந்த ரிப்போர்ட் காமிக்கணும். ரிப்போர்ட் காமிக்கவும் முடியாது, அதுக்கும் ஒரு 1.5 மாதம் கழிச்சு வா. இப்படியாக அந்த டாக்டரை மட்டும் 3 முறை சந்திச்சிருக்கோம். அந்த 3 முறை எங்களுக்கு 7 மாதம் ஆச்சு. அவ்வளவு பிஸி அவங்க. நான் அதை குறை சொல்லலை, அவங்கள பிஸி. ஆனால் ஒவ்வொரு முறையும் எங்களுக்கு 3 மணி நேரம் 2 மணி நேரம் காத்திருக்கிற மாதிரி தான் இருந்துச்சு. இது எங்களுக்கு அப்புறம் இதுக்கு ஒரு மாதிரி எங்களுக்கு ஒரு மாதிரி பெயின் ஆகிட்டே இருந்துச்சு. ஏன்னா அங்கே போயிட்டு வர்ற அன்னைக்கெல்லாம் இன்னும் தூங்காமல் போகிறான். என்ன ஒரு குட்டி இடத்துக்குள்ளே உட்கார வச்சுக்கிட்டு அவனை ஓடக்கூடாது, நிற்கக்கூடாது, என் பயம் ஏதாவது சொல்லிடுவான் இல்லை டாக்டர்கள் அப்படிங்கலாம் பிடிச்சி அமைக்க வச்சுட்டே இருக்கும். முடியவே இல்லை. அந்த சமயத்தில் தான் புதுயுகம் சேனல்லேருந்து புதிய தலைமுறையிலேருந்து ஒரு வீடியோ விளாகிங் எடுத்தாங்க. அப்போது அங்கேருந்து ஒரு ப்ரொடியூசர் டீம் சொன்னாங்க, டாக்டர் தேவகின்னு ஒருத்தங்க இருக்காங்க, அவங்க பையனுக்கு ஆட்டிசம், நீங்கள் அவனை போய் பார்க்கக்கூடாது, அவங்கள போய் பார்க்கக்கூடாதுன்னு கேட்டாங்க. அப்படி டாக்டர் தேவகிட்ட அப்பாயின்மெண்ட் வாங்கி வந்து பார்த்தேன். அவங்க 5 மணி கொடுத்தாங்க. நாங்கள் 4:50 போனோம். உள்ளே போன உடனே வான்னு கூப்பிட்டு உட்கார வச்சிட்டாங்க. வாழ்க்கையில் கடவுளை பார்க்குற மாதிரி இருந்துச்சு. ஏப்பா என்னடா இது 10 நிமிஷம் முன்னாடி போனோடனே வான்னு சொல்லிட்டாங்க அப்படின்னு. இல்லைப்பா நான் எப்போதுமே ஒரு பேஷண்ட்டுக்கு டைம் கொடுத்தா முன்னாடி ஒரு 1/2 மணி நேரம் ஃப்ரீயாக வச்சுக்கிறேன்னு சொன்னாங்க. எனக்கு பெரிய ஆச்சரியமாக இருந்துச்சு. ஆகா இப்படி ஒரு டாக்டர் கிடைப்பாங்களா அப்படின்னு. அப்புறம் தான் ஆட்டிசம்னா என்ன, ஆட்டிசம் எப்படி இருக்கும் அப்படிங்கிற எல்லா விஷயத்தையும் சொன்னாங்க. இது ஒரு லைஃப் டைம் கண்டிஷன் அப்படின்னு அவங்க சொல்லும்போது எல்லாரை போல எனக்கும் ஒரு பெயின் இருந்தது. ஏன்னா எனக்கு ஒரு கனவு இருந்தது, என் குழந்தை என்னை அடிக்கக்கூடாது, என் குழந்தை தானே கற்றுக்கிட்டு வரணும்னு. ஆனால் நகைமுறை என்னென்னா எல்லா விஷயத்தையும் என் குழந்தைக்கு கற்றுக் கொடுக்குற மாதிரி காலம் என்னை கொண்டு வந்து வச்சிச்சு. எல்லாம் ஈவன் சட்டை பட்டன் போடுறது, பாட்டில் திறந்து தண்ணி குடிக்கிற வரைக்கும் எல்லாத்தையும் சொல்லி கொடுக்குற மாதிரி என்னை காலம் கொண்டு வந்து விட்டுச்சு. எங்களுக்கு டாக்டர் தேவகி கொடுத்த தைரியம் இருக்குல்ல, அது ஒரு பெரிய தைரியம். அதன் தொடர்ச்சியாக எங்களுக்கு நல்ல ஒரு தெரபிஸ்ட் அமைஞ்சாங்க. அவங்க எங்களுக்கு அவங்களுடைய புக்குகள் கொடுத்தாங்க, படிக்க கொடுத்தாங்க. டாக்டர் தேவகி நிறைய படிக்க சொன்னாங்க, இது குறித்து நிறைய படி அப்படின்னு சொன்னாங்க. நானும் என் மனைவியும் தொடர்ச்சியாக படிக்க ஆரம்பித்தோம். அப்புறம் சில அடிப்படையான விதிமுறைகளை நானும் என் மனைவியும் உட்காந்து பேசி வகுத்துக்கிட்டோம். ஒரு 4 விதிகள் இருந்தால் நல்லா இருக்கும் அப்படின்னு நாங்கள் வகுத்துக்கிட்டோம். அதில் முதல் வகுத்துக்கிட்டது ஏற்றுக்கொள்வது அப்படின்னு விஷயம், 2வது கற்றுக்கொள்வது, 3வது புரிந்து கொள்வது, 4வது போராடுவது. இது ஒவ்வொரு பெற்றோரும் செய்யணும் அப்படின்னு நாங்கள் அதில் முடிவெடுத்தோம். எங்களுடைய அனுபவத்திலிருந்து நான் அதை சொல்கிறேன். ஏற்றுக்கொள்வது அப்படின்னா என் குழந்தையோ அதோடைய நிறை குறையோடைய ஏற்றுக்கிறது. இந்த பேர் குரூப் ப்ரெஷர் இருக்கா, அந்த பிள்ளை செய்யுதே என் பிள்ளை செய்யலே, இந்த பிள்ளை செய்யுதே என் பிள்ளை செய்யலேங்கிறதுலாம் இல்லை. என் பிள்ளைக்கு என்ன செய்ய வருதோ அதை அவன் செய்யட்டும், அவன் மெதுவாக கூட செய்யட்டும், ஒரு அவசரமும் இல்லை. ஆனால் நான் அவனை இம்மி விடாமல் கண்காணித்து கொண்டே இருப்பேன் அப்படின்னு நாங்கள் முடிவெடுத்தோம். அவனுடைய ஒவ்வொரு சின்ன மாற்றம், அவன் முகத்தில் ஒரு சின்ன மாற்றம், அவன் கை காலில் ஒரு சின்ன மாற்றம் வந்தால் கூட ஏன் என்ன காரணம், என்ன அசௌகரியமாக இருக்காங்க, அங்கே என்ன டிஸ்டர்ப் ஆகுறான் அப்படின்னு உடனடியாக நாங்கள் பார்க்க ஆரம்பித்தோம். ஏன்னா அவனுக்கு பேச வராது, பேச தெரியாத பிள்ளை. முதல்ல எறும்பு கடிச்சானா இப்படி நெளிவான், ஏன் சும்மா நெளிகிறான், டக்குன்னு உடனே சட்டையை தூக்கிப்பாரு அப்படின்னு பார்க்க ஆரம்பித்தோம். இப்படியே அவனை தொடர்ந்து கவனிக்க ஆரம்பித்தோம். இதுக்கு நாங்கள் ஒரு இடத்துலையும் கூச்சப்படுறதே அவமானப்படவோ கூடாதுன்னு முடிவெடுத்தோம். என் குழந்தை அது நாங்கள் பெற்ற குழந்தை, அவன் எப்படி இருக்கானோ அப்படி இருக்கான், அப்படியே ஏற்றுக்கிறோம். அதனால தைரியமாக நாங்கள் பொது இடங்களுக்கு என் குழந்தையை அழைத்து கொண்டு போக ஆரம்பித்தோம். கோவில், குளம், கல்யாணம், லொட்டு லொசுக்கு எல்லா இடத்துக்கும் கூட்டு போக ஆரம்பித்தோம். அடுத்து கற்றுக்கொள்வது, டாக்டர் தேவகி எங்களுக்கு வழிகாட்டின மாதிரி தொடர்ச்சியாக கற்றுக்கொண்டே இருப்பது. கற்றது கைமண் அளவுன்னு சொல்லுவாங்க இல்லையா, நீ என்ன இலக்கியம் படித்தாலும், என்ன பொலிட்டிக்கல் சயின்ஸ் என்ன வேணாலும் படிச்சுட்டு வா, ஆனால் இந்த உலகம் என்பது வேறு, இந்த உலகத்தை நீ புரிந்து கொள்ள வேண்டும். இன்னும் சொல்ல போனால் நான் தைரியமாக இன்னைக்கு என் குழந்தைக்கு 17 வயது, நான் அடித்து சொல்ல முடியும், ஒரு மருத்துவரை விட ஒரு பெற்றோருக்குத்தான் ஆட்டிச குழந்தையை பற்றி அதிகம் தெரிகிறது. ஏன்னா 24/7 அவன் இருக்கான் கூட. அதனால அவங்களுக்கு நிறைய விஷயங்கள் தெரியும்னு பார்த்து சென்னையில் பெற்றோர் மீட்டுகளை நான் ஏற்பாடு பண்ணேன், பெற்றோர் ஒருங்கிணைக்கிறதுக்கான கூட்டங்களை ஏற்பாடு பண்ணேன். புரிந்து கொள்வது, நம் குழந்தைகளோட ஒவ்வொரு நொடியும் மனதால் பின்தொடர்வது, நான் ஆரம்பத்தில் சொன்ன மாதிரி. அப்படி இருக்கும்போது தான் அந்த குழந்தையோட செய்கை என்ன, அவன் எண்ணத்தில் சங்கடப்படுறான், எண்ணத்தில் சிக்கலாகிறாங்கிறத உடனடியாக உணர்ந்து கொள்ள முடியும் அப்படின்னு. ஏன்னா இங்கே நாங்கள் 2 பேரும் கண்டுபிடிச்ச ஒரு விஷயம், அது ஏற்கனவே யாராவது சொல்லியிருக்கலாம், பட் எங்கள் அனுபவத்தில் நாங்கள் கண்டுபிடிச்ச விஷயம் என்னென்னா, எந்த இடத்தில் ஒரு ஆட்டிசம் உள்ள குழந்தைக்கு பிஹேவியர் இஷ்யூ வருது அப்படின்னா அது லாங்குவேஜ் லேக்னால வருது. அவனால் தான் நினைக்கிறதை சொல்ல முடியாத போது தன்னுடைய கோபத்தை, தன் ஆற்றாமையை எப்படி வெளிப்படுத்துகிறான்னா கோபமாக வெளிப்படுறான். நான் தொடர்ச்சியாக பார்க்குறேன். என் குழந்தைய நான் இது வரைக்கும் அடித்ததில்லைன்னு சொன்னேன் இல்லையா? என் பிள்ளை இது வரைக்கும் யாரையுமே அடித்ததில்லை. நான் இது கண் கூட பார்க்குறேன். எந்த தாயோ தகப்பனோ தன் குழந்தையை அடிக்கிறாங்களோ அப்போ அந்த குழந்தை என்ன நினைக்குதுன்னா, எஸ் உனக்கு பிடிக்காத நான் செஞ்சா நீ அடிக்கிறீல்ல, எனக்கு பிடிக்காத நீ செய்கிற நானும் உன்னை அடிப்பேன். அவ்வளோதான் விஷயம். குழந்தை அப்படி தான் ஈஸியாக எடுத்துக்கிறது, நம்மகிட்ட அது லேர்ன் பண்ணிக்குது அப்படின்னு நாங்கள் உணர்ந்தோம். அதனால் நாங்கள் குழந்தைய ஒவ்வொரு விஷயத்துலையும் புரிந்து கொள்ள முயற்சி பண்ணோம். எங்கே என் குழந்தைக்கு லாங்குவேஜில் பிரச்சனை இருக்குன்னு முடிவு பண்ணோமோ அதான் பிஹேவியர் இஷ்யூன்னு நாங்கள் உணர்ந்துக்க முடிச்சு பண்ணோம். ரெண்டாவது, இன்னும் அதிகமாக விழிப்புணர்வை அடையாத நம் நாட்டுச்சூழலில் உறவினர்கள், அக்கம் பக்கத்தினர், பயிற்சியாளர்கள் எல்லா தரப்புலையும் குழந்தைகளுக்கான உரிமையை பேசுவதுன்னு முடிவெடுத்தோம். ஏன்னா இன்னைக்கு டிசைனா நான் ஆட்டிசத்துக்கு மருந்து கண்டுபிடிக்கிறேன்னு கிளம்பி வர்றான். அது ஏகப்பட்ட பேர் சொல்கிறான். நான் அப்படி 10 அடி தூரத்துலேருந்து இப்படி கையை காமிச்சே நான் ரெடி பண்ணுவேங்கிறான் ஒருத்தன் நான் பொடி அரைச்சி மூக்கு வழியாக விடுவேங்கிறான். ஒருத்தன் தலைகீழாக தொங்க போட்டு ஆயிலுக்குள்ளே முக்கி எடுக்கலாம்ங்கிறான். அப்படி விதவிதமாக அவன் கற்பனையை பூரா கொண்டு நம்ம பிள்ளையை எளியாக மாற்றி நான் மருந்து கண்டுபிடிக்கிறேங்கிறான். நான் பல இடங்களுக்கு குழந்தையை கூட்டிகிட்டு போய் சரியாகமான்னு அலைஞ்சவன். எதுலேயும் ஒரு இம்மி கூட முன்னேற்றம் இல்லை. பயிற்சிகளின் வழியாகத்தான் என் குழந்தை மேம்பட்டு வந்திருக்கிறான். அதுதான் நிஜம். அதே மாதிரி இங்கே இன்னொரு விஷயம் என்னென்னா, இந்த நான் வைக்கிற இங்கே என்னுடைய கோரிக்கையாக இதை நீங்கள் எடுத்துக்கலாம். ஒரு பெற்றோரின் வழியிலேருந்து இந்த கோரிக்கை வருது அப்படிங்கிறத நீங்கள் உணர்ந்துக்கிறீங்க நம்புகிறேன். மருத்துவர்களிடம் நான் வைக்கிற கோரிக்கையாக இந்த வாய்ப்பை நான் பயன்படுத்திக்கிறேன். நீங்கள் ஆட்டிசம் குழந்தைகளுக்கு, இன்டெலெக்சுவல் டிசபிலிட்டி இருக்கக்கூடிய குழந்தைகளுக்கு நீங்கள் ஒரு அப்பாயின்மெண்ட் கொடுத்தீங்கன்னா 90%, 99% அதே நேரத்தில் அவர்களை சந்திக்கிறதுக்கு கொஞ்சம் மெனக்கெடுங்க, கொஞ்சம் கருணையோடு நடந்துக்குங்க, பரிவோடு நடந்துக்குங்க அப்படிங்கிறத கேட்குறேன். அதற்கு அடுத்ததாக, எந்த வயது குழந்தையாக இருந்தாலும் சரி, இப்போ ஆட்டிசத்துக்காக வரல, நீங்கள் ஒரு சாதாரண ஒரு பீடியாட்ரிஷனாக இருக்கீங்க, ஒரு குழந்தை நல்ல மருத்துவராக இருக்கீங்க, வேறு ஒரு டாக்டராக இருக்கீங்க, தலைவலி, காய்ச்சல், ஜுரம் எதுக்கோ ஒன்று வருது, அந்த குழந்தைக்கு ஒரு 10 வயசு இருக்குது. அந்த பேரண்ட்ஸ் நீங்கள் கூட்டு வரும்போது உங்களுக்கு தெரிஞ்சிடும் அந்த குழந்தைக்கு ஆட்டிசம்னு. என்னப்பா பிரச்சனை? ஆட்டிசமா? ஓகே, இப்போ என்ன வயசு? 10 வயசு. ரைட். இனி டீனேஜுக்குள்ளே போகும்போது என்ன மாதிரி இஷ்யூஸ் அந்த குழந்தைய சந்திக்குங்கிற அந்த பெற்றோருக்கு நீங்கள் கைட் பண்ணுங்கள். ஏன்னா உங்களுக்கு தான் அது தெரியும். நீங்கள் தான் அந்த குழந்தைய அலாட் பண்ண முடியும், அந்த பேரண்ட்ஸ் அலாட் பண்ண முடியும். அது தெரியாத விஷயங்கள் தான் பெற்றோர் இன்னும் பயத்தில் இருக்கான். இன்றைக்கி மாஸ்டர்பேஷன் செய்கிறது அப்படின்னு இன்றைக்கி இந்த கூடிய அறைக்குள்ளே பேசுகிறோம் இல்லையா? நான் ஓப்பனாக பல பெற்றோர் மீட்டிங்கில் போய் பேசுகிறப்ப எல்லா பேரும் என்னை எரிக்கிற மாதிரியே பார்த்தான். என்ன இதெல்லாம் பேசிக்கிட்டு இருக்கான் இவன் அப்படின்னு. அப்போ என் குழந்தைக்கு வெறும் 7 வயசு தான். ஆனால் நான் படித்ததுலேருந்து நான் அப்போவே பேச ஆரம்பித்தேன். கொல்ல பேர் நீ சேர்த்துக்கவே இல்லை, இப்படிலாம் பேசிக்கிட்டு இருக்கீங்களே நியாயமாக சாருதுங்கிட்டான். நீ பேசணுண்டாத குழந்தைக்கு, உனக்கு அறிவு இருக்குது, உன் குழந்தைக்கு தெரியாதுல்ல. குழந்தைக்கு எது சரி எது தப்புன்னு எப்படி தெரியும்? அவன் வேறு ஒரு உலகத்தில் வாழ்கிறான். அவனுக்கு இந்த விஷயங்களை பற்றி பெற்றோர் நீ உணரலைன்னா அவனுக்கு நீ அடக்க முயற்சி பண்ணணும். அடக்கம் வந்து அது கோபமாக மாறும். அப்போ இதை யார் சொல்லிக் கொடுக்கணும்? இன்னொரு மருத்துவர் சொல்லிக் கொடுங்க. அப்போ உங்களிடம் வரக்கூடிய எந்த வயதுக்கான குழந்தையாக இருந்தாலும் சரி, அது வேறு காரணத்துக்காக வந்தாலும் சரி, உங்களுடைய மருத்துவ அறிவை அந்த குழந்தைகளுக்கு நீங்கள் பயன்படுத்தி இதை இந்த பெற்றோருக்கு நீங்கள் வழிகாட்டுங்க. இது இந்த மாதிரி இஷ்யூ நாளைக்கு வரலாம், இப்படி நீங்கள் கவனிங்க அப்படிங்கிறத நீங்கள் அதை சொல்லிக் கொடுக்கணுங்கிற ஒரு வேண்டுகோளை இங்கே வச்சுக்கிறேன். ஆமாம், நேரம் முடிஞ்சு போச்சு. ஆனால் ஒரு பெரிய காமெடி என்னென்னா, மொத்தமே 45 நிமிஷம் இந்த செஷனுடைய நேரம். எங்களுக்கு 10 நிமிஷம் லேட்டாக தான் மைக்கே வந்துச்சு. எனக்கு இல்லை, தேவகி அக்காக்கே 10 நிமிஷம் லேட்டாக தான் வந்துச்சு. ஓகேவா? ஓட் ஆஃப் தேங்க்ஸில் முன்னாடியே போயிடுச்சு அந்த 10 நிமிஷம். அந்த 10 நிமிஷத்தை நான் இப்போ சேர்த்து எடுத்துக்கிறேன், வேறு ஒன்றும் இல்லை. ஆமாம். அதே மாதிரி ரொம்ப முக்கியமாக நீங்கள் எந்த ஒரு சந்தர்ப்பத்திலையும் தயங்காமல் சொல்ல வேண்டிய ஒரு விஷயமாக நான் நினைக்கிறேன். இன்னைக்கு தேதி வரைக்கும், இன்றைய அப் டு டேட், இன்றைய நாள் வரை ஆட்டிசத்தை குணமாக்க மருந்துகள் இல்லை. ஓகேவா? அதை நீங்கள் உங்கள் பேஷண்ட்டை எந்த வயசுக்கு வந்தாலும் நீங்கள் சொல்லிடுங்க. முதல்ல குட்டி குழந்தைகளை கூட்டு வரும்போதே சொல்லிடுங்க, இது லைஃப் டைம் கண்டிஷன்ப்பா, இதை குணப்படுத்த முடியாதுன்னு. ஏன்னா அப்படி சொல்லாததோடைய விளைவு என்ன ஆகுதுன்னா, உடனடியாக அவன் இன்னொரு மருத்துவரை போய் பார்க்குறான், இன்னொரு ஜோசியத்தை பார்க்குறான், வெளியில் நாக்கு பண்ணி போடுறேங்கிறான், தலையில் கோவிலை சுற்றுறேங்கிறான், இப்படி கிளம்பி போய்கிட்டே இருக்கான். அதில் டிலே ஆகி நான் 1.5 வயசில் ஆரம்பித்தேன் இல்லையா, என்னுடைய ஜேர்னி 1.5 வயசுலேயே தெரப்பி ஆரம்பிச்சிட்டேன். நான் என்னோட சக பேரண்டாக வர்ற அத்தனை பேருமே 3 வயசு, 3.25 வயசு, 4 வயசுல தான் வந்தாங்க. என்னடா கேட்டால் 2.5 வயசில் சொன்னாங்க சார், ஆனாலும் பாருங்கள் நாங்கள் அங்கே ஒரு சித்தர் இருக்காருன்னு சொன்னாங்க, நாங்கள் அவர்கிட்ட போயிட்டு வந்தோன்னு கிளம்பி வர்றான். ஒரு 3 வருஷத்தை லேட் பண்ணிடுறான், டிலே பண்ணிடுறான். அது அந்த குழந்தையின் இவனுடைய ஒவ்வொரு நாள் டிலே என்பது குழந்தையின் 1 வருடத்தை இன்னும் பின்னோக்கி தள்ளுதுங்கிறத பெற்றோர் உணர்றதில்லை. அதை மருத்துவர்கள் உணர்ந்து, அது எந்த சூழல்லையும் ஆட்டிச குழந்தைகள் பார்த்தால், தம்பிகளா அம்மாக்களா இங்கே வாங்க, இது ஆட்டிசம்னு இதுக்கு பேர், இதுக்கு வேறு மருந்தெல்லாம் கிடையாது, உலகத்தில் இது வரைக்கும் இல்லை, இது ஏதோ தமிழ்நாட்டில் சென்னையில் மட்டும் இருக்கிறது இல்லை, மதுரையில் மட்டும் இருக்கிறது இல்லை, உலகம் முழுக்க இருக்கிறது. இதை லைஃப் டைமாக அவனை மேம்படுத்தலாம், அதற்கு பயிற்சிகள் உங்களுக்கு இருக்கும், மருத்துவர்கள் துணை நிற்போன்னு அந்த தைரியத்தை கொடுங்க. மருந்து மாத்திரை பின்னாடி குணமாக்குறதுக்கு ஓடாதீங்க. ஜுரம் வந்தால் மருந்து கொடுக்கலாம், எனக்கு ஜுரமா என் பிள்ளைக்கும் ஜுரம் மருந்து கொடுக்கலாம், வகுத்த வழியா மருந்து கொடுக்கலாம், தலைவலியா மருந்து கொடுக்கலாம். இப்படி எல்லாருக்கும் வரக்கூடிய எல்லா நோய்களுக்குமான மருந்துகளை வழியாக அவனை மேம்படுத்தலாம் ஒழியே பர்டிகுலராக ஆட்டிசத்தை மேம்படுத்த மருந்து அப்படிங்கிறது இங்கே இல்லை அப்படிங்கிறத சொல்லுங்க. எந்த வயது பெற்றோருக்கும் வழிகாட்டுங்கிற வேண்டி கோரிக்கையை வச்சுக்கிட்டு வாய்ப்புக்கு நன்றி கூறுகிறேன்.
எஸ் தேவி மேடம் ஃபைனல்.
நான் சொல்லணும்னு நினச்சதான் பாலா சொல்லிட்டாரு, ரொம்ப நன்றி. அதை மிஸ் பண்ணிட்டேன். அப்புறம் என்கிட்ட வந்து கத்துவான், அக்கா நீங்கள் சொல்லவே இல்லை, ஆட்டிசம் இஸ் நாட் அ டிசீஸ்ன்னு எத்தனை வாட்டி உங்ககிட்ட சொல்ல சொன்னேன், நீங்கள் சொல்லலைன்னு வயசாதுரா மறந்து போச்சு. ஓகே, நீ சொல்லிட்ட, ரொம்ப சந்தோஷம். ஐ வுட் சஜஸ்ட் யூ டு ரீட் சம் புக்ஸ் ரிட்டன் பை பேரண்ட்ஸ். அந்த பேரண்ட், இப்போ நாங்கள்லாம் புக்கெல்லாம் எழுதலை, பாலா நிறைய புக் எழுதியிருக்காரு. பேரண்டல் ஜேர்னி பற்றி நிறைய பேரண்ட்ஸ் புக்ஸ் எழுதியிருக்காங்க. ஜலஜா நாராயணன், From a Mother's Heart, 10 Things an Autistic Child Wants You to Know by Veronica Zisk, அப்புறம் டெம்பிள் கிராண்டன், எழுதா பயணம் பை லக்ஷ்மி பாலகிருஷ்ணன், ஆட்டிசம் சில புரிதல்கள் பை பாலபாரதி, அதையும் புக்கை நான் தான் ரிலீஸ் பண்ணேன். ஸோ இது எல்லாமே நீங்கள் இது பண்ணுங்கள். ஒன்று நான் சொல்லிக்கணும், சச்சினுடைய ஸ்டோரியை புதிய தலைமுறையில் பாலாவும் ஒரு டீம், அப்படி தான் பாலா எனக்கு பழக்கமானார். சச்சினோட ஸ்டோரியை புதிய தலைமுறையில் புது யுகம்ங்கிற ஒரு சேனலில் ஒரு ஸ்டோரியாக எடுத்து அதை விஷுவலாக காமிச்சிருக்காங்க. அந்த விஷயத்தை நான் சொல்லணும்னு நினச்சேன், மறந்துட்டேன். அப்படி தான் எனக்கு பாலாவை தெரிய வந்துச்சு. தேங்க்யூ ஃபார் திஸ் ஆப்பர்ச்சுனிட்டி அண்ட் வி ஆர் ஆல்வேஸ் வில்லிங் டு ஹெல்ப் யூ ஃப்ரம் அ பேரண்ட்ஸ் பெர்ஸ்பெக்டிவ். உங்கள் பேரண்ட்ஸ்க்கு ஏதாவது கஷ்டங்கள் இதுதான், டோன்ட் வரி, there is a parent here with some experiences like me, Mr. Sudan and Bala and many other parents too.
Thank you, Dr. Devaki. Parents' perspective, I think both of them have elaborated. Center of Excellence Autism, we are doing many things. One thing I think not said enough. Top practitioners, doctors, therapists, இவங்களுடைய வியூ பாயிண்ட்ஸ் எல்லாமே வந்து வெபினார் மூலமாக எவ்ரி சாட்டர்டே வந்து ப்ரெசென்ட் பண்ணப்படுது. அண்ட் ஐ திங்க் மோர் தென் 200 people வாட்ச் தோஸ் வெபினார்ஸ். அது எல்லாமே கண்டென்ஸ் பண்ணி ரொம்ப அழகாக தமிழில், சிம்பிள் தமிழில் புக்லெட்டை வந்து போட ஆரம்பிச்சிட்டோம். அவுட் ஆஃப் சம் 53 வெபினார்ஸ் so far held, சம் 30 வெபினார்ஸை வந்து பிரமாதமாக பண்ணிட்டாங்க. லீகல் ரைட்ஸ், ஃபினான்ஸ் எப்படி பிளான் பண்ணணும், மெல்டவுன் எப்படி ஹேண்டில் பண்ணுறது, எல்லாமே த எக்ஸ்பர்ட்ஸ் ஃப்ரம் தோஸ் ரெஸ்பெக்டிவ் ஃபீல்ட்ஸ் அவங்க சொன்னது எல்லாத்தையுமே வந்து கன்சாலிடேட் பண்ணி we are going to publish. I would request my team, இதோடைய டிஜிட்டல் காப்பீஸ்லாம் கேன் பி சர்வ்டு to all the participants here. Once again, thank you. It is a fantastic event. Parents' perspective ரொம்ப ரொம்ப முக்கியம். I think that is going to give life to all our initiatives. Thank you.
Thank you, Sudan sir. Thank you, Dr. Devaki and Mr. Balabharati, for sharing such a personal and moving journey with us. I invite our Chief Executive Officer, Sudan sir, to felicitate Mr. Balabharati and Dr. Devaki. Thank you, ma'am, sir. For our third session, I invite the chairperson, Dr. Shanti Nambi, Professor and Head, Department of Psychiatry, Savita Medical College. Dr. Shanti Nambi will be inviting Dr. Venkateshwaran and Dr. S. Neelakandan to give their talks in this session. The session is on pharmacotherapy on ASD and sexuality in autism.
Good afternoon, everybody. My deep sense of gratitude to Rama Madam for having given us this opportunity, and also my gratitude to the Department of Child and Adolescent Psychiatry, Government Institute of Child Health, where we developed deep insights into this complex neurodevelopmental spectrum disorder, and also happy to have been a member of the formation of the Center of Autism in the Institute. So the first speaker will be Dr. Venkateshwaran. I please call upon Dr. Venkateshwaran. Just to be very brief, the goal of pharmacotherapy in autism is to maximize the developmental potential and to try to achieve maximum independence possible. But it's practically not always feasible. So there are specific therapeutic interventions that are available for certain deficits in the disorder, for stereotypy, for repetitive behavior, for irritability, and for aggression. As mentioned earlier, Dr. Shobha Srinath had mentioned, and even our parents and Dr. Devaki Madam had mentioned, that there are no specific pharmacotherapeutic interventions for the core symptoms of autism. Though memantine has been tried, D-cycloserine has been tried, intranasal 24 IUBD has been tried, but none of them really works. But there are 2 FDA-approved drugs that can be used for irritability and for aggression. The antipsychotics, risperidone and aripiprazole, really does help in bringing down the irritability. Mood stabilizers are available for controlling the mood fluctuations. Antidepressants are available for controlling the anxiety, as well as the social anxiety that we see in children. But the core point here must be that each child, the treatment has to be tailor-made. And as Devaki Madam told in the morning, sorry, pharmacotherapy does help certain children, but it does not help other children. We have to tailor-make and adjust the dose, start with a minimal dosage. For example, risperidone can be given only up to maximum dosage of 2.9 milligram per day. And similarly, it has to be withdrawn and tapered off, because we still see adults who are on quite a few psychotropics. So this is a very tough area, and Dr. Venkateshwaran will be talking about all these issues.
Okay, sure. Thank you. Good afternoon, everyone. I really thank Rima ma'am and the organizers for this wonderful opportunity, and Shanti Nambi ma'am. I think I was scared like she's going to complete the full speech.
I was very brief, but...
Sure. So as everybody says, the disease burden is quite high. The current CDC says 1 in 36. So it's a non-clinical population. We are seeing much more children with spectrum. And as everybody mentioned, there is no medications for the core symptoms. So we are going to talk about only comorbid conditions. So, but these comorbid conditions, we cannot just palm away, these are just comorbid conditions. Sometimes this comorbid condition causes significant impact, okay, in the day-to-day functioning of the children with autism, and it can cause significant caregiver burden, leading to lots of like emotional distress for the child as well as parents. So we cannot ignore comorbid conditions. So basic principle, before moving into main comorbids, like we'll just see the basic principles. So start low and go slow. So this is applicable to any child psychiatric prescription. So like even if you can start with slightly lesser than the standard dose, that would be better, because some children are prone for side effects and this will always helps. and monitoring matters. These children, as previous speakers mentioned, like these children are mostly non-verbal. Many of them are verbal as well, but there are children who cannot effectively communicate their side effects. So, like if we don't monitor side effects precisely, then you may end up with worsening of behavior problem due to side effects rather than the problem per se. So here the monitoring is one important thing. And one size doesn't fit all. Okay, for example, take an example, you have to prescribe lithium. Okay, here is an adolescent autism, you are suspecting mood disorder and you are starting on lithium. But if the child is going to make big hue and cry for a blood sample, and you have to take blood sample every 2 weeks, so starting the child on lithium is going to make the matter worse rather than helping the child. So here it has to be tailor-made, because you can give lithium for that condition. In this situation, if you start, it is not going to help you. So it should be tailor-made for that child based on the side effects, based on the BMI, based on the weight, etc. So you have to really choose that appropriate medicine. And back to the basics. Before starting any medicine, like basically you have to screen for other medical and psychiatric conditions presenting with the behavior problems. Okay, sometimes GERD can present as behavior problem. Sometimes insomnia per se present as behavior problem. Sometimes a whole lot of medical and new onset psychiatric syndromes can present as behavior problem. If you could pick up like your choice of pharmacotherapy may be like very simple and you can avoid polypharmacy. So these principles are very important before starting any medications. So these are the headings we will see. So we'll go to irritability. So irritability is a roof term, okay? So it can, sometimes we call tantrums as irritability, self-injurious behavior as irritability, aggression as irritability. Sometimes irritability can be part of psychiatric syndrome. So irritability is a broad term that refers to these set of conditions. So this is load of irritability is quite high. If you read through the slides, almost 1 in 2 children can have irritability in ASD at some point of their life. And 1 in 3 can have severe irritability leading to that may require intervention. So the burden of irritability is quite high. So before starting medications, so you have to keep these checklists in mind. Okay, whether the irritability is due to medical problem like reflex, or sometimes insomnia itself can cause present as irritability, or any other gastric conditions like constipation, which is very common in autism, whether that is presenting as irritability. So once you rolled out medical problem, whether it is due to communication challenges as well as maladaptive reinforcement pattern. So these two combine and produce irritability a lot. Poor communication with the child and maladaptive reinforcement from the parent side. These two can combine and produce irritability, whether it is due to that or any recent psychosocial stressor in the family presenting as irritability. Lastly, psychiatric syndrome. Once you have these checklists in mind, once you rule out these things, almost we cannot thoroughly rule out. At least you have considered these things. Then probably go on to start on pharmacotherapy. So imagine this circuit. So thanks to ChatGPT I have created. So this circuit in mind. See, if you see this side. This is a hero, amygdala. Okay, so sorry, I'm not able to. You all know amygdala. So the amygdala is a hero, and there are two regulators. One is prefrontal cortex that reduces impulses. Another is anterior cingulate cortex that regulates emotions. So here, naturally, this imbalance is tilted in ASD. So the amygdala will be overactive, and there is less prefrontal control and less regulation from ACC. This is a natural thing that exists in ASD. So what happens post this, the hypothalamus? So this one, that is after response. Once this is triggered, the stress response is also exaggerated. So the control is less, the one who is reacting is more reacting, and the after response is also high. In this background, so if you see the other side, the insula and striatum, so what it does? The insula is something called sensory modulator. Okay, so sensory is not wrapping with cloth alone. The sensory is different from what has been assumed as sensory. Means like, for example, if somebody talking to an 8-year-old child, the autism children sometimes may receive as hypersensory input. Okay, sometimes it may be a threatening input. So even a natural sensory input can be sometimes threatening to them. Okay, and this striatum, this striatum, which over the time results in restricted behavior, rigid repetitive behavior. So they learn over the time. What we are doing? This is the domain for non-pharmacological technique. For example, if you don't give the appropriate sensory environment to the children with autism, and if you are going to challenge this rigid repetitive behavior, naturally what happens? The amygdala sitting here is going to overreact and the control is lost. Overall, it results in significant irritability. Okay, so this is the area where you can work as a non-pharmacological thing, modulating sensory environment and handling the rigid repetitive behavior through non-pharmacological techniques. If it is not working, if the irritability is very severe, you can go for pharmacotherapy, like Madam was telling, risperidone and aripiprazole as the FDA-approved medication. By modulating these on the other side, by modulating these neurotransmitters that basically work in this side pathway, that is mesolimbic pathway, so that the irritability is decreased. So this is what happens inside the brain of children with autism with irritability. Okay. So risperidone start, if it is less than 20 milligrams, start with 0.25. If it is more than 20.5. See, for pediatrician, I am telling you can go up to 2 milligrams safely. If you are going to go above this, probably refer to a psychiatrist. You can go up to 8 milligram, but if it is not working with a small dose, 1 to 2 milligram, probably make the referral at that point. Okay. Usual effective dose is up to 2 milligram. The next is aripiprazole. It is FDA approved above 6 years. Again, start with 2 and go up to 5. If you have to use more than 5, probably make an appropriate referral, okay, at that point. Because going above, like, you might find it a little hard to manage, when to stop and when to increase, so that will be a little difficult. So the mechanism is little different. One is dopamine antagonist, one is dopamine partial agonist. So here the difference is, I'm not going into theory. See, if you read the literature, the aripiprazole will be portrayed as some guardian angel. So aripiprazole is safe in terms of weight gain, aripiprazole is safe in terms of EPS, aripiprazole is safe in terms of this, that. But imagine it all doesn't work for children. Sometimes aripiprazole can also cause severe EPS. I have seen severe dystonia with aripiprazole after starting even a small dose. And aripiprazole, many a times, 1 out of 3 children can cause significant weight gain, even though it doesn't cause us increase in lipids, even though it doesn't cause us increase in blood sugar like risperidone do. Aripiprazole do cause significant weight gain. So we have to keep in mind. So if you read the literature, like aripiprazole will be projected as a hero and risperidone is projected as villain. But in real life, there is no hero and villain. Okay, each one has his own plus and minus. So whichever comfortable you can start first. If you are like the child is not tolerating, probably go to the other drug. So that will be a more practical approach in this scenario. So monitoring, so you have to monitor baseline BMI, vitals, and blood sugar monitoring. How frequently you can monitor? Like you can do the baseline BMI, weight, height at first month, then 1 month, 3 month, and yearly onwards if the child is stable. For blood parameters like lipids, sugar, etc., you can start at baseline 3 months and then yearly if it is stable. If it is increasing, probably more frequent monitoring, because different guidelines say different thing. So it is an overall more pragmatic approach where you won't like end up with dyslipidemia or increased sugar due to the medication treatment. And prolactin, if you are starting on risperidone, probably monitor yearly. If the symptomatic, monitor more frequently, like galactorrhea, enlarged breast nodules, or menstrual abnormalities in female children. Probably you have to monitor prolactin more frequently. And duration of treatment. This is a big area, gray area. Sometimes, like how long to treat for irritability. So if you are starting, like review every 3 to 6 months whether the child is stable. If 3 to 6 months stable, then taper down over another 6 months to 1 year. Because nowadays more and more even Maudsley guidelines are telling the slow you taper, better the chance that the child don't relapse. So taper very slowly. And if the child is doing well with tapering, probably we can go off the medicines. But many a times, practically, when you start tapering, the child may relapse with irritability, and sometimes you may end up giving even long-term, even lifelong. Okay, so general rule is 3 to 6 months. Once the child is stable, consider tapering. Discuss with the family. So start with the minimal effective dose, titrate slowly, monitor metabolic side effects, and have a decision making with the family. Okay, previously, like doctors used to be little autocratic, but nowadays we have to discuss with the family, and it is a combined decision making rather than you imposing your opinion on them. So, rough chart, see, guanafacin is not available here in our country. So, mild behavior problem, this is a BMC guidelines. Clonidine you can use. If the behavior problems are very severe, probably you can go to atypical antipsychotics directly. These are the other options. So, because of time, I'm not going into these things. We'll go to the next topic, sleep disturbance. Again, disease burden is very high. Sleep disturbance can cause developmental arrest and lead to other behavioral problems as well. Again, rule out other sleep disorders like narcolepsy, obstructive sleep apnea, medical causes presenting as sleep disturbance before going into pharmacotherapy. Again, this is a rough pathway. This is a master regulated suprachiasmatic nucleus. What it does normally, it stops VLPO, ventrolateral preoptic nucleus. It stimulates orexin neurons in normal state. So when that light goes down, the suprachiasmatic nucleus triggers melatonin. Melatonin in turn blocks the SCN. So what it does, it stops blocking VLPO and it stops stimulating orexin neurons. So what happens? The VLPO switches off the brain. And what does orexin neurons do? It actually stimulates the brain, so its stimulation stops. So this is what normally happens in the routine day. So these are the potential pathway substrate for the pharmacotherapy in sleep. So first and foremost, if any sleep disturbance, the melatonin is the choice. So you can start with 1 to 3 milligram, go up to 10 milligram. Extended release melatonin is not widely available here, so we have to go with the plain melatonin only. Not much side effects. This is lemborexant is a dual orexin receptor antagonist, that is DORA. It is not FDA recommended, it is off-label, but I find it useful in the day-to-day practice because it reduces in the other pathway, that reduces wakefulness. Okay, so make sure the child doesn't have narcolepsy or other type of sleep disorder, and it is much less side effects, so you can safely start this lemborexant, and it works through different mechanism. And again, this is a flow chart, BMC flow chart. So start with melatonin. If it is not working, then if the onset is the problem, the clonidine, trazodone, hydroxyzine is an antihistaminic. All three works through different pathway. It doesn't work on the pathway I shown here. These agents works through adrenergic, histaminergic, and sometimes dopamine pathway in the brain to induce sleep. If these things, if the maintenance is the problem, if the maintenance of the sleep is the problem, then extended release preparation will be helpful. But India extended release preparation is not that widely available. So you can go for a sedating antidepressants like trazodone, mirtazapine, or if nothing is working, you can go to benzodiazepine. So in a nutshell, try melatonin. If it is not working, go for clonidine, that is alpha-2 agonist. If it is not working, try trazodone or quetiapine. If it is not working, then go for benzodiazepines. These would be a rough pathway in our setting to manage sleep disturbance in autism. So ADHD. Again, the combination is very high. More and more the early intervention services are there. More and more the children with autism are improving. They are becoming verbal. They have high comorbid ADHD. Both of them is a killer combination. So when you have a child with ASD and ADHD, for example, imagine a situation where like they don't have, like theory of mind is less, but the ADHD symptoms is causing the child to be impulsive all over the place. It results in significant caregiver burden and it has a long-term burden for the child as well. So this combination has to be addressed very early in the treatment phase. So the pathophysiology, don't go into this circuit. Basically, from the cognitive circuit, more and more attention has been now shifted towards a reward circuit in the brain. Okay, previously, the ADHD, the more focus has been given for a cognitive part of the brain. Now, more and more, the reward pathway is in the limelight. Why? If you see, the outcomes of ADHD, addictions, obesity, less social interactions, dysphoria without any reason, all these things are basically denotes dysfunctional reward pathway in the brain, especially in the adolescent age. Next is less evidence for cognitive remediation. Nowadays, cognitive remediation is a big market, but cognitive remediation is not widely recommended by standard guidelines for the treatment of ADHD. Like cognitive remediation means doing something to just to improve their cognitive skills. More and more evidence is there for behavior therapy, where like you improve the reward functioning of the child so that the long-term effects of ADHD is reduced. So these experience says the ADHD has a dysfunctional reward pathway along with a cognitive difficulty. So again, this is the if you see this, lots of dysfunctional reward circuit in the form of obesity, poor social skills, drug addiction in the untreated ADHD in the long run. So this is the APA guidelines. The APA guidelines, preschool behavior therapy, if not, go for stimulants, school age medicines plus stimulants, adolescent medicines plus stimulants. So here ADHD, the pharmacotherapy seems to be the mainstay of treatment along with the behavior management techniques. So this is the Texas algorithm. So I tell you, don't bother about the chart. So first choice is stimulants. In India, especially non-stimulants are preferred over stimulants, but Texas algorithm says the stimulants are the first choice treatment for ADHD. Amphetamine is not available here, only methylphenidate is available. So start with the stimulants. If it is contraindicated or if the child is not tolerating, go for second choice is atomoxetine. Again, if the child is not tolerating, this stage 4, 5, 6, I'll leave it to you, okay? Because there is no clear algorithm after that. Some clinicians use clonidine, like it is available here, alpha agonist. Some clinicians do use bupropion for especially adolescent age. But once the first two fails, all these things should be according to the child. For example, ADHD with some other addiction, you can use bupropion. Or if a small child use clonidine, the other choice will be left to the individual clinician's discretion. So when you start on stimulants, one thing you have to remember in mind, the stimulants dosing depends on the formulation. For example, you use immediate release formulation. For example, 30 milligram you use in the morning, you would end up with more side effects. Okay, so immediate release, sometimes you have to give thrice a day. Okay, morning, afternoon and evening, because it will work for a few hours, then the effect goes off. In modified release, which is available as SR preparation in India, that you can use for twice a day, one in the morning, one in around 3, 4 o'clock, so it covers through the day. Osmotic release, there only one brand is available in India, we can use once a day. So if you are not comfortable with the preparation and treating according to the preparation, you will end up the children either having side effects or effect will be pronounced only for one part of the day, and the next part of the day the child is going to have completely behavior and lots of issues. So stimulant use depends on the formulation you use rather than rigid dosing scheduling guidelines. So common adverse effects are like loss of appetite, headaches, gastric symptoms. So you can warn the parents. Growth, again, it's a controversy. There are studies says where you have 1 to 2 centimeter loss of adult height, but there are enough and more evidence to support the long-term growth potential doesn't change, but we have to monitor. Every 6 months you have to monitor whether the child is growing according to the growth chart. Okay, as long as child is growing according to the growth chart, you can continue. And tics, again, it is controversial. There are evidence says that tics is worsened, but enough and more evidence to say you can safely use stimulants in children with tic disorder. And if you don't warn about this uncommon but possible side effects, like worsening of dysphoria, hallucinations, then you may lose the patient. Lose the patient means they won't come to you. You give the medicine, suddenly the child become highly dysphoric and aggressive, then say, doctor has done to my child. So please do warn the parents about possible dysphoria or hallucinations when you start the child on stimulants. So like 1% of the children can have this dysphoric reaction to the stimulant medication. Next is whether the routine cardiac monitoring is required or not. Okay, so previous guidelines says yes. Now the AHA guidelines says no need for routine cardiac monitoring, but there is a catch. They have given 1,001 conditions to say like you make sure there is no family history, you thoroughly examine the patient, rule out all these syndrome. Yeah, am I competent to do all those things? No, I routinely take cardiac clearance before I start on stimulant. So if you are thorough with cardiac workup and cardiac examination, no need to routinely take cardiac consultation before stimulant. But if you are not thorough, better to take. And atomoxetine, again, I'm not going into detail of this neurotransmitter, but basically it works in the cognitive pathway than reward pathway. That is why the effect size is slightly lesser than stimulant. Stimulant, it's 0.9, atomoxetin, it's 0.6 to 7, because it mainly works in the cognitive pathway, less in the reward pathway. When to use atomoxetin? When the children is not tolerating stimulant, not responding to stimulant, comorbid anxiety, and parent preference. So these are the situation you will use atomoxetin instead of stimulants. Last is anxiety, depression. Just a brief note, if you know, like clearly the behavior problems are due to syndromic anxiety or depression, first trial of SSRI will help in the long run, because side effect profile wise, these class of medication has lesser long-term side effects than atypical antipsychotics or mood stabilizer. So here it is important, because if you could recognize anxiety or depression in children with autism, please consider a trial of SSRIs before going into other medication choices, as I mentioned. Thank you.
Thank you very much, Dr. Venkateshwaran, for being on time and for your very insightful lecture on this very important topic. Sometimes we find it very difficult because parents are very hesitant to start a child on medication. And as a therapist, we have to decide very carefully whether the child really needs the medications or not. So thank you very much. As time is up, as Rama Madam said, we don't have time for questions. Thank you very much.
Thank you. Thank you. Thank you.
Thank you. Can we have the next speaker, Dr. Venkateshwaran? Sorry, Dr. Neelagandan. Can we have his CV, please? So Dr. Neelagandan is now the Associate Professor of Psychiatry in Thanjavur Medical College. He will be speaking on a very grey area, sexuality in autism, which we don't much talk about. Though we have seen adults with autism have less romantic relationship, we have seen that they have few sexual relationships. Hypersexual behavior is an area that needs to be addressed. Similarly, as Deviki Madam was saying, we have to be extremely sensitive to the masturbatory practices. We have seen young children, adolescents who the parents bring them to us for the masturbation, and how we need to be sensitive to them. And just one point I would like to say here, routinely we do the basic investigation to rule out a physical illness. We take a EEG, we take an MRI. I think a comprehensive psychiatric service in a child with autism must include sexual health assessment. It must include the social sexual dysfunctioning, and also their if a child is able, if the adult is able to communicate about their sexual practices. Similarly, many children and adults also have paraphilic tendencies, which also has to be addressed. So Dr. Neelagandan will be speaking on this very, very grey area.
Happy morning, everybody. At the outset, I would like to thank the CoE team headed by Rama ma'am and my dear guru and friend, Dr. Sivalingam sir, for giving me this opportunity. And then my chairperson, Professor Dr. Shanti Nambi ma'am, gives me little anxiety to present, because she is very meticulous and teacher. So I'm not supposed to make any inadvertent mistakes before her. And then I asked Dr. Sivalingam sir, why you chose me for this topic. நம்ம அந்த கரகாட்டக்காரன் ஜோக்கு மாதிரி திடீர்னு என்ன ஏன் சார் ஏன்டா கேட்ட அப்படின்னு சொல்லுவாங்க. அந்த மாதிரி எனக்கு ஏன் சார் இந்த டாபிக் அப்படின்னு கேட்டேன். அவர் ஃபன்னியாக ஏதாவது சொல்லுவார்னு பயந்தேன். ஆனால் அவர் கரெக்டாக சொன்னார். ஆக்சுவலாக ஐ அண்டர்வென்ட் forensic aspects of child sexual abuse training at NIMANS. Thanks to my then director, Professor Purna Chandrika ma'am, for sending me to that training, a 2 weeks training. So it's a lengthy training, nobody accepted. So I went for the training. So he finally said, because of that only we selected you for this topic. I think I should do justice for his expectations. And sexuality, I think sexuality in autism, but sexuality is a problem throughout your life. For anyone, sexuality is a problem at any stage of life. I feel that way only. Even adults, even geriatric population struggle with to deal with their sexuality. Many complaints we receive from young adults, middle-aged adults, even older people. We see many dementia patients, family complaining of sexual problems. And I forgot to wish my grand guru, like Grandma Jayantini ma'am. She has been a very, she is very godmotherly for me, and she is like grandma and grand guru for me. Thank you, ma'am, for inspiring me to take up child psychiatry, because I've been a pediatrician for 30 years. Then I then became a psychiatrist also. So thank you very much. And then I am going to cover the normal developmental milestones that the child undergoes during adolescence, and then the interconnections between autism spectrum disorders and adolescent pubertal growth, and then what are the problems we face in sexuality, and then how to sort it out. I'm giving an overview of how to do therapy for those children, and conclude on that. So we all know that I used to tell them this anecdote, like the metamorphosis anecdote. We all love this. Starting from a larva child, and pupa is the adolescent stage, and mature adult, they fly as butterflies when they mature. So they always have this, it is multidimensional. Growth is not only physical, but it also psychological, physical, cognitive, emotional, and temperamental changes are there. We should kind of educate parents about this. And this anecdote is very useful for me in the practice. And adolescent turmoil is even normal in all neurotypical children. So it is not only a problem for neurodiverse children, it is a problem even for neurotypical children. So most of the times our consultation is only for adolescent turmoil. I tell them I have no diagnosis, it's only adolescent turmoil. Just give them some space and they'll be all right. So this is the first thing. Second developmental thing is the adolescence is divided. You all know very well that adolescence is divided into early, middle, and late adolescence. What actually happens, apart from we all know Tanner's staging of sexual maturity. So what actually happens psychologically is they start having the thinking becomes from concrete thinking to abstract thinking. So before that, they will accept whatever you tell. Book மிதிச்சுனா தொட்டு கும்பிடு சொன்னா they'll say okay அம்மா சொல்லிட்டாங்க தொட்டு கும்பிட்டுருவாங்க. அதுக்கப்புறம் they'll ask why should I do that? ஒரு பேப்பரை மிதிச்சிட்டா why are you asking me to do? Why are you asking me to do this ritual? And they start questioning you. Slowly the revolting behavior starts because of their critical thinking. They start analyzing for themselves with whatever knowledge they have and whatever information they get from net and others, and then they start questioning you. So it's a transition from concrete thinking to abstracting. That is the main thing. They need more autonomy for themselves. They need more independence to function. They need space for them. They say that, don't interfere in my space, leave me alone. Like that, they start telling. Those parents most of the times think that it's kind of a problematic thing. They think that because, sir, the autism குழந்தைங்க தான் இப்படி பண்ணுவாங்களா சார், இல்லைன்னா நார்மல் குழந்தைங்க இப்படி தான் பண்ணுவாங்களா? They think that it's a problem of, they tag everything to this autism spectrum disorder, and they don't understand this normal physiological thing. So that we have to educate them. Next thing is, so what the adolescent development is heralded by the, characterized by puberty, pubertal growth, identity formation, and then emerging sexuality and with pure dynamics. And the autism they have their own sexual, the sensory needs, cognitive rigidity, social deficits, and communication barriers. So both together it becomes a clinical focus for us. So these are all the things. So what is sexuality? Most of the times people, even learned people, doctors don't understand what is sexuality. Sexuality is not only that sexual behavior, sexual activity or reproductive function. It is kind of a, first thing is identity, gender identity. They should feel their biological sex, what it is. And then sexual orientation, to whom they are attracted to. That is sexual orientation. And then comes the understanding of the sexual behaviors, and then individual expression. Each individual has a different expression of sexuality. So sexuality is a collective term of sexual growth, maturation, development, everything. So WHO has a definition for sexual health. So state of physical, emotional, mental, and social well-being in relation to sexuality. and not merely the absence of disease, dysfunction, or infirmity. That we should understand. Actually, later only I found that they have a, so we know the definition of health. So for sexual health also, the WHO has got a definition for this, and it should be useful for us. So the core requirements are we should have a respectful approach for the possibility of pleasurable, safe experiences, must be absolutely free of coercion, and so we have to approach keeping in all these in mind, the biological perspectives, psychological, emotional, and social perspectives. All these should come into your mind before we deal with the sexuality issues in autism children. So I want to kind of highlight these 4 things. There is this imbalance is there. The physical puberty timing is earlier than their cognitive and social maturity, right? And the adolescent with autism experience physical maturity of puberty at approximately the same time as their neurotypical peers. But the gap is there, though they experience cognitive, communicative, psychosocial difficulties due to the core features of autism that we all know. So the result is a sexual drive occurs without adequate adaptive skills, limited peer relationships, reduced access to accurate information, normal developmental urges that manifest as challenging behaviors that we have to deal. So this is one aspect of the biological maturity outpaces the cognitive and social maturity. That's one thing. Second, this you should understand high profile, high functioning autism profile children and high support needs profile. That means they need very substantial support because their IQ is low, adaptive skills are inadequate, and then their theory of mind deficits are more. And so they have a different profile. They even need support for self-care activities of daily. So another high end of the spectrum is developmental milestones are almost intact. They are very, verbal communication is also better, and they have very less theory of mind deficits. So these are all high functioning profiles. So they do have different sets of sexuality related issues that you should understand. The next thing is, this one we have to understand, the sensory collision funnel, okay, because of hormonal surge, body size increases, hair growth increases, menarche occurs, and the skin texture changes. So all these sensitivities, they have these filters, tactile hypersensitivity, proprioceptive vestibular shifts, visual auditory sensitivity to one's own body changes. So all these results in this resultant collision of sensory overload, meltdowns, and shutdowns, because the adolescents with ASD are not just dealing with hormones. They are experiencing an unprecedented disruption of their body's sensory baseline. Multiple sensory changes occur simultaneously at the same time. So they become sensory overload for them. They become overwhelming with handling all these things, so resulting in meltdowns and shutdowns. So the third thing is, boys have a different set of problems, girls have different set of problems. So gender also plays a behavioral and social pathways in ASD. So they are distinct in some few ways. So boys tend to report more higher interest and desire in sexuality, adopting sexual behaviors in early age and with greater frequency. The girls with ASD exhibit significantly more flexibility in sexual orientation. They are highly influenced by changing social gender norms and heavily engaged in social masking. So common shared thing is prevalence of gender dysphoria, variant sexual orientations, notably higher in adolescents with ASD than with non-autistic peers. So the next is, so this is all for normal children also, cultivating sexually healthy young adult. So what are we going to do? So they should know first, I know my body and how it functions. We should kind of educate them in these areas. I am comfortable with my body and my sexuality. I can talk effectively with my peers, family, and partners. And I understand the risk and responsibilities and consequences. I form and maintain healthy relationships based on personal values. I set boundaries regarding sex and relationship. These are all the healthy sexual education things we should address. Each one has got a relevance. So a few clinical presentations we encounter in our clinical practice. Like I had a 16 years old high functioning autism boy who expressed that he expresses distress over his gender, saying that he started searching the net for female dress, clothing, cosmetics. What he told us, I feel feminine presentation will be, I will be more pampered with gentleness, and family will handle me more very softly. So I like that. So he was already on medications, but he was telling this thing about his sexuality. So this another 14 years old child with who is non-verbal and having low IQ has compulsive layering. He will always wear chudidar tops inside the house. When he comes out for the clinic and social places, he wears another shirt and pant over the, but he is not able to express himself what he actually feels. So this is this thing was noticed by us. So the other things are, so a 19-year-old girl have intense romantic fixation on a YouTuber who is a brother's friend, believing that they communicate love through videos, inappropriate staring in public, and highly irritable when confronted. This is one scenario. And another 16 years old male who is non-verbal, engaged in public masturbatory activities, watching porn in the family living rooms, so displaying disinhibited behavior with the female family members and household server maids. So another 26-year-old, this patient was, I should not say is a patient, he is a 26-year-old IT professional. The father and mother has managed to put him into engineering college, finished his BE degree, and he is now working in an IT company of his father's friend. So they accommodate with all his little deficits, and they plan to get him married now. So they brought this man to me, saying that, sir, you have to check whether he is having a sexual knowledge and whether he is ready for marital life and all. So this is also another scenario in clinical practice. So we'll finally conclude how we can approach this. So this 14 years old mild autism with mild ID. So the child was suddenly having not anger outburst, irritability, school refusal, and not taking proper food and all. So when I asked him, he told, I get erections on and off, and sometimes I get ejaculate also. I fear that this may happen at school also, so I don't want to go. So it makes me embarrassed at school, so I don't want to go. So parents didn't know how to manage this. So this is also another scenario. So what presents clinically as an acting out rigidity, inappropriate fixation, or somatic distress is rarely a primary pathology. It is almost always a secondary manifestation of unaddressed developmental needs. We have to address these sexuality issues for the child to cope up. So we have a pillar. Pillar one is social interpersonal architecture. So we have architectural pillars to manage these things. So social mechanics, approaching, greeting, introducing the topics, decoding non-verbal cues. These are all given in the intervention guidelines for parents and caregivers by NIMANS. So decoding non-verbal cues, eye contact, how to interpret it, tone, postures, gestures, turn-taking, active listening to them, apologizing when they get hurt, appropriate expression of fear, anger, and affection. These are all social mechanics. And interpersonal dynamics are distinguishing casual friendships from long-term relationship, understanding healthy limits and expectations of a partner, developing assertiveness, respecting rights of others, cultivating desire for and skills to maintain intimate connections. These are all to be addressed. The pillar two is normalizing puberty and body image. This is very important actually, demystifying puberty. So proactively educating on bodily changes. Even before they get into problematic issues, we have to be proactive in dealing these issues. Explaining menstruation, hygiene and nocturnal erections, differentiating between masturbation and intercourse, normalizing sexual curiosity while defining healthy versus unhealthy practices. So stabilizing body image is another area, assessing for body image disturbances. So all these were explained in the clinical scenarios also, emphasizing healthy eating habits, reinforcing physical strength to build baseline self-esteem. So the caregiver and environment, the third pillar is the myths carried by the caregivers. So they think that adolescents in the ASD lack sexual feelings and dislike social relationships. Reality is that they possess normative desires, but lack the intuitive roadmap to express them only. They have the problem with the expression only, not the lack of these feelings. So second thing is they may present atypically. Because they present atypically, they are neurodivergent children, they are not attractive and so safe from sexual abuse. But it is not like that. downstream somatic, only thing they may be delayed or they may be internalized. They may not be able to externalize, express what they suffer inside actually because of abuse. So these are the challenging behaviors as everybody is removing clothes in public. So they are kind of tactile hypersensitivity issues, intolerance to changing skin texture and hair growth, and then public masturbation and touching others inappropriately. So body exploration without understanding social boundaries or public and private cues. So this aggression and mood swings, they are emotional regulation difficulties and distress over changing routines. So the behavioral management comes with the two approaches. So we have to be proactive. One is the proactive toolkit, the other is the reactive toolkit. So what we have to do is, whatever is proactive is, before the problem arises, we have to intervene. Like antecedent management, taking preemptive environmental steps to eliminate triggers, prevent target behaviors. Before taking them anywhere, we have to kind of do a small role play or a small briefing about what we are going to do, like the time structuring, activity scheduling, fulfilling the needs, building autonomy. And then the reactive toolkit is differential reinforcement is good actually. If they do something wrong, we are just telling. But if they could do something good, if they are actually compliant with your instructions, praise them, validate them. So accept them and validate their good behavior also. So appreciate their good behavior also. And attention enhancing tasks. So engaging activities should be given to them. One mother who is a doctor, who engaged his son during the adolescence in Mridangam. As madam said, he is a good Mridangam artist. Even Sirgali Sivasudama sir was attending his Mridangam Arangetram. So he finished his, for almost 1.5 hours, he gave a concert along with his teacher. Actually, she was on vocal and he does the Mridangam. So that much of engaging activities the mother planned actually. And then disregard versus ignore. So sometimes we may have to disregard their small deviant behaviors. Sometimes we may ignore also. These are all the techniques too. So they have to bridge the gap to normative functioning. Somehow we have to desensitize, graded exposure, strict follow through, and the limit setting. And this is the clinical matrix. So the master A and D, so they had identity problems with body image and sensory autonomy. So we have to do desensitization, social skills training. For this Miss T and Master V and S, we have to do puberty education, give them a briefing about interpersonal limits. So limit setting, differential reinforcement are very helpful. And for a Master S with somatic complaints, demystifying pubertal biology, who was crying and school refusal for his fear of erection or ejaculation. So we have to demystify pubertal biology, graded exposure, antecedent management. So essential topics for components. I don't have to elaborate on this. Physical changes you have to address, hygiene, body awareness, public and private cues, masturbation rules, and touch and boundaries. So tailoring educational tools. This is very important. Tailor-made should be there. You have to customize your approach to each child. Each child may have a different approach. So don't be kind of one pill treats all, like kind of not there. So you have to use social stories, visual strips. We have to use picture cards when they are very non-verbal. We can use animated videos, and then we can use life-sized dolls. With dolls, we can teach them. And then modeling and role play. But suppose if he is going for a class party, 12th student going for a class party where girls will be there, you have to teach them how to talk back and forth or how to respond to cues. So cultivating a safe harbor through proactive caregiving. So we have to have open communication, family-centered approach, problem solving together, and there should be consistency in all these strategies. And the most important thing is emotional support. That's the single most important factor in reducing adolescent anxiety and distress during puberty. So multidisciplinary ecosystem ensures safe transition to adulthood. So with family and environment, they have only 3 settings which they function. Family setting, school setting, and then the social setting or clinical support. With clinical support from doctors, family and environment, and education system. Teachers should also be educated. So I request CoE to conduct workshops for teachers also, how to handle them in the classroom. So in the end, we should have a sexually healthy, safe, empowered young adult. So empathy meets structure. Navigating adolescence in ASD requires decoding complex behaviors, addressing deeply human needs, and applying structured proactive modifications. Empower the adolescent, educate the family, structure the environment. We must strive to handle sexuality with utmost care, scientific approaches, gentleness to ensure our neurodivergent children transition safely into young adulthood. I conclude with this slide. I request all of you to read this book on by Osho. It's kind of different thing, but sex to super consciousness. He has combined everything, scientific approach, a psychological approach, and then spiritual approaches also. So parents should be first normalized to talk about sexuality and approach sexuality with in a healthy manner, because it is of course, I still remember the Park SPM book in our MBBS. The primary motives of life வந்து மூணு கொடுத்துருப்பாங்க. Sex, survival, sex, hunger and survival. These are the primary motives. The sex is basically to procreate and propagate the progeny, right? So it is a basic need for every living organism. So we have to normalize that. And I request all of you to watch this movie, Cries from the Heart. It's a 1994 American movie by Michael Switzer. So Duke, that child is Duke and she is Gilbert. So this is a non-verbal child who expresses his sexual abuse in a beautiful way using AAC. So we cannot, we think that they don't feel, they don't express. But by watching this movie, I just cried. And then the child was so, with the help of, she is his therapist. So she only helped him to express things through AAC. They used AAC to express. And it was, the case was won in the court of law also. Everybody please watch this movie, then you will understand how intellectual the autistic children, Madam said, even though if they are non-verbal, they will be they are not intellectually incapable. That we should understand. With this, I just concluded this topic. It was difficult for me also to prepare. But somehow, Dr. Sivalingam made me, Neela, you can do this. So I thank him also for this thing. And I thank my teacher. Thank my teacher, Shantinami ma'am, to patiently watch and chair my session. Thank you, ma'am.
Thank you very much, Dr. Neelakandan, for talking on this very, very grey zone. I think you've really done a wonderful job on this. I think you addressed all aspects of sexuality and autism, including gender dysphoria, and on stressing on the importance of behavioral management in these children and adults with ASD. Thank you very much. Thank you very much, madam.
Thank you for those valuable insights, sir. I invite Dr. Rama Chandra Mohan to felicitate Dr. Shanti Nambi and Madam Dr. Shanti Nambi to felicitate our speakers. I also invite Dr. Shanti Nambi to felicitate our speakers, Dr. Venkateshwaran and Dr. Neelakandan. That brings us to lunch. Please join us for lunch, and we look forward to seeing you all back in your seats in half an hour. Please be seated by 2:20 for our panel discussions, please. come inside the hall and please be seated, please. Welcome back, everyone. We now move into our afternoon panel discussions. For our first panel on adolescence and autism, I invite our moderator, Dr. Satya Raj, psychiatrist, to the dais. Ma'am will be inviting Dr. Shivalingam, psychiatrist, Dr. Kabilan, pediatrician, Ms. Jaimina Dhanapalan, board certified behavior analyst and founder director, J Special Needs Center, and Mrs. L.V. Jayashree, director, the Spastic Society of Tamil Nadu.
Very good afternoon to all of you. At the outset, I'd like to thank Rama ma'am for giving us this opportunity. So, Tamil ஆரம்பிக்கணும்னா எப்பவுமே சொல்லுவாங்க செவிக்கு உணவில்லாத போது சற்று வயிற்றுக்கும் இயப்படும். Madam has given me the biggest challenge. I think எல்லாருக்கும் வயிற்றுக்கு நல்லா உணவு கொடுத்துட்டு இப்போ நீ செவிக்கு வேணா ஏதாவது கொடுத்து பாரு ஒர்க் அவுட் ஆறுதான்ற மாதிரி she has put me in a spot. I hope to do some justice to it. Of course, I have a lot of senior people with me, so I'd like to invite the speakers first for the panel discussion. So the first one is Dr. Shivalingam. He's a psychiatrist with more than 21 years of experience, and he's worked with IMH, and of course, he is now currently in professor in psychiatry. His areas of expertise are child and adolescent psychiatry, autism, and neurodevelopmental disorders. Thank you so much, sir, for coming. So this session is going to be a very practical session. So nariya theoretical sessions we had seen. Now, what are we actually going to do on the ground? That is what we're going to discuss now. So next I invite Dr. Kabilan. He's a pediatrician. He's a pediatrician in the Center of Excellence for Persons with Autism. He's also the assistant professor of pediatrics in Institute of Child Health ICH in Egmore. And of course, more than 9 years of experience, and sir has a significant interest in neurodevelopmental disorders. Welcome, sir. Thank you for joining us. Then we have Ms. Jaimina Dhanapalan. So she's a board certified behavioral analyst. So a lot of ABA, inclusive education, early intervention, school consultation, these are her areas of interest, and has had multiple presentations at conferences as well. Thank you so much, ma'am, for joining us. And of course, last but not the least, we have Jayashree ma'am. She's the director of the Spastic Society of Tamil Nadu, and of course has been the principal and psychologist and head of a multidisciplinary team in Association of Persons with Special Needs in Singapore. So again, ma'am brings to her a rich sort of experience, which we can. So the idea of this panel discussion is to give everybody an idea of what is adolescence, what is ASD with adolescence, right? How does it actually pan out? What is different? So Adapatidam we are going to discuss today. So we'll try to switch between languages so that everybody can feel comfortable. We will try to accommodate a few minutes at the end for some discussions to make it very interactive. So inniki we saw certain sessions. So adolescence, now what do we understand by adolescence? Anybody? So I have a lot of therapists and students also here. So is growth and development same? No. Excellent. Thank you so much. So growth is more in the physical size of a cell, mass, development and all that. But development is very different. Clear areas like biological, cognitive, social, emotional. That is a functional ability, is a development. Right. So adolescence turmoil pati, actually Dr. Neelagandan had said a good pace about sexuality and what pubertal changes happen in adolescence. So if you see adolescence, it is, I will not say it's only a vulnerable period. I'm a very, very positive person. So I will say any period which is vulnerable is also a period of opportunity. Appadina enna artham? If you're able to intervene at the right time, you can make miracles. So that is how I like to look at, or that is the lens I'd like to look at from adolescence. So adolescence, one side, what is happening? We saw about the hormonal changes, brain maturation, amygdala, that is number social brain is maturing fast, But நம்ம prefrontal cortex, the area of the brain which has to think and plan, that is கொஞ்சம் laid back and பின்னாடி வந்துருக்கு. So there is a lot of difficulties for these normal adolescents itself. That is why they have a lot of risk-taking behaviors. But when to this equation, you had autism also. So what happens? Autism does not, it makes these challenges a little more complex, right? So adolescence, there is a pressure. I have to create a sense of myself, or identity, autonomy, independence, peer pressure, academic achievement, you name it, and everybody is pressurizing an adolescent, right? A child with autism is already struggling with some of these areas, and when நம்ம சொன்ன மாதிரி ma'am was giving the example, pushing them, just give your 10th exam, it's enough. So that causes meltdowns, that causes anxiety, that causes possibly a mood, and therefore there are multiple expressions. So that is where, so adolescence is challenging. When there is an adolescent with ASD, it makes it a little more challenging. So let's start from the basic minimal questions. What will usually come to us in a OPD when you're sitting, when you're in therapy? Why do they come to you? So I'm going to start off. Possibly we'll start from the common thing. No, in the problem may illama or normal pubertal change. So sir, if someone comes to you, unga clinic ku varanga, like ipo vanda I'm starting, my voice is becoming a little more different. I'm starting to develop some hair on my body, pubic hair, mustache for a boy, or some secondary sexual characteristics. How will you explain this, sir, to ஒரு autism இருக்கிற குழந்தைக்கு இந்த pubertal changes, how do you actually explain? So parents struggle to do this. How do you do it?
ஆட்டிசம் குழந்தைங்களுக்கு ஆல்ரெடி இருக்கக்கூடிய ப்ராப்ளம்ஸ் என்ன அப்படிங்கிறது நமக்கு தெரியும். சோஷியல் இன்ட்ராக்ஷன் அண்ட் சோஷியல் கம்யூனிகேஷனில் பிரச்சனை இருக்குது. அது இல்லாமல் நிறைய சென்சிட்டிவிட்டிஸ் இருக்குது. ஸோ எனி திங் தட் ஹேப்பன்ஸ் இன் த பாடி, குழந்தைங்களுக்கு வந்து ஒரு வியப்பாகவும் இருக்கும், ஆச்சரியமாகவும் இருக்கும், பயமாகவும் இருக்கும். ஸோ எனி கைண்ட் ஆஃப் எமோஷ்னல் எக்ஸ்பீரியன்சஸ் தே கேன் ஹேவ். ஸோ அதனால் நிறைய டவுட்ஸ் இருக்கும். ஸோ அதனால் அவங்களோட பிஹேவியரல் ப்ராப்ளம்ஸ் வெளிப்படலாம். ஸோ அவங்க வரும்போது நம்ம ஃபர்ஸ்ட் ஆஃப் ஆல் அந்த பியூபர்ட்டியை பற்றின அவேர்னஸ், அதை பற்றின ஒரு இன்ஃபர்மேஷன் வந்து அவங்களுக்கு கொடுக்குறது நல்லது. ஃபர்ஸ்ட் ஆஃப் ஆல் அவங்களுக்கு கொடுக்குறத விட பேரண்ட்ஸ்க்கு ஃபஸ்ட்டு கொடுக்கும்போது பேரண்ட்ஸ் அதை குழந்தைங்களுக்கு முன்னாடியே எடுத்துகிட்டு போனால் நல்லாயிருக்கும். உண்மையாக சொல்லணும்னா ஒரு அடோலசன்ட் பீரியடில் அந்த குழந்தைய பியூபர்ட்டி அட்டைன் பண்ணுறதுக்கு முன்னாடியே அதை பற்றி அந்த குழந்தைகிட்ட பேசினா இன்னும் நல்லாயிருக்கும். ஏன்னா அந்த குழந்தை அதை தயாரிச்சுக்கணும் அந்த சேஞ்சஸ்க்கு. ஸோ இப்போ பியூபர்ட்டினா என்ன அப்படின்னு சொன்னால், இட் இஸ் அ நார்மல் அந்த டெவலப்மெண்டல் ட்ரெஜெக்டரியில் பிஃபோர் லேட் சைல்ட்ஹுட், ஐ மீன் ஆஃப்டர் லேட் சைல்ட்ஹுட் அண்ட் பிஃபோர் அடோலசன்ஸ், அந்த டைமில் வர்றது தான் பியூபர்ட்டல் சேஞ்சஸ். அது கேர்ள்ஸ்க்கு ஒரு மாதிரி இருக்கும், பாய்ஸ்க்கு ஒரு மாதிரி இருக்கும். பட் ரெண்டு பேருக்கும் காமனாக சில இது இருக்குது. ஸோ ஹேர் சேஞ்சஸ் இருக்குது, பாடி சேஞ்சஸும் இருக்குது. ப்ளஸ் இப்போ கேர்ள்ஸுக்குன்னு சொல்லணும்னா ப்ரெஸ்ட் டெவலப்மெண்ட் அண்ட் ஹிப் சைஸ் சேஞ்ச் இருக்குது, ஸ்கின் சேஞ்சஸ் இருக்குது, அண்ட் ரீப்ரொடக்டிவ் ஹார்மோன்ஸோடைய சேஞ்சஸ் இருக்குது. அது இல்லாமல் இட் எண்ட்ஸ் வித் மென்ஸ்ட்ரேஷன். ஸோ இந்த சேஞ்சஸ் எல்லாத்தையும் அவங்களுக்கு நம்ம படிப்படியாக சொல்லணும். இதெல்லாம் நான் சொல்லும் பொழுது அவங்களுக்கு ஒரு ஒரு சென்ஸ் ஆஃப் அவேர்னஸ் அண்ட் சென்ஸ் ஆஃப் கான்ஃபிடென்ஸ் வரும். அண்ட் ஸ்லோலி அவங்க என்ன சொல்கிறது, அதை மீட் அவுட் பண்ணுவாங்க. அதே மாதிரி பாய்ஸ்க்கு வந்து மசில் மாஸ் நல்லா டெவலப் ஆகும். பேரலாக வந்து எக்ஸ்டர்னல் ஜெனிட்டல்ஸோடைய சைஸஸ்லாம் சேஞ்ச் ஆகுது. இப்போ பினைல் சைஸ் சேஞ்ச் ஆகும், டெஸ்டிஸோட சைஸ் சேஞ்ச் ஆகும். ஸோ இந்த மாதிரி வரும்போது அவங்களுக்கு முன்னாடியே வந்து அந்த பாடி சேஞ்சஸை பற்றின அவேர்னஸை நம்ம கொடுக்கும்போது தே வில் ஃபீல் கம்ஃபர்டபுள் ஆஸ் அ சேஞ்ச் அக்கர்ஸ். மேடம்,
thank you very much, sir. So உங்ககிட்ட, because we were talking about how pediatrician is one common line, you're the front warriors to sort of meet with children and continue their care. So when they are coming to you, so you know that the child has autism and you've been seeing them as a child and now grow through adolescence. Up to 2-3 questions which will come to you. So when that 10, 11, இப்போ வந்து என்னன்னா, we'll talk about that later, a little about precocious puberty, but அதுக்கு முன்னாடி, like, do they come to you, sir? Puberty suppress பண்ண முடியுமா? Can we delay it? Can we sort of do? That is one thing for girls. And more so for boys, in the masturbatory behavior, what can be done? Can some medications be given to sort of basically dampen their responses? Abdina, naraya parents keep asking. So from a pediatrician's point of view, how will you respond to it, sir?
As recently we are having more of ASD cases, and especially during adolescent behavior changes. Many of the parents are approaching us for pubertal suppression, menstrual suppression, both. But both terms are different. We should first assess why the concern is raised. Whether there any medical indication, dysmenorrhea, or any cyclical behavioral changes, or purely the caregiver burden led to that questions. So then shared decision making should be approached. Based for that, we need to assess the child, its communication, whether it is verbal or non-verbal. We try to have a shared decision making in that thing. In India, we as a team, caregiver, concerned child, treating physician, pediatrician, psychiatrist, and if needed, gynecologist. We decide, as a team, we have to decide whether the child needs that suppression or menstrual suppression or pubertal suppression. But when it comes to RPWD Act and Mental Health Act, still there is no proper guidelines. It's clinically you have to decide whether needed or not.
Sure, sir. So, do you involve a psychiatrist also, sir, a child psychiatrist, to look into the cognitive and emotional functioning of the child?
Yeah.
Sure, sir. Sure. Thank you so much. So, the other question flowing through that is, precocious puberty, is it a problem with children with autism, sir? Adolescents, do you think that is happening?
Recently, there is an increased prevalence of obesity in ASD. Latest meta-analysis shows 17% prevalence of obesity in ASD. Risk is also 1.6 when compared to typically developing children. So we can straight away attribute early puberty to the obesity. There is evidence. But there is emerging evidence which shows autism as a direct lead to early puberty. But we need more studies to come.
Sure, sir. Thank you so much. Ma'am, looking from a more social perspective, so as I was saying, adolescence is a time period where the independence, autonomy, peer pressure, many of these things are starting to sort of kick in. How will you actually integrate them very effectively into a family life first? And of course, later we'll discuss about school as well. Initially is to start with the sibling, with the family. How does the equation change, ma'am?
You're talking in terms of how are we going to integrate the families?
Yes,
okay.
Yes.
First and foremost is we have to work with the families a lot because they really have to let go the umbilical cord, so to speak. The physical and the emotional umbilical cord. They are holding on to, especially when we are talking about adolescents. One of the pain points for parents is that he's adolescent, he's a person with autism, and he's an adolescent. Obviously, he has his own sense of personhood. He has a sense of agency. Are we giving him that autonomy and that sense of choice making and making volitional decision making is something that we have to sensitize the caregivers on that. Unless the parents are rejigging their thought in terms of learning to let go so that his daughter or his son's personhood emerges.
So the helicopter parenting is something they'll have to stop at some stage. Yes.
That is one aspect of it, yes.
Yes.
And sometimes they also have to tune into the child's this one because sometimes there's also the, and especially when we work with parents as an institutional provider, one of the things is that when we look into the behavior modification and multiple other issues, but even after that it has not been addressed, we encourage them to go and meet the medical the psychiatric help that we may need because we may need some additional support. Parents tend to occlude that. They kind of delay those, and it is adding to the trauma and the anxiety or the ODD behaviors that they may be experiencing. The parents are not realizing that they are putting the child at some level of risk. The more they delay, because it is going to be incremental, because how long he could be undergoing this kind of trauma.
Sure. So educating the parents about the adolescent-related changes, both at the cognitive level, at the emotional level, at the physical level, is very essential. And at some stage, letting go and allowing them to bloom into a person they are. Right. So that is most essential. Thank you so much. Jaimina ma'am, a question to you. So if you take, ma'am Chunanga, ma'am had very nicely explained in her parent session where she said, the most difficult time was that 17 to 21, right? So I think that is the story of every other child with autism. So initially the diagnosis is difficult. And the diagnosis vanda udana நம்ம அந்த stages of grief, I think all parents go through. Initially there is a denial, then there is an anger, then there is a bargaining, adukapram there is a acceptance. So adu nadakkuradhu, that happens in stages. But at least there is something very clear. So people were saying, they give us a list of things to do and say, நீங்க இதெல்லாம் போய் பண்ணுங்க as parents, go back home. And ABA, of course, that is the first thing they tell. So applied behavioral analysis, now every other parent who is trying to look knows about it. So a skill cholli kodukano, how do I do it with ABA principles is very nicely explained in a child. What is the relevance in an adolescence, ma'am? How do you see that panning out?
Coming to, hello? So as an, see, adolescent is a transition phase, which I say. See, initially, ஒரு child வரும்போது நம்ம வந்து skills-ஐ first focus பண்ணுவோம். அதாவது அது குழந்தை பேசணும், அது எப்படி பேசும், how do we work on the improving the language, how to work on the sitting tolerance, how to work on the eye contact. அதுதான் ஒரு 6 years வரைக்கும் ஒரு parents-ஓட கவலையாக இருக்கும். As they grow older, they come to a bigger picture. எப்படி இந்த குழந்தைய ஒரு சோஷியல் என்விரான்மெண்ட்டில் நம்ம இன்டகிரேட் பண்ண போகிறோம், அந்த அக்செப்டிங் நோ வந்து ரொம்ப கஷ்டப்படுவாங்க அஸ் தே டிரான்சிட். ஒரு 6 இயரோ 5 இயரோ நோ சொன்னால் எப்படியோ நம்ம சமாளிச்சிடலாம். அதே ஒரு 12 இயர் பாய் நோ சொல்லிட்டு நடு ரோட்டில் உட்காந்துட்டா இட் இஸ் வெரி டிஃபிகல்ட் டு டிரான்சிட் தெம். ஸோ அந்த மாதிரி நிறைய சேலஞ்சஸ் வி ஃபேஸ் டூரிங் த அடலசன்ட் ஃபேஸ். ஸோ அப்போ வந்து இந்த பிஹேவியரல் ஸ்ட்ராட்டஜிஸ் ஹெல்ப். So namma eppadi panna, lot of parents has like, and the predictability, they don't know what is happening next. That also brings them anxiety. So these kinds of lot of behavioral challenges they face in the adolescence, like self awareness becomes more. ஐயோ நம்மக்கிட்ட ஏதோ தப்பு இருக்கு, நம்மளை எல்லாரும் ஒரு மாதிரி பார்க்குறாங்க அப்படிங்கிறது ஒரு 10+ ரொம்ப ஒரு செல்ஃப் அவேர்னஸ் அவங்களுக்கு ஜாஸ்தி வர ஆரம்பிச்சிடும். இப்போ அப்புறம் வந்து அம்மா ஏதாவது நோ சொல்லிட்டு அவங்க பயங்கரமாக ரியாக்ட் பண்ணுவாங்க. ஆஃப்டர் when they become 12 and 14, no, they react very hard. Sometimes they are very aggressive at those times. ஸோ இந்த மாதிரி சேலஞ்சஸ் வந்து அடலசன்ஸில் நம்ம நிறைய பார்க்குறோம். அட் சம்டைம்ஸ் அந்த டைமில் தான் மெடிக்கேஷனே போகாதவங்க அந்த 14, 15, 16க்கு தான் டாக்டர்கிட்டே போகிறாங்க. I have seen a lot of people who gone at this point they come when they are not able to manage the behaviors. So நான் எப்படி அது ஒரு இதாக பார்க்குறேன்னா, so there are a lot of clusters of behaviors arises which has been comorbidity-யும் அதில் இருக்குது. It is not only ASD, they have some comorbidities-உம் வருது. அதோட sometime OCD இருக்கலாம், அதோட sometimes some anxiety will be there. So there are a lot of comorbidities also. As you are all a panel of doctors, you know the comorbid condition is more when they are transiting to the adolescent. So I feel and the behavioral intervention will help them to settle these issues or to reduce this is what my point here.
Thank you so much, ma'am, that you wanted to add.
I just wanted to add a few points. It's very important for parents to start looking at giving the sense of agency to the child. Do not delay ADL activities for them. Do not see them in a perennial child mode, because before you know and bat your eyelids, they're already growing into manhood. So that being the case, that is really important. And the another point that I wanted to know is, please respect their children's interest and their educational choices. அவன் எப்படியாச்சும் மேடம் NOS பண்ணி முடிச்சிருங்கோ, நீங்கள் தயவு செய்து பண்ணாதுங்க. The child has his own interest. Identify and work with the child and discuss with him, because what happens is there's so much of trauma he goes through. He indulges in behaviors that are very harmful to the teacher, harmful to the classmates, because he's not able to express his sense of frustration.
I also like to add a point here. In the age la வந்து அவங்களோட deficits நம்ம focus பண்ண மாட்டோம். When they are 2 and 3, doctors will அப்போ வந்து as they grow they have to focus on their strength. That is one of the important point when they grow.
Very true. So how many of us here, all of us are professionals in some form, and all of us are parents. Most of us are parents in Nanikre. So if I have a child with ASD, if they were 2, 3, 4, 5, நான் அவங்கள வெளியில கூட்டிட்டு போகும்பொழுது எனக்கு இருக்கிற ஒரு comfort, obviously even if they behave badly, it is like it's a child. But when my adolescent, when a 16-year-old, when a 17-year-old misbehaves, masturbates in a public area, that is where I think parents actually manage it very difficult. But look at it from the point of an adolescent. You have never taken them out any time before. The first time it's like a flooding for them. You're exposing them to a society and you want them to behave to their best. So that is not possible. Can we give them these opportunities? Like, நம்ம சொன்ன மாதிரி accepting them as they are and sort of saying, yes, they are a little different. They are neurodiverse, but can we just accept them as people? I think that is what we have to do for integration. Anything
Especially
to add,
when you take them out and they may have their own anxiety or meltdowns or what have you. Let parents not be guided by what the society will say. They care a damn. The most important is, as mothers, and you think your child is undergoing some level of stress, you need to first self-regulate yourself. If ஐயோ அவ என்ன சொல்கிறா அப்போ எல்லாரும் பார்த்துட்டு இருக்காள் என் குழந்தை என்ன அப்போ தயவு செய்து கண்டுக்காதுங்க. Just chill out. The moment you chill out and you're in a state of calmness, you self-regulate, then gradually move into co-regulation with the child. அது ரெண்டும் நடந்தப்புறம் தான் communication with the child. He will be able to meet you at your level. Otherwise, you are stressing the kid. His absolutely stressful scenario for the child. So the most important, parents, you need to self-regulate yourself first. The moment you self-regulate, the child can, then you move into an emotional space of co-regulation. Then a communication can happen. Kana settle ஆயிட்டியாடா கண்ணா, ஓகே உனக்கு இது பிடிக்கலையா, நம்ம போகலாம் அந்த கல்யாணத்தில் இந்த டுமுன்னு சத்தம் இருக்குது, சரி ஒரு 10 நிமிஷம் வெயிட் பண்ண, நம்ம லீவ் பண்ண, honor your word that 10 minutes, not 10 minutes for him is absolutely written in stone. Yeah.
Thank you so much for
Ma'am,
that.
இந்த இடத்துல about the bodily changes, இப்போ நீங்கள் masturbation public placeல, so if you educate about the, to the child about the body and how to maintain it, this is my body and there are certain private parts and other parts, and how to use those, where to use, certain behaviors are private. So அந்த மாதிரி விஷயங்களை நம்ம முன்னாடியே நம்ம சொல்லும்போது, ஸோ இந்த மாதிரி பப்ளிக் பிளேஸில் மாஸ்டர்பேஷன் இந்த மாதிரி நம்ம ப்ரிவென்ட் பண்ணிடலாம். ஸோ இந்த இடத்துல வந்து பேரண்டோட கஷ்டம் அங்கேயே ப்ரிவென்ஷன் இஸ் பெட்டர் இல்லைங்களா அந்த மாதிரி.
One final point I'd like to add to this is possibly, before moving to the next question, we need pediatricians, we need psychiatrists, we need therapists, speech and language, behavioral therapists, everything. All the more what we need is advocates. Advocacy is something which is very important. It needs to happen at every stage. So, இப்போ வந்து many places are doing it. For example, a mall has a specific day where a dim lighting is there for the child, where the child with a neurodiversity can go purchase the way they want to, right? They're boarding a flight, can they be given some preference before the chaos starts, right? So, can we be voices for them, to be advocates? I think that is what we need to do as a community who are basically supporting children across the lifespan when we are looking with ASD. Just move on to Shivalingam sir. Now physical changes, Pati, we had spoken, sir. The next most important thing in adolescence is the cognitive changes and the emotional changes. So there are a lot of emotional changes like நம்ம சொல்லுவோம் இல்லையா, saying no happens at 2 times. One is at the terrible twos. Anything you say no, அதான் first வரும். Then only what did you ask அப்படிங்கிறது is the next question. Similarly, adolescence. So that is a part of normal adolescent development. But in children with autism, that becomes a little more complex, where they are not able to say that no in an acceptable manner. That comes out as anger, that comes out as aggression, that comes out as maybe self-injurious behavior, head banging. How do you delineate, sir? Edella is only a part of autism. How much of it can you give a leeway? The other thing must also not happen. The diagnostic shadowing mari ellame autism naladha, right? It's all because of that. Appdingiradhum illa. There are a lot of mental health issues. We know that these children with autism are more prone or vulnerable to develop mental health issues. So how do you delineate this, sir, in the emotional and mental health?
as the child grows into an adolescent, there are a lot of hormonal changes takes place, and this hormonal changes will have impact on the physical changes as well as the mental or emotional changes. So, as we know, because of the autism manifestation itself, it has certain impacts on the behaviors of the child, because the child, depending upon its intelligence, the child will manifest different forms of behaviors. So it depends on how the symptoms evolve. For example, how emotional regulation the child has, and how the symptoms of social interaction and the social communication is severe enough. So all these will have an impact on the mental well-being of the child as the child grows into the adolescence, because the challenges into the adolescent is going to grow up. The setting where the child is, and that plays an important role. For example, the classroom is going to, it is crowded and the noise is going to be high, and the class teacher is not going to be the same. It keeps changing. So all this creates a lot of unpredictability in the child's career. So each and every day the child is faced with so many sensory difficulties, and all this can have an impact on the emotional well-being of the child. So certain behaviors can manifest in certain places, not everywhere. So, but when it comes to mental illness, the behavior is pervasive and it is severe enough. So, and it also affects the functioning of the child. So all this has to put into play before we consider this as symptom because of some comorbid illness and because of autism.
Thank you so much, sir. Now, recently I happened to do one, not recently, a few months back, a workshop on anxiety in ASD, adolescents. So, appa we were talking about, I told only one thing is a golden word. Intolerance, neenga sonna mari, intolerance of uncertainty. So, that is what triggers. So, when we were talking about anxiety management in adolescents with ASD, we were saying how you can work at the environment level. How you can make a structure, you can make a routine, you can have dim lights, you can have more or less crowded places. So everything in last is your anxiety management and then medications. So neenga sonna mari intolerance of uncertainty is the most important thing triggering this, and differentiating from a normal adolescent behavior versus a disorder neenga sonna mari is the impairment. When you feel it is clearly more than that causing an impairment, then definitely search on Amari, it's something more.
At the same time, the teacher or the parent will know the baseline behaviors of the child. So when comparing that baseline and the change of the behavior, that will give us some idea about the abnormality of the behaviors.
Sure. So just one question, this is more out of curiosity, because we were speaking about sensory issues in adolescents, and a lot of them have a lot of feeding and eating related problems, starting from early infancy, childhood, and then adolescence. இப்போ அந்த மாதிரி இருக்கிறதுனால, you were interestingly talking about the relationship between obesity and precocious puberty. So obesity பத்தி adolescents la, how do you think we must educate adolescents with autism or their caregivers to be on the guard?
Once we made a diagnosis of ASD as early as possible, during that time itself we have to plan. As it's a lifelong condition, we have to plan. So, the prevalence of obesity varies in the ASD, ma'am. The earlier age, they will be picky, choosy while eating, might be due to the sensory issues. As age advances, it totally differs. The obesity prevalence increases. In that study itself, they shows that the prevalence of obesity is 12% in the younger age group. As the age advances, it's 33%. So it shows that having medications, sedentary habits, restrictive and repetitive behaviors, relying on high caloric foods, they land in obesity.
Sure, sir. Just to sort of, sir was talking about a classroom, ma'am. So in a classroom, like, or in a vocational training, what is the liaison we can actually do with schools to help them accommodate adolescents with autism? Okay, you are talking from, who would be this one? Will it come from health sector you're talking about, or from, yes, how can we facilitate it as a whole, as a team?
One of the pain points for parents is how to navigate the fragmented systems. So let us look at it from the prism of a parent. They have to often navigate fragmented service sectors, which includes NGOs, the healthcare, and all of or the therapy sessions and what have you. And sorry, your question was in terms of how do we, yeah. So we have to move in, instead of working in silos. The next step for us is to go into a participatory model or person-centered care planning for them. When we are looking at participatory model, some of the key things we should be looking at it, we can look at it as a triangle, where the foundational skills we will be working on for the medical fraternity as well as the therapists, or all of these can, their psychological well-being as well as their psychiatric well-being can be taken as the baseline. The next enabler for this is a school system. The school systems will work on their communication, including the various therapists, ABA professionals, and all will come in terms of communication and behavior regulation aspects of it. We'll work on that. And the apex of this is participation. Whatever we are talking today, unless we know this young adult or adolescent is able to participate in his life, all the efforts that we do will not happen. So we need to have some sort of a transition coordinator who will, because otherwise it's fragmented systems. At least in metro, there are a lot. It is not lack of services. There's no problem in lack of services, but lack of connectivity among the services. Exactly. Parents are left to their own wisdom. Talk to some parents, say, "Idu pannalama, adu pannalama, in the homeopathy doctor to ponga, adu pannu." They're struggling with decisions. I'm not passing any judgment on the choices parents make, but we need to have some sort of a transition coordinator at the individual level and at the systemic level. When you're talking about, we have to make sure that interdepartmentally there is a coordinated mechanism to support the whole process.
I think that was very nicely brought out by the parent session, where they said that we are all working in silos and it's up to the parent to sort of get. And of course, in our session by Shobha ma'am had said, parent is the case manager, taking the logbook, trying to see what appointment where. Exactly. So I think that working in silos doesn't sort of help, and working together.
It has to be a participatory, person-oriented mechanism where we are not looking at number of hospital visits, the medical management, the medicines have stabilized. No, that is the hospital. I, as a therapist, will look at my therapy goals. I have achieved it. Done. Tick box. Then you move into the next, this one in terms of, we will look at IEPs. Okay, finished, achieved, done. Happy we are. Then we are vocational training, work skills. And somebody who's going into work employment and such other things, we're looking at performance and work skills. They're all working in silos. But none of us are sitting together on the same table, including this one person we are missing in this combination is, are we having that person whose life we are talking about? Exactly. Does he have a say and autonomy in this conversation? We need to include them in the conversation, because choice making and participatory, this one will not happen if that young adult has no. Amma decides everything for him. In fact, one of the first things when you start in the early childhood, we tell mother is, you don't decide, kalyanathu pona vaida chungiya or t-shirt pottupa or chungiya or pant pottam. Parvala adu pottu pota. Illa madam marriage ku porthu. Avanukku adu irritate aarudhu. Adnal da avanukku anga meltdown arudhu. Adhe veetla irukra t-shirt pottu kalyanathu pona samatha irukkalam. He'll behave very well, because your perception is Wallahenna Solu. Right. We are putting this child and we are not listening to him. He is communicating at every point in time. I am struggling, Amma, or I'm struggling, teacher. Don't put me into I'm a square person. Don't put me in a round peg. He is communicating. Correct. We are not hearing. We are hearing but not listening, sorry. Because there are some speech and language that will kill me if I use the wrong word.
Definitely. So I think basically putting the adolescent or the young adult in the center of all the systems, I think that is what is most essential, and that's really well highlighted. One more thing, starting from that. See, when I see a child, I see a lot of children in the younger age group with developmental delay, intellectual disability and autism. Somehow I feel a little better. I might be wrong. There might be many people who are maybe opposing my view. But I feel a little more difficult actually for the children with high functioning autism. The reason is they'll come and tell us, ma'am, I'm somehow different from the others. I'm not able to talk to this person. I want to talk to that person. Actually, this girl came and gave me a letter, ma'am. I don't know how to respond to this girl, right? On one way, they want to express themselves and they have the cognition that they are different from the others, but they can't make a change. I feel they are more at a struggle sometimes than actually when the child is with a developmental delay, with an intellectual disability and autism, the burden is on the primary caregiver and lesser on the child. But of course, it's for debate. One thing in the same terms, ma'am. So when there is an adolescent like that, where an adolescent who is wanting their voice heard, wanting and striving for that autonomy, that dignity, that sense of self, how will you sort of integrate into that so-called function-based or compassionate care for adolescent, ma'am?
Yeah, so we normally when they grow as an adolescent, as you rightly said, many of them said they cannot accept no and they cannot say no. And sometimes they are not able to give the right choice. Even though they like something, they are forced to choose something. So Inga, we want to see something called ASAN-based intervention where we honor the child. The ASAN-based intervention is very, very important, where we are not going to be accepting the behavior or we are not going to ignore, but we are going to understand why the behavior happens first. And then understanding in what situation it is happening, that ABC model, we've already spoken in a thing. And after understanding the why, next is we are going to give them some words, communicating and giving an alternative way, which in way we are not going to do extinction. நீ இதை பண்ணி தான் ஆகணும், இதை பண்ணாதான் உனக்கு அது கொடுப்பேன் அப்படின்னு நம்ம சொல்ல போகிறதில்ல. We are not going to use some kind of a withholding the reinforcement or இல்லை உங்களை ஃபோர்ஸ் பண்ணி பண்ணாமல் உனக்கு பிடிக்கலையா சரி, as she rightly said, leave him at that point of time. Come back after some time and give more choices. அதாவது ஒரு reinforce இது வாங்கிறதுக்கு இது ஒரு தான் வழி இல்லை. There are many ways to get the reinforcer. So we need to give the ways. Okay, இதெல்லாம் பண்ணால் உனக்கு இது கிடைக்கும். So we are trying to teach the child the alternative ways for the same function. The function can be different. Maybe நம்ம நேற்று நிறையா we spoke about the functions of the behavior, and today morning also doctor said about the function of the behavior. So for the ஒரு ஃபங்க்ஷனுக்கு there are many ways to get that way. அவங்க குழந்தை எஸ்கேப் பண்ணணும்னா அழுது தான் எஸ்கேப் பண்ணணும்னு கிடையாது. அவங்க they can ask for a break. They can say, I will do later. There are a lot of choices the child can make. So we need to teach the child, உனக்கு நிறைய வழி இருக்குது இதை பண்ணாமல் இருக்கிறதுக்கு, இல்லை நிறைய வழி இருக்குது இதை வாங்குறதுக்கு. So we need to teach that alternative. At the same time, the child should feel honored. Okay, மம்மி அம்மா நம்ம சொல்கிறத கேட்டிருக்காங்க. So we need to honor. And another important thing, we need to teach the tolerance. And sometimes we know whether we like it or not, we do it. Because we have the tolerating skills and the waiting. We have both of skills. Children, they lose that. That's why they become anxious. And the waiting illadanaladha or anxiety varudhu and the predictability. So we have to teach this tolerance, and also we need to teach the waiting skills. So and making them self, we know when we wake up, we know, okay, this is our schedule. But children with ASD, they don't have a schedule. They're not able to tell what they're going to do. They say randomly, or they say what the father said, what the mother said, but they will not say what they want. So teaching them, telling to do a self-management, managing their behavior, rewarding themselves, and gradually bringing to the natural contingency of the reinforcement. Idellame nama train pannanom. That is the one I feel at this point of time we need to educate the parents to do the right thing and to teach the right way, what the understanding the child, the why, and honoring the child is the one thing which I tell as a take-home point.
Thank you so much, ma'am. So coming back to Shivalingam sir, I was just thinking, so we were talking about differentiating between adolescent-related behaviors worsening and mental illness or emotional illness where you're going to need medications. Where do you draw the line, sir? We had a nice session on pharmacotherapy, but how do you actually, in practice, tread this road with a parent? This is the most difficult thing. Writing a prescription is the easiest job. But how do you actually tread this road, and how do you do it?
First, we need to differentiate whether it is a behavior due to an environmental issue or some parental issue, or is it really a mental illness? We have all kinds of mental illnesses represented more than the general population in autism children. So right from depression, anxiety, bipolar disorder, OCD, ADHD, any kind of mental illness can happen. So we have to, if there is a clear-cut diagnosis, then we can go ahead and start with the medication depending upon the impairment in the functioning and the adaptive problems. So that's where we need to delineate between whether it is something related to an environment or it is really inert mental illness.
Sure. That's a very, very nice thing. So for parental inability to manage a behavior or for an environmental difficulty, don't start medications. I think that ma'am also very clearly highlighted a medication must have a reason to be started. Now, when I see a prescription with more than 2 antipsychotics and 1 SSRI, this is possibly not for the anxiety of the adolescent, it is the anxiety of the treating doctor. So, whose anxiety are we treating here? I think that is some reflection we have to do. Thank you so much, sir. Just coming back to you, because they come to a child psychiatrist, but they come to you on a regular basis. So when you know that is an adolescent with autism, they are on medications, how do you have to monitor the metabolic sort of paths, and do you think that is essential, and how can you effectively do it, sir?
Definitely, ma'am. Whether they are medication or not on medication, we routinely check the BMI, whether it comes under overweight or obesity. Especially on antipsychotics, means we have do surveillance in the gap of 3 to 6 months, doing routine anthropometric parameters plus biochemical, LFT, RFT, lipid profile, HbA1c, that has to be done, routine.
So I think psycho-educating the parents about that also is very essential.
Yes, ma'am.
Before it's too late, whether we can do proactive or some checks so that we maintain.
Otherwise,
that.
they land up in, they keep on buying the medication with the prescription. After a long time, they will come up with some other issues. When we evaluate, we find it out. HbA1c will be in rise, 12 to 14. Then we, பின்னாடி செக் பண்ண prescription பார்த்தா தான் தெரியும் எவ்வளவு நாளா அவங்களே மெடிகேஷன் போட்டுட்டு இருந்தாங்க.
So they have come for one problem and then they are getting treated for added advantage of diabetes type 1 or type 2 will also start in because of the glycemic control. So definitely. So ma'am, to you, you did start talking a little about the ICF model. Can you just elaborate that, ma'am? Because I want all of them to know so that we can effectively integrate it when we are managing an adolescent with ASD.
Whether it is a person with autism and intellectual disability at one end, or a person with autism without intellectual disability, they come from mild to severe. The ICF model here, it recognizes that strengths always coexist with supports and support mechanisms that way. So somebody with an intellectual disability may require a very individualized, long-term care plan of support, whereas somebody who is, we use say high functioning, this one, or late diagnosis of autism, they've already become adults and then a late diagnosis of autism, they may require support mechanisms. We all know that support mechanism is again a continuum. It could be something in terms of intermittent, limited support, all the way up to pervasive or extensive support. So somebody without intellectual disability but high functioning may require support only in critical stages. For example, managing intimacy and relationship. I think one of the previous speaker was talking about their gender identity and such other things. So those are the times in which they would require either an intermittent support for overcoming those little blip points that they may have. They will not require a pervasive support. The very thumb rule in the area of the ICF is participation. It's not whether my therapy goals has been achieved. How has my therapy goals resulted in him participating in the community, participating with... Don't expect him to chat up with friends, backslapping terms. No, it will not happen. You have to respect you have to accept that he's a person who is struggling with a lot of nervous system issues that he is struggling with. We need to respect that. But having said that, with a limited scheme of friends that he has, we may have to give him some scripts because he has what is called context blindness in a typical social situations. If you're supposing we give him a script and say that when you meet a lady, say this and this and this, and then he will just stick to that. But if he meets another lady who is already married, the same questions will not be applicable. So we need to walk him through those stages of how he can actually participate. The more success he or she gains in these kind of encounters will increase or enhance his participatory mechanism. So the thumb rule for each one of us who are working with child with disabilities, how has my intervention resulted in him or her participating in multiple contexts? It's not that I have achieved my goals, I have given the medication. No, that is not our goal. Our goal is to ensure that, ask the parents, இப்போ அவன் வேறு எங்கெல்லாம் பண்ணுறான், வேறு என்னெல்லாம் பண்ணுறான், ஏதாவது டென்னிஸ் மாதிரி கேம் எடுத்துகிட்டு இருக்கானா. ஸோ அதுதான் நம்மளோட யார்ட் ஸ்டிக் ஆஃப், ஏன்னா the word successக்கு மீனிங் இல்லை. நம்மளை பொறுத்தவரையும் where all he is able to participate. I would not like to use the word success and interventions. They are not equal in any this one. Participation is the only barometer for us to know that, hey, this boy within his limitations, he or she within his limitations, is able to navigate the social world it is. என்னோட அண்ணா கல்யாணம் ஆயிடுச்சு, எனக்கு எப்போ கல்யாணம் பண்ணுவேன்? Common question parents face. So
yeah, very true. That's a nice thing, ma'am. Like, because the sometimes the rigidity, the cognitive rigidity the adolescents have, like, and the children with autism have, is very, very difficult to navigate. Ninga sonna mari identification of the social nuances. If I see 2-3 people looking at their watches, what do I understand? It's not very interesting, possibly make it a little more lively. So just coming back to that, I'm going to add one small, one Vinay, like case Vinay Mari, like something. There was an inspector who was coming to a government school. And the government school teacher was trying to sort of set it all up so that everything goes fine when the inspector comes. So the first child was taught when the who made you, na, the first child must answer God made me. The second child was taught who loves you. Then the second child would answer God loves me, right? Unfortunately, the second child was a child with ASD who had that rigidity. And the first child had to go to the restroom when the inspector just walks in. And the teacher didn't realize that the first child has walked out. So the teacher comes in and then asks, who made you? So that second child says, ma'am, the boy whom God made has gone out, but still he loves me. So that is the cognitive rigidity which these children have. So just coming back and making it a little more active, just coming to you, ma'am, about this strength-based interventions. Basically, when you're looking at quality of life for adolescents with ASD, what can you do from a therapeutic perspective?
So as a therapeutic, you rightly said we have to start from the strength, and we also believe we have to start because, as I already said, when they are early we start with some of this deficit. Now we have to do the strength. And some of the questions a parent has to ask to themselves: is my child happy? That is one of the first question. And am I spending adequate time with my child? That is a happy engagement. Am I paired? Am I having a connect with the child? Is there a connection established between myself and the child? So I feel many a times the parent is in a high expectation or in a hurry or in a race. They fail to understand the child's need, and there is no connection. We say as a pairing, we pair as a positive bonding with the child. So that is something is missing. So as an intervention, we need to start by connecting with the child, understanding the child's current level, and keeping very basic, a minimal goal. You don't want to keep a very, very high goal. Just make sure you identify the correct goal that should be socially significant. That means that is important to the child, and the child is also needed to take the concern. Unakku idu pannalama. See, I have a child who has been 21 years, and the parent has come with some things, and the mother was asking a lot of things. Idu pannanu, adu pannu. Then I went and asked, what did you like to have? And he said that I like to have an ice cream shop. So the parent had a lot of expectations, like I want this, I want that, but the child wants to have a nice. So we should have a person-centered behavior plan is more important rather than the mother-centered one.
100%. I think there are a lot more questions we thought we must discuss on behavioral aggression, self-injurious behavior, social competence. I think we will have a lot more areas, but I think it would be good if we can take even a few questions with Rama ma'am's permission, of course, in case we have time. So just to sort of conclude by saying that definitely adolescent with autism must be the center of any therapeutic service, right? So I think that is the beauty of Center of Excellence, where they're trying to put that in the center to basically being able to facilitate that happen for the adolescent, right? So yes, there is a therapist, there is a speech therapist, there is an occupational therapist, there is a special educator, there is a psychiatrist, there is a pediatrician, but at the center of all is not even the parent, it is the adolescent or the young person with autism. So let's conclude with that and maybe
one point on that.
advocate for that.
One point I just want to tell, as they grow older, we need to reduce the support system the child should have. That should be the parents' thing. The child should not be dependent on therapies. We need to go to a natural environment, integrate into the natural. So our goal, how they are going to integrate into the natural environment, how this therapy should become less necessary. Right now at the early age, the therapy is most necessary. As they grow older, the therapy should be less necessary. We need to bring that kind of environment to the child, that kind of integrating to the community we need to bring.
That is exactly like from moving a specific situation to fading off that and integrating into the natural socialistic environment. That needs to be done. And
Transition for parents, ma'am.
Sure.
That's the main thing.
Sure.
Before the
Definitely, parents also must understand that I always say parenting is most difficult area, because when a child is born is when a parent is also born. Even if you get a mobile, you have a user manual. Unfortunately, we don't get a user manual saying like, tap my left shoulder and I'll stop crying. If I am doing this, this is my... You have it for everything else. We don't have. And unfortunately, when the child has a neurodiversity, like ASD, we are also relearning everything and trying to help the child in the best of our interests. So I think that transitioning in that support system is essential for the young person or the adolescent with autism, and definitely for the parent. And I think that holistic approach is what CoE is trying to do. And thank you so much for the opportunity. Thanks a lot.
Thank you so much to the panel for such a rich discussion on adolescence and autism. Let's now felicitate our moderator and panelists. I invite Dr. Rema Chandramohan to felicitate Dr. Satya Raj. I also invite Dr. Satya Raj to felicitate our panelists, Dr. Shivalingam, and Dr. Kapilan, and Ms. Jayamina Dhanapalan, and Mrs. L.V. Jaishu. For the kind attention, attendance sheets will be passed on. Kindly sign it, and row-wise the sheets will be passed. Kindly sign the attendance sheets, please. For our next panel on schooling and autism, I invite our moderator, Dr. Sudhakar sir, applied behavior analyst, to the dais. The panelists are Dr. Vimal Doshi Veerappan, psychiatrist, Dr. Vijay Lakshmi, pediatrician, Mrs. Sumitra Manoharan, Director, Balamandir Maduram Narayanan Center for Exceptional Children, and Ms. Ramalakshmi Kannan, special educator, counselor and psychotherapist, founder of Elena.
In the meantime, kindly sign the attendance sheets, please.
Good afternoon to every one of you. I'm Dr. Subhakar, student of Dr. Rama Chandramohan Madam. I always start with thanks to Dr. Sarada Suresh Madam, my teacher, my mentor who introduced me to development pediatrics, and Dr. Rama Madam who introduced me newborn examination and so on. I have to thank Center of Excellence, Tamil Nadu government for making it such a big event. Usually we say government is a very big elephant. It moves very slowly. But the impact is very big. You can never stop it. And luckily in autism, I'm seeing the government is a fast moving elephant. It is making a very big impact and very colorful also. Of late I'm seeing many programs, variety of programs, and the conference also added to that. Thank you for organizing such things. And more than managing autism, it may be very difficult to keep you awake at this hour after 1 hour of a beautiful, very fantastic lunch, because what happened after having a good carbohydrate rich lunch, the carbohydrate, what happens? Our sugar level increases, insulin, competing insulin increases, it pushes the tryptophan into the brain, and tryptophan converts to serotonin, and we go for sleep. So if you sleep, it is not our fault. It may be the food they serve. With these things, thanks to the previous chap, their wonderful discussion on adolescence. We are not mature, we are going down. Schooling and autism, and another very difficult area. Every therapist will find it difficult, every parent will find it difficult actually. I have an excellent combination of panelists here, and we have to thank autism is the one disorder which connects everyone together. Everyone to feel the same level of ownership. If you go cardiology, we cannot get connected, other things we cannot. But autism is the only condition which connects equal responsibility, equal ownership, and we all feel that we need to do something. It creates a lot of passion. I was talking to many, observing many people, talking with a lot of passion. I want to do something for that actually. Of course, we are not able to do anything much. But still, we have the passion to do that actually. Long way to go. So, we are starting with this schooling and autism. So, let me introduce our panelists. Dr. Vimal Doshi, you can understand, a very big claps are done. So, we know what is his credibility. We worked as a colleague in Institute of Child Health. He was in psychiatry and I was in the child development. Dr. Vijay Lakshmi, our junior, he was the pediatrician, CoE. Mrs. Sumitra Manoharan, the person whom I want to work with actually, the director of MNC, and Ms. Ramalakshmi Kannan Madam, founder CEO of Elena Services, found to be very active in our group. So schooling and autism, we talk more about inclusion, but we more talk about inclusion, but we may not be practicing it, not yet started practicing much in the private sector. For that, we need to understand, we need to empower not only the children, parents also. Empower the school administrations, educationalists with knowledge. So let me directly go into the questions. Dr. Vimal, do children with autism struggle to cope with mainstream education?
A very good afternoon to one and all. I thank Professor Ramachandra Mohan for giving this opportunity. Sir, again, this depends on the child. In fact, many normal children have a struggle in schooling system, and I too had a struggle in schooling system. Now also I had a struggle in my colleges. So it doesn't come as a surprise that children with autism have a struggle because they already have a burden of making them understand to other people and do things. And I feel it's mainly depends on certain factors of the child as well as certain factors of the school as such. The factors which I would say is more important is intelligence and functional communication. If intelligence and functional communication are on point, the other factors can be easily managed with the school management. So these are the two things which I would like to emphasize. As with respect to school, just as people have personalities, schools also have personalities. There are one group of schools which I know which focuses only on marks. It doesn't focus on the child as such. My school has to get mark, this particular student has to get mark, irrespective of the hardship the parent or the school, the parent or the student is going to undergo. There are those group of schools which are performance-oriented school. The other group of schools are those schools which look child as a whole and understand the difficulties child goes through and take their hand and go along with them with their difficulties. So if the school personality is compatible with the child's personality, then we are going to face very less difficulties and friction. If they are going to mismatch, just like in a marriage, obviously we are going to find it very hard to reach or bridge these two gaps. This is what I would like to say, sir. Thank you.
So the point is here, normally making an IQ assessment lesser than 6 is very difficult actually. Then when children with autism, again, we all easy to make a diagnosis of autism and not, most of them it may be misdiagnosis by observation. So easy to make a diagnosis of autism, but what is the IQ level or cognitive level? That is another very difficult area to make it in children with autism. So I rightly point out at that, what is the level of functional communication and cognitive development in the child? We need to consider, and other factors we will discuss in that. So, Dr. Vijayalakshmi, what are the behavioral challenges expected in a school-going autism children? Because you are now working in the CEO with more number of children, you will be facing the difficulties.
Yes, sir. As sir rightly said, even a normally developing child would have many difficulties in coping up with the school environment. As comes the autistic child, he'll have even more behavioral issues depending upon his communication difficulties, sensory issues, and his developmental level. So behavior thus becomes a mode of communication for them. These children would find difficult to sit in a place, to pay attention to the teachers. They'll show temper tantrums frequently. They'll have very rigid schedules. So any change in the schedule will make them, melt down. And even the social adaptability with their friends and the children in the class will make them more sensitive. Like they can't wait for their turn to participate in school activities or programs or activities given by the teachers. They may have sensory difficulties like overcrowding may be very difficult for them to accommodate. Over lighting, over sound, these all will hamper their attention to class, attending the class.
So normal itself, the age is lesser than the early age group, lesser than 5 years, behavioral problems is a normal. Many times the hyperactivity, we cannot differentiate whether it is a age appropriate or age inappropriate, especially in a child with autism who is having a, for everything, B is equal to C. Every behavior is a communication in a child with autism spectrum disorder or any child with communication problem. So whether it is a normal age-related or age-appropriate behavior or it is related to some behavior. Because many times we ourselves may have a very poor understanding about analyzing the behaviors. It is very easy to fix everything into ASD spectrum. So we need to be very thorough. And another thing, rightly, Shivan, what is the social adaptive level? So he rightly points in what is the cognitive level. She rightly pointed out that social adaptiveness. So these need to be considered before you plan a child for a school. And we need to understand what are the normal behavioral problems, age-related problems. Very simple example, a 3-year-old child will have an separation anxiety. Normally what happens in the first preschool, LKG or preschool, they cry a lot and vomiting, everything. All kind of chaos they'll make actually. It may take 1 to 2 months to settle with for a normal child. You imagine what it is. Angiyad we understand he will settle. Here we don't know whether he's going to settle or not. So whether the child is in a confused state, most of the time we will be in a confused state actually. So we need to understand what is the basic level. Is it age appropriate or age inappropriate? Then we need to approach the child. So Dr. Vimal, again to you, how to differentiate the comorbid condition from a behavioral issues due to autism in a school going child? It's a very difficult thing actually, because they are all cousins. Autism, ADHD, all these things are cousins, they come together most of the time.
As I told you, as you pointed out very well, sir, comorbid condition is the hallmark of child with autism spectrum disorder. In fact, the comorbid condition causes most of the impairment rather than the autism itself. For example, language impairment is a comorbid condition of autism. Intellectual impairment is a comorbid condition of autism. And ADHD is a comorbid condition of autism. So, comorbid conditions, the general rule with respect to psychiatry is, if there is a new behavior, whether it is a challenging behavior or an adaptive behavior, we are going to be bothered only about challenging behavior of the child. If it is a new behavior in a stable child, then please rule out medical condition as a cause of behavior, because these children usually express even their medical problems through behavior. And then once you rule out medical conditions or the side effects of medication with the child, because seizure disorder is going to be 30% common in children with autism. So most of them might be on anti-epileptics. Any changes in dosage of anti-epileptics or side effects of anti-epileptics will manifest as behavioral problems. So medical condition, ear infection, a seizure disorder medication side effect, even a psychiatric illness will manifest as behavioral problems. So all behavior should be looked into these three lenses before even we can think in terms of starting a behavioral plan or things. So once these three conditions are ruled out, then we have to decide. But the question here is how to differentiate. Again, the differentiating feature between an emotional disorder such as an anxiety disorder or a depressive disorder or a psychotic illness in an adolescent or an ADHD in a child with autism spectrum disorder is going to take serial observations, history from multiple sources, observation, directly the observation in various places, and then only we can be able to make a decision whether this is going to be a comorbid psychiatric illness requiring independent treatment or a behavioral problem or a challenging behavior associated with autism, which requires probably more of an environmental adaptation rather than treatment for the child. So these are the things we need to focus on, sir.
So we know that ADHD, anxiety, depression, they may come earlier also, and many times the rigid behavior may present like an OCD, early onset of OCD. It's a really very confusing area. We need to take the help of pediatric psychiatrists. Never make a simple diagnosis of that. I never take a diagnosis of the comorbid condition without the help of pediatric psychiatrists actually. And another thing, I have one more question. Do we have any psychometric analysis method to differentiate? Because many times we put the self-engaging activities and hyperactivity. Many times we have seen that self-engaging activity misinterpreted as an hyperactivity and would have been started medications actually.
So any investigations related to?
Psychometric analysis to say it is ADHD and ASD or something like that.
Purely, just like diagnosis of autism is clinical, the comorbid conditions of autism is also purely clinical. So because, for example, as you said, the OCD in a particular child is going to manifest very differently from OCD in a other child. Both can have the same diagnosis of autism, but the manifestations of compulsive behavior, manifestations of obsession depends on, again, each individual child. So it's more of a clinical. After we make a diagnosis of clinical, then you can use a psychometric tool to assess the severity. But no clear-cut psychometric tool to differentiate that this is behavior problems or challenging behavior associated with autism and this is psychiatric comorbidity. As Professor Satyaraj has already pointed out, what is more common in these group of people, especially in children with intellectual disability and autism spectrum disorder, what we call as diagnostic overshadowing. We find a child who has been regularly attending speech therapy, occupational therapy or special education, suddenly the child is withdrawn from therapy and not going to go to school and uses screen as a means of escape from the negative mood. It's actually a sign of depression. We attribute that as a behavior problem associated with intellectual disability and autism spectrum disorder. We try to find solutions for it behaviorally. That is what is diagnostic overshadowing is. In fact, the comorbid diagnosis are overshadowed by the primary diagnosis of autism. So that should be the caution when each and every pediatrician and psychiatrist comes across new behavior in a child with autism spectrum disorder or intellectual disability.
Another important thing, medical condition is the constipation is a very important thing actually. Disturb the child presenting with the behavior problem and sleep deprivation, sleep issues. These are the things whenever you come across a child with behavioral issues, please go through the medical and psychiatric condition. For medical by history, clinical taking history and examination give it. For other things, we need to take the help of pediatric psychiatrists and make a then you start managing it actually. So Dr. Vijayalakshmi, what are the expectations about school education among parents when they meet with a pediatrician at Center of Excellence? Because you are seeing the maximum numbers.
Sir, first of all, they'll want to know whether they can put the child into the mainstream school, inclusive school, or special school. And then they want to know about their child's strengths and their difficulties so that they can focus on that area particularly. And then the developmental level of the child, to which standard or mental age they are, so that they can put into the appropriate class and section, class into the class which they need. And then they would ask if, they would like to know about the inclusion criteria of the school, like if they have special educators there, if the child needs a special educator, 1:1 teaching, speech therapy and OT therapy is needed in the school itself, or should it be done separately? And then the safety issues for the child, like if the child, the school environment should not be bullying to the children should not be bullying the child. Other safety precautions like light sensitivity should be looked upon, sound hypersensitivity looked upon. And then how the teachers are trained there or experienced there for their child.
So you are meeting the most smart parents, I think. So they're very knowledgeable. I understand that actually. Because many times parents come to me, "Eppadi sir, பையன் படிச்சு டைரக்டா அப்படிங்கிற மாதிரி தான் இருக்கும். Many times, yeah, it's an expectation of any parent. நம்ம குழந்தை பிறந்தோன்னு டாக்டர் இன்ஜினியர்ஸ் லேபிள் பண்ணுற மாதிரி தானே. So any parent's expectation has to be respected properly and properly guided. So Sumitra madam, the question comes to you now. The parent comes to you. She has already pointed that is it mainstream or special school or inclusive? Which one is the right choice?
Yeah, she told me the first line of my talk. Any parent goes and meet a doctor or when they come to us, first question is, என் பையன் ஸ்கூலுக்கு போயிடுவானா? அதுதான் முதல் கேள்வி. I'm also a parent, for your information. So I've been in this field for, my son is now 37 years. So I'm in this field for the last 30 years. I've been in this field. And so யாரை பார்த்தாலும் இந்த கேள்வி கேட்குறாங்க. ஒரே லைனில் அதுக்கு ஆன்சர் சொல்ல முடியுமானா, I'll be very, very happy. I'll be the happiest person. பட் அப்படி ஒரு லைனில் சொல்ல முடியாது. பிகாஸ் நீங்கள் ஸ்கூலுன்னு டிசைட் பண்ணுறதுக்கு முன்னாடி ஃபஸ்ட்டு we have to understand the child and his difficulties or strength, everything both நீங்கள் ஃபஸ்ட்டு முதல்ல அண்டர்ஸ்டாண்ட் பண்ணணும். அது முதல் ஸ்டெப். நெக்ஸ்ட்டு வந்து கேள்வி என்னென்னா, எல்லா பேரண்ட்டுக்கும் அவன் எழுதுவானா மிஸ், அவன் படிப்பானா, அந்த ஸ்கூலில் போயிருந்தால் அந்த ஃபாலோ பண்ணுவான்ல, ஸ்கூல் இதெல்லாம் ஃபாலோ பண்ணிவிடுவான்ல. நீங்கள் 2 hours சொல்லி முடிச்சதுக்கப்புறம் இந்த கேள்வி வரும். 2 hours நான் பேசியிருப்பேன் அந்த பேரண்ட் கிட்ட, இது இப்படி இல்லைம்மா, இது இப்படி இல்லை, அதெல்லாம் உங்களுக்கு போயே இருக்காதுன்னு நினைக்கிறேன். அப்புறம் என்ன கேட்பாங்க, மேடம் ஸ்கூலில் போனோடனே எழுதிடுவான்ல, படிச்சிடுவான்ல. நான் சொல்லுவேன், இதெல்லாம் கேட்கறதுக்கு முன்னாடி நான் உங்களை 2-3 கேள்வி கேட்குறேன், அது நீங்கள் ஆன்சர் பண்ணுங்கள். அவனுக்கு அண்டர்ஸ்டாண்டிங் இருக்குதுன்னு உங்களுக்கு தெரியறதா, இல்லை அண்டர்ஸ்டாண்டிங் இருக்குதுன்னு உங்களுக்கு தெரியறதா? இஸ் ஏபிள் டு கம்யூனிகேட், இஸ் ஏபிள் டு டூ ஹிஸ் ஓன் செல்ஃப் ஹெல்ப் ஆக்டிவிட்டீஸ், அதெல்லாம் அவனால் பண்ண முடியாதாம்மா, அது சொல்லுங்களேன், எனக்கு கொஞ்சம் தெரிஞ்சுட்டு அப்புறம் நான் உங்களுக்கு எப்படி கைட் பண்ணோம் நான் கைட் பண்ணுறேன், அதெல்லாம் சொல்லுங்கன்னு ஆரம்பித்த உடனே அவங்களுக்கு கொஞ்சம் அழுக வந்துடும். மேடம் அங்கேருந்து காட்டுறாங்க அழுக வந்துடும் அப்படின்னு. அப்புறம் நான் சொல்லுவேன், இல்லை கவலைப்படாதீங்க, பிகாஸ் எனக்கும் தெரியும் அது எவ்வளோ கஷ்டம்னு. நானும் ஒரு ஸ்டேஜில் அதுலேருந்து தான் இங்கே வந்திருக்கேன். ஸோ ஐ நோ இட் இஸ் வெரி டிஃபிகல்ட். பட் ஐ வில் ஆல்வேஸ் திங்க் பிஃபோர் டிசைடிங் டு அகாடமின்னு நினைக்கிறதுக்கு முன்னாடி ஒரு ஸ்கூல் ரெடினஸுக்கு என்னெல்லாம் தேவைன்னு நினைக்கணும்னா, ஃபர்ஸ்ட் we have to know that he can communicate well, then he will be independent in his self-help skills, so that it will be easy for him wherever he goes. As rightly somebody mentioned, the waiting for his turn should be there, sitting tolerance should be there, then attention should be there. இதெல்லாம் இருந்துச்சுன்னா இதெல்லாம் ஸ்கூல் ரெடினஸ்ன்னு சொல்கிறோம். ரெடினஸ், நாட் ஃபார் அகாடமிக் ரெடினஸ். So before you think about academic, you must think about school readiness First, if you see, then you can take him to the school. So when usually what we do, enga kitta varumbodhu namba enga age la na munadi early years la I used to see children when they are here referred at 3-year, like autism children உங்களுக்கு எல்லாருக்குமே தெரியும் அவங்க ஐடென்டிஃபிகேஷனே ஆஃப்டர் about 2 years 2.5 years தான் அவங்களுக்கு தெரிய வருது. நிறைய பேர் எனக்கு மார்னிங்லேருந்து பேசுனாங்க. ஈவன் டாக்டர்ஸாக இருந்து அவங்க சன்னை அவங்க கண்டுபிடிக்கும் போது தேவகி மேடம் கண்டுபிடிக்கும் போது 1.5 yearsன்னு சொல்லிட்டாங்க. ஸோ அப்படி இருக்கும்போது மற்ற பேரண்ட்ஸுக்கெல்லாம் உங்களுக்கு தெரியும் பேசலை, when he is not talking, that is the only thing they would have noticed. மேடம் பேசலைன்றதுனால தான் நான் டாக்டர்கிட்ட போனேன். அவங்க ஏதோ ஆட்டிசம்னு சொல்லிங்க. சார் சொன்ன மாதிரி எங்களுக்கு வரவங்கெல்லாம் இந்த மாதிரி தான் வருவாங்க. ஸோ அவங்க வந்தோன்னா அவங்க ஏதோ சொன்னாங்க ஆட்டிசம்னு. நீங்கள் என்ன சொல்கிறீங்க, ஸ்கூலுக்கு போயிடுவான்ல, இப்போ நீங்கள் ட்ரைனிங் கொடுங்க, என்னன்னு சொல்லுங்கள், நீங்கள் ட்ரைனிங் கொடுங்க. அண்ட் ஒன் மோர் திங் தே வில் சே ட்ரைனிங் கொடுங்க. தென் ஐ வில் டெல் நோ, ட்ரைனிங் கொடுக்கலாம், நம்ம 2 பேரும் சேர்ந்து ட்ரைனிங் கொடுக்கலாம், நீங்கள் 50%, நான் 50%. ஸோ I will tell them that we have to work with the child and get it ready. So நாங்கள் 3 years வந்தாங்கன்னா எங்ககிட்ட வந்துட்டாங்கன்னா we'll see that they are having at least ஒரு 60% of their age appropriate behavior. Like 3 years இருக்காங்கன்னா ஒரு 2 years 2.5 years அந்த மாதிரி இதில் 2 yearsல 2 years and 2 years 1 month அந்த லெவலில் இருந்தால் கூட 1 year நாங்கள் ட்ரெயின் பண்ணிவிடுவோம். இந்த ஸ்கூல் ட்ரெயின் பண்ணி அடுத்த 1 years அகடமிக் ப்ரீ அகடமிக் ட்ரெயின் பண்ணிவிட்டு we have placed. இது வரைக்கும் எங்கள் மாதவரம் நாராயண் சென்டர்லேருந்து 143 சில்ட்ரன் நாங்களாவே கொண்டு போய் பிளேஸ் பண்ணிவிட்டு 3 years we do ஹேண்ட் ஹோல்டிங் ஃபார் தெம். எங்ககிட்ட கம்ப்ளீட் பண்ணாமல் போகிறவங்க நிறைய பேர் இருக்காங்க. பட் ஆனால் கம்ப்ளீட்டாக எங்களோட நாங்களாக செலக்ட் பண்ணி இவங்க பண்ண முடியும்னு போனவங்க டிகிரி படித்தவங்க இப்போ எனக்கு தெரிஞ்சு 10 பேர் இருக்காங்க. எல்லாரையும் ஃபாலோ பண்ண முடியல. இட்ஸ் நாட் அ வெரி பிக் டேட்டா. பட் எங்களுக்கு தெரிஞ்ச வி ஹேவ் கனெக்ஷன் பிகாஸ் ஐ எம் ஆல்சோ பேரண்ட், வி ஹேவ் பேரண்ட் குரூப். அதில் கனெக்ஷன் இருக்கவங்க ஒரு 10 பேர் டிகிரி பண்ணியிருக்காங்க. ஸோ இதெல்லாம் நடந்துகிட்டு இருக்கு. பட் ஆனால் எந்த ஸ்கூலுன்னு கேட்டால் நாங்கள் போகும்போதே சொல்லிடுவோம், ஸ்கூல் ஷுட் ஹேவ் சம் க்ரைட்டீரியா. தே மஸ்ட் பி லெஸ் சில்ட்ரன் இன் தட் கிளாஸ் ரூம். ஒரு 20 children 25 children உள்ளே இருக்க மாதிரி ஸ்கூல் ஷுட் பி ரெடி டு அக்செப்ட் அஸ் as a professional to come and talk to them about the child and give report and then place them, then continuously அவங்களுக்கு சப்போர்ட் கொடுக்க முடியும்ன்ற அக்செப்ட் பண்ணுற ஸ்கூலில் இருந்தாங்கன்னா then all this happens. But there are, I have faced, I myself have gone to many schools where they will say, ஆனால் ஒன்று புரிஞ்சுக்கணும் பேரண்ட்ஸ், நிறைய ஸ்கூல் they are not equipped because அவங்களே சொல்லிடுவாங்க எங்களுக்கு ஸ்பெஷல் எஜுகேட்டர்ஸ் இல்லை, or we are not ready still, we don't have teachers to train the have the children here. ஸோ அப்படி சொல்லிடுவாங்க. பட் மற்ற ஸ்கூலில் சில பேர் எங்களை நாங்கள் எடுத்துக்க மாட்டோம், இந்த மாதிரி குழந்தைங்களெல்லாம் வச்சுருந்தா எங்ககிட்ட இருக்கோம் நார்மல் சில்ட்ரனோட, ஐ மீன் டிபிக்கலி டெவலப்பிங் சில்ட்ரனோட பேரண்ட்ஸ் தேல் கோ ஆஃப். ஸோ எங்களுக்கு வந்து வி cannot take in on my face, many have told. But still I have seen from that time to now there are many schools which have inclusive setup they take, but only thing it is still costing high. If so, you have madam, a special child,
madam, I would say that here actually. So our dream is every mainstream should be a real inclusive. Yes. In the practical reason, real inclusive, not on paper. So special school are meant for children with intellectual disability or so many severe other comorbidities. Can we put it that way? So only 2 things. One is mainstream, one is a special school. Dr. Vimal, your opinion, just one line.
Yes, sir. Opinion on what, sir?
Whether to select mainstream, because many times parents ask me, mainstream போடுறதா, because nowadays a lot of special schools also coming actually. Schools for neurodiverse conditions.
Illa sir, rather than looking at mainstream, special or inclusive, we will choose the curriculum. For example, there are gifted children in autism. Exactly. So gifted children in autism க்கு அவங்க வந்து they can even go for advanced schools. எங்ககிட்ட ஒரு குழந்தை வந்து இப்போ ஐஐடியில் இருக்காரு, integrated physics 5 year course படிக்கிறார்.
So my question is, from the parent perspective, this question comes to you. In a short answer, what we can give?
About?
Selection of schools.
It depends very on the child.
Again,
depends on the child's level as far as
IQ das.
Yeah, cognitive level of the child.
IQ and language. இப்போ வந்து ஆஃப்ஸ்லேட் வந்து முன்னாடி ஃபைன் மோட்டார் ஸ்கில்ஸ்லாம் இன்க்ளூட் பண்ணிட்டு இருந்தோம் ஸ்கூலுக்கு. ஆனால் இப்போ வந்து நம்மளே கடைசியாக எப்போ சார் பேனா பிடிச்சி லெட்டர் எழுதியிருக்கோம் ஒரு 2 பக்கத்துக்கு, எழுந்ததில்லை. ஸோ இப்போ வந்து மோஸ்ட் ஆஃப் த ஸ்கூல்ஸ் we say that you can use voice activated mechanisms or and schools are ready to, there are certain schools, madam sonna mari not everybody, there are certain schools who are ready to accept even typing as well as orals answers and idalam pandranga. So I would say language and cognition are the 2 determining factors. General neenga vandu oru specific answer kekringa, if IQ is going to be above 70 irrespective of the severity of autism, then or mainstream education we can try.
Yes. Otherwise, thank you, sir. One more thing I wanted to add, sir. Now it's a boon like NIOS has come. So many children in that moderate, they are able to, with the support and good training, they're able to pass 10th and 12th in the thing.
Yeah.
It's a boon. Years back it was not there.
Ramalakshmi madam, what are the limitations prevailing in our system at present, and any solution in a shorter thing? I know it's a very big essay question.
So, having doctor already told that it's a very wide range, so I'll just bring a small anecdote here. So we all know vanilla cake, right? Vanilla cake, chocolate cake, marble cake. There is also a cake called CoE lapis. How many of you know CoE lapis? So it's a Indonesian Singaporean delicacy basically. So it's a very carefully made cake made of like around 11 to 12 layers spread, thin layers spread. So every cake has its own, skill set, its own taste. Some of us like chocolate cake so much that, we obviously forget all our dietary restriction. Some of us, really would want that delicacy. It's obviously, priced high. It obviously needs that kind of skill set to make that kind of a cake also. So when we talk about limitation, I wouldn't look at it as a limitation. I will look at it as a challenge, which we all need to rise up to. So that is what I would look at. So having said that, sir, if you can just show the visual. So I'm a very visual person, so I wanted a visual that you can all relate to when it comes to that. So like I told you that there are layers, even the challenges that we are facing in terms of, inclusion has layers. So while I say layers, the bridge is also a very good anecdote. Like, you have to bridge between these four things so that, the child can achieve participation, belonging, learning and growth, which we all strive for at their level. But what are all those four layers nu paathom appadina? First vandu munadi placement nu irundhathu, eppadiyaadu kulandai vandu school la sethunadanum அப்படிங்கிறது. But now we are moving to participation. So it's not just about placement. ஏதோ ஒரு ஓரத்துல உட்கார்ந்துட்டு போறான் அப்படிங்கிறது கிடையாது. The child has to participate. So that is the first layer. Second thing is individual expertise. I think the last panel they kind of addressed this very beautifully, where we cannot work in silos anymore. So it needs that collective responsibility. So that's the second layer. The third layer is, okay, வருஷத்துல ஒரு தடவை எல்லா டீச்சரையும் கூப்பிட்டு ஒரு ட்ரைனிங் கொடுத்துடுவோம். And the teacher will be ready for the inclusive. I know teachers are all Maha Shaktis and Kalis with so many hands and so many weapons. That's how we portray. But then in reality, when it comes to an inclusive classroom, it does require a lot of ongoing support. So that's the continuous capacity building that we are looking at, which is the third layer. And the fourth layer or the fourth challenge that we are facing is child focused support. அப்படிங்கிறது வந்து இந்த குழந்தைய எப்படியாவது நம்ம இந்த ஸ்கூலில் கொண்டு போய் போடணும்னா என்னெல்லாம் ரெடி பண்ணணும் அப்படிங்கிறது அந்த பேரண்ட்டுக்கு இருக்கிற ஒரு ரெஸ்பான்சிபிலிட்டியாக மட்டும்தான் நம்ம பார்க்குறோம். பட் பியாண்ட் தட் இட் இஸ் ஆல்சோ த ecosystem readiness. So the teacher has to be ready, the school environment has to be ready, the parent has to be ready, and the therapist also have to look at a slightly wider angle where they have to look at என்னோட செட்டிங்கில் பண்ணுறான்னா ஸ்கூலில் பண்ணுவானா, வீட்டில் பண்ணுவானா, சோஷியல் கம்யூனிட்டியில் போய் பண்ணுவானா. ஸோ ஆல் தீஸ் திங்ஸ் ஹேஸ் டு கோ இன் டேர்ம்ஸ் ஆஃப் ecosystem readiness. ஸோ இந்த 4 லேயரை நம்ம கரெக்டாக அட்ரஸ் பண்ணினா மட்டும்தான் நம்ம வந்து we can move towards the child's success criteria, whatever we call. ஸோ இப்போதைக்கு இருக்கிற challenges அப்படின்னு பார்த்தா இதுதான். சொல்யூஷன் அப்படின்னு பார்த்தா for the first thing like placement அப்படின்னு பார்க்கும்போது belonging and participation and learning-ஐயும் நம்ம மெஷர் பண்ணணும். இட்ஸ் நாட் அபவுட் இவ்வளோ நேரம் அவன் கிளாஸில் இருக்கான், ஹாஃப் டே இங்கே ஹாஃப் டே அங்கே இருக்கலாமா, அதெல்லாம் கிடையாது. லைக் how can we measure that? The second இதில் பார்த்தோம், செகண்ட் சேலஞ்சுக்கான சொல்யூஷன் அப்படின்னு பார்த்தோம்னா how do we share the goals, how do we coordinate the planning and how do we communicate? ஏதாவது ஒரு பிஹேவியர் ஸ்கூலில் வந்துச்சுன்னா 10 நாள் கழிச்சு தான் தெரபிஸ்ட்டுக்கே தெரிய வரும். தென் behavior would have either gone to the next level or it would have disappeared. There is no point there. So communication has to be taken care there. Second thing is ongoing training for the teachers has to be there. If you expect the teacher to address an inclusive classroom, we need to spend some time here and then prepare the teachers, peers, classrooms and families along with the child in whatever capacity. It's not that 100% everything has to be ready before the child goes there. In some capacity, we have to start. So when we look at it, it looks like more work, but actually it's not more work, it's different work. So that is what we need to look into. So what I have come to understand from my experience so far is that children don't experience me or that child. The நானா இருக்க கொண்டு ஒரு டீச்சரா அந்த child shape பண்றேங்கிறதெல்லாம், I mean, we say it for our own இது, but what the child really experiences is the quality of our collaboration. Everybody speaks the same language. Everybody is actually, coming to the same page. They are not confusing me, for God's sake. So இதெல்லாம் தான் வந்து the child will experience. So that's
so
what.
First level, what I understand is, understanding at an educationalist level, they have to understand autism is modifiable. It is not a neurodivergent. Just like that, we cannot omit. They are all modifiable. One thing, they should have a good knowledge about the symptoms as well, behavioral things actually. They should understand. And another limitations, the number. Even normal children struggle to learn. The teacher one teacher for 48 students. She is not understanding whether he is not aware that children are understanding it. Many times children comes to us actually, parents கூட்டிட்டு வந்து, sir மறந்து போறோம். For them, they blame the teacher, student, that child is not giving adequate, concentration, something like that. We never consider whether child has understand the subject at or not. Makeup பண்ணி 10th வரைக்கும் வந்துட்டோம். Our system was like that. Now everything crashed. Now we have to understand, especially CBSE. Madras is a place where everywhere CBSE schools are there. நம்ம போடுறது எங்கே போடுவோம்? சிபிஎஸ்சி ஸ்கூலில் தான் போடுவோம். There you need to understand each and every line. Unless you understand, you cannot memorize things. So that is for a normal kid அவ்வளோ கஷ்டமாக இருக்கு. I can understand that CBSE mathematics is one of the toughest thing nowadays actually. Becoming more and more tough. And we are putting our children in, and then they really struggling to communicate. Where is the point of learning that? So we need to sensitize, rightly pointed out, continuous education of the educationalists. That is a very, very important. Even now, we are not reached a level of at least 1 day, half day. I have done more than workshop for more than 750 teachers last 1 year itself, but I know how difficult to do it. It's very difficult to keep them even for 4 hours together, because their world is different, their challenges are different. I cannot blame school system. We need to sensitize them and make them to take the ownership on their own. So we have a limitation. We cannot put the blame on anyone else, but we have to keep on. Can I go back? A lot more questions. Okay. Madam Sumitra, madam, in a short way, because we have only 20 minutes. How to prepare an IEP for every child? Is it possible? First question.
Yeah, 100% it has
Who
to
will
be
do?
possible.
Is it possible? Who has to do? Who has to sensitize the school
Sir,
system?
we cannot have a common, as we were talking from the morning, நீங்க பார்த்தீங்கன்னா autism, one child மாதிரி இன்னொரு child இருக்கவே இருக்காது. அது என்னன்னு கண்டுபிடிக்கிறதுக்கே அவ்வளோ இது சொன்னாங்க காலையில் சார். I got so confused. No, அதுவே கண்டுபிடிக்கல. அப்படி இருக்கும்போது how can we have a same syllabus and fit in the children there? We should not do it. Anywhere, even in a special school or in a inclusive school or in a mainstream school, when they are taking the special child, they have to do an IEP. IEP is, you all know, it is an individualized education plan where you have to do the assessment is the first step for it. So unless you do the assessment, how will you know where the child is functioning? So once the child, we know the child is functioning, if we know the strength and needs and keeping their likes and dislikes, everybody were talking, we have to sit and do the lesson plan for them, where we also strategies, everything we have to put in, and we have to monitor it regularly in intervals, so that sometimes the child would have achieved the goal very fast, or sometimes the strategies we may have to change, or sometimes what the lesson plan also will be not very suitable, so we have to do. And we can give adaptation, all that we can add. So IEP is the answer for the child's progress, and
so
in
IEP
his life,
need to be
it's a
planned
living
by
documentation. Yes.
IEP need to be a planned by the therapist with the parents, with the school
yes,
teachers.
with the school teacher. All put together, they have to plan.
It's our dream and it is our aim.
Sir, it is happening in some schools, as I told you, we have worked on it, but not every school is thing, but now they have got resource room and thing. When they are approaching, parent itself must see whether the school, as she rightly mentioned, whether the school is suitable for the child, whether they have that, trained teacher, then it is, we can do this.
I have met many principals and correspondents who have a lot of one-to-one discussion. They are doing sympathy, everything. They are showing sympathy for that. They understand. They say, yeah, we are that. And I used to tell them, it is not happening to someone. If you calculate the prevalence, every extended family will have one child. So it's our own family member is also going to have in 2050, I don't know. Now it is rising to 1 in 34, it's May 32, and the world may become complete, then it's no problem. So we pray either we should correct it or either all of us would become autistic. That's the best answer, I would say. So the schools are not aware. They may have sympathy, but they are not empathetic or they are not ready to accept. Our long way to, I already introduced, there is a long way to go. So is there any special education meant for children with autism spectrum? Dr. Vijay Lakshmi?
Sir, as ma'am told already, each autistic children is different from each other. So we cannot generalize teaching methodologies. Each child should have a unique educational program. Otherwise, depending upon the child's learning capabilities and capacity, we can teach them through visual specs method, or we can do A/B analysis, we can do task analysis, give them short and small steps to learn things, or storytelling, social storytelling.
Fantastic.
Teach them in good behaviors and other morals also through stories. Even daily routines can be taught to them through not stories, then through rhymes. Include music with them. Then we can.
So we don't have a separate plan for that. Yes. Every mother has to become a teacher here. Like every mother has to become a therapist. Here the mother has to become a teacher. Visual things, task breaking the task into small steps and reinforcing everything.
Play activities, sir.
Play activities, social stories. So the parents has to be enriched knowledge about these methods. Again, it is going to be individualized. So every education happening in the classroom has to be, I'm sorry to say mothers actually, parents, grandparents, the whole family has to get involved in that actually. As of now, if you go to the internet, we can in abroad, US, they have a lot of labels for that. So many things of even pre-kindergarten assessment, checklist for us, preparedness of entry into school system. There are a lot of things actually. Of course, whites are very good in that. They label for everything, put a label for everything. And we don't have such things, but we have to help our parents to excel in all these things. With that, definitely our children can excel in that actually. So what is the RPWD Act 2000 actually guarantees? Ramalakshmi madam, you are the right person to talk about it.
Yeah, hopefully. So guarantee is a very strong word. According to me, I feel, the visual please. According to me, I feel yes. So the guarantee is access. This is according to me. So access is the guarantee. But how we can bring it to implementation is something that we need to really think about, because access in the sense the right to education and non-discrimination. So that's what it says. So we cannot discriminate anybody, we can give access. But does it really mean good for the child? Does it really mean participation? So what do we need to do beyond that to bring it to, we are only talking about RPWD from that angle where, எப்படியாவது கொண்டு போய் அந்த கிளாஸில் உட்காரணும் அப்படிங்கிறது. ஸோ அதை தாண்டி இந்த 3 ஸ்டெப் இருக்குது அப்படிங்கிறது is something that we need to also think about as practitioners, so that we actually make meaning out of what the act is trying to bring to the schools and to the child actually. So reasonable accommodation is the next best thing that I feel it is guaranteeing, but it's still a lot of work that has to be done in order to even get that now. But beyond that, a collaborative planning is required, and meaningful participation is also required for the child to completely benefit out of the act is what I strongly feel. So to me, collaboration makes participation possible. So I think that is the missing link between the act itself, what it guarantees, and how it has to be actually implemented. So this is what I feel. Sorry.
Happening?
Went to the next.
No, no. I'm not doing that. Next. Okay. What is school preparedness and how to implement? It's a very important question I'm asking you, because many times parents putting in the center after 1 year, they feel that with 1 year of continuous therapy, the child is ready for the school, and many times they get bored of coming to center alone. They say, shall I put in the school? Very, very common questions. Yeah. So I'm concentrating only the early. So I don't teach adolescent children because first of all, I'm not qualified for that and experienced in it. So I concentrate more on children less than 7 years. There, every parent on the first day itself, they ask, first thing I come across, pediatrician to போயிட்டு autism suspect பண்ணும்போது, when you suspect autism என்ன வரும், ஸ்கூல்ல போட்டு பாருங்க. ஸ்பீச் டிலே இருந்தா ஸ்கூல்ல போட்டு பாருங்க. எல்லாமே school is a trial. So that is not an answer. So what is this called school preparedness and how to implement it?
So enna portha varaikum school preparedness is definitely a component. It's not a thing in itself. So to me it is a triangle. If we can go to it's too much of a trouble, then it's okay. Otherwise we can show the visual. So it's basically the child preparedness, ecosystem preparedness, and the school preparedness that will make it holistic actually. So we can't just talk about school preparedness alone actually. So because எல்லாரையும் prepare பண்ணறது தான் வந்து it will lead to participation like I told you earlier. So definitely school preparedness is a component, and school preparedness involves teacher readiness like I told you earlier. Some form of capacity building should be there to the teachers, and then classroom adaptation. So there should be probably a sensory corner or something where children with autism can relax when they have a sensory overwhelm or something like that, and training for that has to be given as well. Peer sensitization is a very, very important part where all peers should be aware that this is an inclusive space and you can get children from different abilities and disabilities. And what I have seen in my experience is also that at least until the primary grades, children are naturally inclusive. Like, yaar vandala avanga vandu, they don't see, okay, this is a child with autism or ADHD or anything like that. It's in the adults. So how you as an adult, as a teacher, behave with the child is what tells another child. Especially, I'm sorry if I'm being controversial here, when you bring in a shadow teacher. The shadow teacher vandachinale, the peers will relate to the adult, not to the child anymore actually. So you have to be very careful about what you as an adult portray especially in a primary and a pre-primary setting. When they go to secondary school, they are mature enough and old enough to understand differences among themselves also. So we have to sensitize them in that way. And environmental supports, if any, like in terms of let it be therapy, or maybe some schools la pathina in the madri light kannila adikum, from a window, so it will be very, very difficult for the child. So and edathila endu konjam maati vekkradho illa visual nariya posters irukku classroom la appadina adve distracting ah irukum and kulandhikku. So we can probably seat him in a different way or her in a different place. So that is something that we can look at as environmental support and flexible teaching practices. The child, இப்போ one-on-one pull-out plan பண்ணா lifelong அந்த குழந்தைக்கு pull-outங்கிறது கிடையாது. So sometimes we have to say, okay, mathக்கு pull-out. English can be with the classroom. Science, it can be a small group. So that kind of dynamic and flexible planning is also very, very important when it comes to school preparedness. So these are some of the components. Similarly, there are other things like, இப்போ என்ன problemனா, we are basically giving everything. இப்போ child preparednessல இருக்கிற emotional regulation, ecosystem preparednessல இருக்கிற ஒரு shared goal, shared expectation எல்லாத்துலேயும் ஸ்கூல்ல திணிக்கும் போது தான் schools also get overwhelmed. So we have to be clear about certain things that child should be prepared for, that ecosystem should be prepared for and what the school has to be prepared for. இதெல்லாம் non-negotiables for the schools. அப்படிங்கிற அந்த ஒரு distinction இருக்கும்பொழுது we can probably facilitate a little bit more of participation.
So now I have a question from the perspective of a school. I have a school, running a school. I have a good name. My parents are a little bit anxious if I put a child with autism with a behavior in a classroom. I am answerable to that also. I don't have my staffs trained in that because I don't have any thing. I don't have any shadow teaching support or anything because there is no proper course or something. You are having that different. Okay, a proper. So, as a school administration, do I have a right to refuse admission solely because I lack in the resources?
No, actually,
I'm the
right,
principal,
sir,
I
if
don't
you
have
say right,
resources.
it is not right because we all know that no school can reject a child.
No,
that we have to educate the parents. See, it's a very emotional situation when a school rejects the child. So for the mother and the parents, of course, I'm a mother, so I'm telling parents is a very emotional thing. But two things, as I told you, that time, I think the mothers or the parents should be ready to talk to the school when they are thinking about putting the child in that school. They must first get a professional to talk for them. As she rightly mentioned, they must see all this readiness and everything in the school is there. Some professional should go with the parent. Then they must explain what the child is able to do and they can tell all that and then they can seek for the. See, many a times the school also doesn't know what the child will come and do here. Suddenly, if they scream, what will I do? Suddenly, if he hurting the other child, what will I? See, all this, keeping all this in mind, they say no admission. So it is not that easy. So I think, as a mother, I think you must go to first, plan this properly. Get the child as school readiness for the child. Also, make, as I told you, that I listed out certain things. If the child is ready, then they can take a professional and approach the school and see whether they can understand and give the school. And we must educate the parent. There is a right for the child to give the school must give the admission to the child.
No,
so
I understand.
Legally, it is that, no, we must educate many parents. They don't even know. Some school will just say like that and they will come and,
so madam, I'm a teacher now. I have 40 children. I have a child with autism behavior. Do not deny the rights of 39 children learning in the right time.
Yeah, they also have, but
so the 39 children also have the right to learn the right way.
But this child but I agree with you with having a shadow teacher, or even many mothers I know, they were sitting in the school, in children garden school, I can even mention the school, the mother was with the child for some classes and then later she started working in the school. Now the child would have finished a PG course. So it was very easy for the child for the transition.
For every mother cannot do that.
No, every mother, they can have a shadow teacher.
So I'm purposefully raising the question. I'm purposefully raising the question.
If I can add one point, like this also points back to like when you ask the question about IEP, you are asking like who is accountable. So every time the child is taken into a school or admitted into a school, this is the question that the management, who is accountable for this child?
Yes.
So when you attach that accountability to one single special educator or that resource teacher, then obviously not having that resource teacher is the criteria. So you may have to deny because that person is not there. But we need to change that narrative. So the accountability is shared. So there are these 5-6 people who are accountable for this child.
Yes.
Like she said in that example, the mother was also accountable in that journey.
So the message actually I want to give is, we cannot put a school in the fit that it's right as per the RPUD or the RT, you have to take my side. It is not going to happen. Sometimes if you force, nothing is going to happen. Many, is it right or no, I don't know. If you put in a government school, they cannot die, they add the child in the classroom. Is it beneficial for the child? First question. So anything has to be beneficial for the child. It is not about claiming my right. It is not for the school because I have put in inclusive everything in the rule, I have to put it. Fundamentally, is it beneficial for the child? That is the first question. So, the responsibility not with the parents or the schools, I would say here many therapists are, ideally the responsibility should come to us first. We should be very clear what is school preparedness, how to include the parents in the therapy. From the day one, Make them as a co-partner in that actually. So prepare the child, really prepare child with a, you see the problem here is behavior is a communication. That's your repeated say B is equal to C. If the child shows behavior, it is not able to communicate. So teach the communication. Rightly she said a specs method or some method. Many times they say speech therapy, speech vendam. I said let them communicate first.
Communicate, yes.
Let them communicate first. Then with word or something. Don't bother about it. Ava, speak something. Let the child communicate. Once the child started communicating, behavior automatically comes down. The repetitive behavior, don't bother about it. Again and again, concentrate in the communication. We need to make the parents to understand that it is only the deficit in the social communication interaction. Teach them properly. It is not like that teaching that personal needs and requests. Many times as a therapist, we train the children. I used to say it is not teaching, it's a train. You teach the child, train the child for personal needs and requests, which is already good. It's good enough. The deficit is only in the social communication interaction. We don't address it properly. We don't give a social skill training. We don't give behavioral skill training. Unless we do that, we cannot put the responsibility whole on the school actually. If I'm right, you agree with that? I hope my panelists are there. So the responsibility more with us than the schools and parents. Now it is our responsibility to take the parents together. Then it is a responsibility, rightly mentioned, before going into school, we need to talk to the schools. Of course, I tried many times to contact the schools. They are still in the early stage. They are not taking our calls. I have already give a letter, anytime ready to talk to the teachers. Many times, only few times they are accepting. Very few schools actually. So for want of time, last thing is, what are the responsibilities of parents, pediatrician, therapists and schools? One. Sir, pediatrician, Dr. Vijayalakshmi, what are the responsibilities? We have only 1.5 minutes.
Responsibility of a pediatrician.
Pediatrician. You are a pediatrician, sir.
So like to identify the red flag signs early so that the intervention can be started early and a multidisciplinary therapy can be started early.
So proper screening, no ambiguity in that answers, no false hope. It is there means it is naive. We are not here to console the parents. We say it is about the child's future. Anga பாரபட்சமே இருக்கக்கூடாது. இருக்குன்னா இருக்குதான். He may get anger, but that is not my problem. At one point of time, they may go out. They may not come to me at all for another 1 year. But after 2 years, when they diagnosis, they accept the diagnosis. They will always worship you because you are the first person told about it. So our pediatrician responsibility is identify it as early as possible, declare it as early as possible.
And one more thing I wanted to add is referral.
From the parents' perspective?
No, sir. For pediatrician, I'm requesting.
Yeah.
As properly referred to the place where they have to go.
So again, I want to, because you are making me tense. It's like a prescription. 3 OT, 3 therapy, speech therapy, go to whenever you make a diagnosis, many times I come across, start speech therapy. There are how many speech therapy? 3 speech therapy, 3 OT. It's like 3 paracetamol 3 times same or something like that.
I'm saying
Pharmacy la poitu if they ask, no, pharmacy la poitu, anna thala valikina, kaalla valikiduna, udanna he will take 1 tablet, this for morning, afternoon, night, and this for that. But without a proper diagnosis, always end up in problem. Without a psychometric analysis, without a psychiatrist, warning is coming, I think. Psychiatrist assessment and proper therapeutic assessment, you will end up in problem. Let us do in a proper way. And from the school's perspective?
I think from the school's perspective, it's about, like I told earlier, we have to move from access to participation. So whatever it takes, like be it capacity building or collaboration, like, I think from a teacher also, like sometimes when a child is in my classroom, I feel solely responsible for the child. I don't sometimes I'm not allowed to, sometimes I don't know how to ask for help. So when it is a child with autism, it is a non-negotiable that we need to ask for help. So collaboration is something that I would probably look for.
So with the want of time, I thank all my panelists for their excellent answer. Now I put the responsibility to Center of Excellence for sensitizing the schools and parents about school preparedness before putting the child in the school. Thank you for the golden opportunity. Yes, madam. It's from the, One question, 1 minute. VXL director, please, madam. Yes. Yeah, I know. Yeah, that's why I'm putting the responsibility to CoE. Yeah, that's why I started with government is an elephant. When it moves, you cannot stop it. This is a fast-moving elephant. I hope with the best thing from us. Thank you very much.
Thank you so much for the panelists. A wonderful discussion on this inclusive schooling. Let's now facilitate our moderator and panelists. I invite Dr. Rema Chandramohan to felicitate Dr. Sudhakar. And I request Dr. Sudhakar to felicitate our panelists. Check. We'll take one final short tea break, 10 minutes. Please be back in your seats by 4:30. Please be back in seats in 10 minutes, please.
திரும்பி வேற பக்கம் பார்த்துட்டு இருக்காங்க. நீங்க செஞ்சு
Kindly, please be seated. We can start the session. Speech therapist, Ms. M.K. Sheba, will not be joining the session. Kindly be seated.
Good evening, all. Thank you for the opportunity to moderate this last session. After having an exhaustive session on autism since morning, the session is on disability rights and legal issues. Maybe a dry area, or it's covering all types of disabilities. In 1995, you all know that the Person with Disabilities Act came. That focused on the equal opportunity, full participation, and protection of the rights of the persons with disabilities. But as years goes by, in 2016, the word rights was included in the Rights of Person with Disabilities Act in 2016. So that plays the Urimaigal, the Rights of the Person with Disabilities Act 2016. Yes, where 21 types of disabilities were included, and the cognitive disability and the other physical disabilities were enlightened. Cognitive disabilities, which include the intellectual disability, autism, and the specific learning disabilities, were all enlisted, and there come the light on each disability and importance to all these types of disabilities. The recognition, the identification, the screening, everything plays a major role there. Again, since we have talked about autism from the morning, and I wanted to stress that it is an invisible disability. Do you agree? Yes. So many people are not aware of such autism is there, or some invisible disabilities are being built up in his or her own child. So there comes the importance of this autism and this convention. See, as many people know that Government of India has laid down the guidelines for assessment of each 21 types of disabilities in 2018. And then 2024 it has been modified. How many know how to assess a child, how to assess a child with autism, who can certify? Everything plays a major role. Why I am insisting on this is because having an ID card is also a right to a child. Do you agree? Yes. So, as per Government of India, now the unique ID card, unique disability ID card, UDID card is mandatory for each and every child. Being from the commissariat, I just wanted to say the fact that in UDID portal, only 10,40,712 people are having an UDID card in Tamil Nadu, out of which 2,14,400 people are being certified as intellectual disability, whereas autism it is only 5,800. Do you agree that number? No, but that is only available in the portal. It is because of the fact, what I think is, the intellectual disability and the autism, they concurrently exist. And people with ID people are given 2,000 rupees as maintenance allowance from our department. And so many people prefer to have an ID card with intellectual disability rather than autism. I just wanted to insist that from last financial year, we are giving 2,000 per month as maintenance allowance for autism people also. So it is our duty to identify the pure autism people now, right? Am I right? And coming to specific learning disability, it is only 3,140 people who have been identified as SLD, specific learning disability in Tamil Nadu. This is also a very alarming signal at the same time, which needs to be identified in school education department. So it's a right to, why I insist on this ID card is, we need to be aware of this and make people, others aware that UDID card is a must for each and every disabled child. Coming to the main topic panel discussion, I'm sorry for boring you. Is it a stigma whether this, quite a few people are being identified with the UDID card and few people are without ID card? that need to be also addressed to. To ensure the integrated rights and the service to the differently able person, the Tamil Nadu government has come out with the TN Rights project with financial assistance from the World Bank. I just wanted to insist on that. Apart from the early intervention centers from our own department, from the Health and Family Welfare Department and the Education Department, we have 43 subdivisional one-stop centers and more than 261 block one-stop social care service centers in Tamil Nadu, where rehabilitation services are given, where all the therapists, psychotherapy, speech therapy, physiotherapy, parental counseling, student counseling, everything is being addressed to. I just wanted to insist because in the last panel discussion, it was said that the reasonable accommodation is not being given and an inclusive education is not being given, and there is lagging in the RPWD Act. We cannot guarantee. So I just want to insist that the government is making all its efforts to make the RPWD Act implementable. Coming to the panel discussion, I welcome all the panelists. Dr. Satyaprabha from CoE. She's a consultant in Center of Excellence for Autism, and she's being graduated in Madras Medical College, a premier institute in Tamil Nadu. And then Vijay Lakshmi ma'am is a senior pediatric consultant who has turned into a rehab professional now. And welcome you, ma'am. And now I know that you are being trained in hearing impairment, dealing with multiple disability, did a lot of training in Netherlands and other areas, countries, and contributing to the government also in training all the educators, parental counseling, translating the RCI into Tamil for people living in Tamil Nadu. You did a wonderful job, ma'am. Thank you. And she has received the Best Doctor Award in 2024 for doing rehabilitation in person with disabilities, and also in International Women's Day from Tamil Nadu Governor. Thank you, ma'am, for this participation and your contribution towards the society. And I welcome Dr. Vasudha, ma'am. She's basically did her BCom, but she has turned herself into a psychotherapist, social entrepreneur, or a visionary leader in over the 22 decades, 20 years of experience in inclusive education, founder of VXL Educational Trust and Incl Training Solutions, both based in Chennai. She's a member of our Committee for Research on Disability and a member of RCI, a dynamic public speaker and a trained classical musician. Is that enough for her? Yeah. And she excels in VXL, she's promoting inclusive education and social inclusion and contributed more towards it. And trained, as she said in the last discussion at the end of the last session, she has trained more and more of more than 18,000 teachers, mainstream teachers, to recognize the different developmental delay in children in classroom, in regular schools that too. She has many counseling experience and education experience, and she has done many workshop and training programs and sensitization to all the people who are the needy. Then our Tanvi ma'am. Welcome, ma'am. She's our advocate and with 10 years of experience, graduated from the National Law University, Jodhpur. She is a partner of Tanvi and Balaji Associates and appearing before the Madras High Court, Labour Court, Central Administrative Tribunal, National Green Tribunal, Consumer Court, Family Court, and since 2021 from our department, she is a legal consultant and has been trained, giving specialized training to the legal team that assists the State Commissioner for Persons with Disabilities. She has conducted multi-state research to draft the state's comprehensive reservation and promotion policy and to draft the ad hoc rules. Multi-state research is not a single thing, it's a very difficult task. She also heads the legal team, and she is appointed as the amicus curiae, that is, a friend of a court, by Honorable the Madras High Court in sensitive legal matters concerning the guardianship of persons with disabilities. Does specialized legal training and capacity building workshop on disability rights and registration for the department officials, government officials, and civil service trainees. Welcome you all, ma'am. And I just start with Satyaprabha ma'am on mental health issues, mental health related to this disability rights and legal issues.
Very good evening to one and all present here. And I would like to thank Rama ma'am for giving this opportunity. and I will go directly into the topic. What do you mean by mental health is that it is the state of well-being. It has to be in 3 dimensions: emotional, psychological, and the social well-being. The problem with the disability, what we label as disability, is the social model. Here, there is an impairment from the side of the person, along with the barriers. When there is an interaction between the person and the barrier, it results in the hindrance for full, effective, and equal participation in the society. So it is the part from both the person as well as the society is the barriers. So here, the mental health is mainly affected by the stigma existing against the disabilities, what we label them as disabilities. The problem here is that we label certain conditions like autism spectrum, or whether any mental illnesses or any other intellectual disability, any condition as such, we label the condition. And then because of the label, there are certain characteristic behaviors, we give them a negative connotation. We see it negatively. We see them in a negative perspective. So because of that negative perspective, we dichotomize. We separate the typical or normal people from the divergent or the different people. Because of the segregation, so there comes the discrimination. This discrimination results in the reduction of the social status of the person, which interferes in the experience. We are reducing the opportunities for that person to interact with the society in an equal manner and to exhibit them to the fullest. So this is a model, both the person is at fault as well as the society is at the fault. So as a clinician side, we can focus on the person as such. As ma'am pointed out, here, based upon the Rights of Persons with Disability Act, there are 21 scheduled disabilities. In that, autism spectrum disorder, intellectual disability, and specific learning disorder has been considered as one of the disabilities. So here, in autism spectrum disorder, first and foremost is that we assess the individual who comes to us. So pediatricians or any other person who the parents reach out first with the concerns, or any teachers who find out that the child is not communicating in a proper manner, the initial screening is done there. The concern is raised there, and based on the concern, parents take the children to the pediatrician or any other health consultant. It does not stop there. The proper ways of assessment has to start from the first point of contact. So it can be either the pediatrician or any other general physician. From the screening, it's not like that. பேச்சு வரலையா, நீங்கள் வந்து தெரப்பீஸ் போக ஆரம்பிச்சிடுங்க, தெரப்பீஸை ஃபஸ்ட்டு ஸ்டார்ட் பண்ணுங்க. It does not, it should not be like that. First concern itself, we have to screen and diagnose the individual based on the multidisciplinary approach. So it is important because early identification of the condition is to find out the deficits or what other milestones which is lagging, which will be important. Unless otherwise that milestones are not at time, the children will not be able to develop in a proper manner to the next step. So it will be affecting their social interaction and communication in the later point of view. What I mean to tell is that at the point of screening, we have to do a proper assessment. We have to come to the conclusion based upon the assessment, and then we have to explain to the parent in the manner that they can understand what their child is going through. So first and foremost, for the children, it is their parent who is going to be the advocates or the voices for their rights. So we are talking about the rights. Every human being has a basic fundamental right of life with dignity. So dignity comes from the point that every human being, just because he is a human, he is born as human, he has an inherent value and worth. It should not be decided based upon the social, economic, or any other status which the child is there, which the human being currently is there. Every human being has to be treated with respect, treated with worth and dignity, and he have to give reasonable autonomy and decision-making authority to the individual as such. In previous discussions and panel discussions as such, what we listened is that parents are not ready to let go their children to take decisions on their own. So it has to start from the earlier stage itself. Decision making has to start even from the children. Can give them choices to choose இந்த டிஷர்ட் வேணுமா, இந்த டிஷர்ட் வேணுமா, இல்லை இந்த கலர் டிஷர்ட் இந்த சாப்பாடு சாப்பிட்றியா, இந்த சாப்பாடு சாப்பிட்றியா, these all comes with the decision making. Even at the earlier stage, if you are giving the power of decision making to the child, he will develop his own self-esteem, and this will help in becoming a self-autonomous person. So here first we have to assess the child. You have to understand the child first. As a multidisciplinary team, you have to understand the child. We have to communicate in an empathetic manner. Just like that, we can't disclose a thing which is stigmatized, which is not easily acceptable by the parents. குழந்தைக்கு ஆட்டிசம் இருக்குது, அவ்வளோதான், இது லைஃப் லாங் கண்டிஷன், இதுக்கு மேலே நீ எதுவும் பண்ண முடியாது, இதுதான் கடைசி வரைக்கும் இதோட வாழணும் அப்படின்னு வந்து மூஞ்சில் அடித்த மாதிரி we can't tell at that time. You have to more empathetic. We have to understand that as a parent, when we are telling a lifelong, this is a lifelong condition, what are the emotions the parent may undergo at the time. You have to understand that. You have to communicate clear and crisp manner in an empathetic manner to the parent. This is very important. Only when the parent accept, they will be willing to take the child for the intervention. Based on early intervention only, we can reduce the level of impairments and the disability which the child may have at the later stage. So this has to be a step-wise process. So as I said before, the parent is the major advocate and the voice for the child. So they have to spend more time with the children. They have to understand what the skills of the child, what are the strengths, what are the difficulties and challenges they face while interacting with the society. It can be either a play area, or it can be the school, or it can be any other social gatherings and family gatherings. Only when the parent understand what the child is undergoing, they can be the advocates. They can tell to the other members of the society that my child is experiencing this. You have to accept the child. First, the parent has to accept and embrace the child, and then they have to make others in the society to accept. Even within the family itself, mother will be supporting more. Mother will be spending more time with the child, and father may not accept or may not be able to spend more time with the child, and this also gives rise to family discord in the families, and support systems may collapse at the time. As a clinician, we also assess or find out the family dynamics which they undergo, and then we try to support them in what all means we can. So next comes the assessment. As I mentioned, less than 6 years, it will be assessed based on the Incline Ames modified tool, and after 6 years, the disability calculation will be based on ISA, that is Indian Scale for Assessment of Autism. This also the assessment of intellectual impairment, intellectual ability and socio-adaptive skills also will be assessed. Based on this, the level of disability will be calculated, and disability certification will be done according to the government guidelines. Here, what the challenge we face is that in prescribing or in assessing the disability certification, there will be a difficulty for assessing intellectual impairment in the non-verbal kit. The tools may not be sufficiently used, or the appropriate tool may not be available throughout. I can't just generalize that, since CoE has various tools. Even the DEICs or any other psychologists who are certified to give the disability certification throughout Tamil Nadu or any other in rural areas, the scales will be available. So the time may not be available. So as ma'am said, ID children are diagnosed or assessed more, and autism is assessed less. One of the reason is that in most of the time, the disability will be disability certification will be done as a whole. Almost over 50 children will be attending the disability camp, and the persons who are available there will not be able to do all these assessments like ISA, take the full detailed history and what the child is undergoing. Just like that, they will see, and they may be in a position to give just an ID for that child instead of giving an ASD. We almost see few cases like that as well. So next comes the mental health of the family is affected by the stigma as well as by the exhaustion which they because of the responsibilities they take more. We are not sharing the responsibilities with the society. This is because we tend to think that we are finding a person to blame. Either it is a mother or a family. The society is not still more inclusive. We are trying to drive our society to be more inclusive. Here we have to understand the concept of double empathy. We just think it is easy for us to think that person with autism has a difficulty in understanding social cues and surroundings. But we fail to understand that we who think we are neurotypical are also at the same position that we are not understanding them. It is not that the person with autism is not understanding us. It is also that we who are not understanding the other people. So in order to bring out the inclusive spaces where they can communicate and participate equally, which is very important for their general developmental growth, has to come from the inclusive spaces, and this has to come from the basic understanding. First, the clinician who sees has to understand the child. Next, the parent has to understand, and they have to be the advocates on voices of their child. They have to communicate it to the family members and other society so that we can drive towards the inclusive society. Thank you.
Thank you for your valuable inputs, ma'am, and insisting on the responsibility of the father, mother, family, and the society, and how can we offer a dignified life to a child. Thank you, child with disability. Ma'am, this is for Vijay Lakshmi, ma'am. What are the legal rights and implementation challenges that you have for inclusive education?
Yeah, actually, the previous batch has really done well in that. And as Sumitra madam said, you cannot deny admission to any child, with a disability. But what happens is, with the mild and moderate cases are being admitted, but what will happen to the severe and profound ones? They are still depending on the special education only, special schools only. The government has started, actually Tamil Nadu government has done extremely well because they have their early intervention centers, they have the block level centers, school readiness program, and also it is also called as daycare centers. And they are really doing wonderfully well because when we refer children to them, even below 3 years or 2 years, in the school, the daycare centers, in the block level, there is a special educator every day, physiotherapist is coming every day, and also the occupational therapist is visiting 4 times. And, the special educator has a very major role there. And she acts as a speech therapist, and also she acts as a counselor, both counseling the parents, the peer group, and also the siblings, they have to be taken care of. And in the DEICs, also they have all these, all the therapies are being given. Suppose a child is denied an admission into the school, they can have a therapy for 3 days, and they can register their names in the inclusive school and attend the therapies. But some inclusive schools have very good resource rooms. But in the private sector, they may not be affordable. But as far as Tamil Nadu is concerned, it is affordable because the centers are all over, spread all over. And I always tell that you don't have to worry about. If they can pay, also we have very good NGOs. So madam, actually Vasudha madam, sometimes when we send very poor children, she never collects the fees. Or if it is passed in madam, they don't do it, If they are really rich and affordable only, they are collecting. So the NGOs have got very rich knowledge in the rehabilitation of persons with disabilities. They run as a special school and they include them into the regular schools. And in the Madam School and Sankalp, they are all done very good work up here. But the severe and profound people are at home, and luckily Tamil Nadu government has started the TN Rights program. You have the mobility clinics, mobility van, they go there and they will phone up. And the route, I have the route map, So I can tell the mother that this is the route map, this van will come to you on this day. So that route map has been given by the government, So TN Rights is now getting well established. The Virudugal, it is in Kannagi Nagar where, I am from Muttukad region, So we have very good collaboration with the Virudugal TN Rights project and also all the other, CDIC, DEICs and your early intervention centers all over Tamil Nadu. And because we are in the National Institute, we have connections with all over the state and even abroad, our students are there, those who have done PGDI. So we have a WHO consultant who is participating here, She's in Pondicherry. And so Dr. Minita is here now. Actually, we have made up a very good networking. So inclusion is not a problem, actually nowadays. We can include people with autism. Mild and moderate are doing very well. But when they come to the class levels, the 10th standard and 12th standard writing, if you are admitting into the NAOS, they need a certification from the government institute. So the medical board, they are finding it very difficult because they have to visit at least 3 times. And the parents doesn't know that they have to take a certificate. So, see, it should be taken very well ahead of the exams. So that is one problem the parents are facing. So that should be made aware, And if they go there, after 3 visits, they give the scribe certificate, provided the child is able to communicate. So any form of communication should be there. They are telling only speech, the child should speak or point out. But in NAOS, that is, if the child is intelligent, and the 4 answers are there, the child is pointing out. Even if the child is not able to, suppose, make a very quick movements, he is getting delayed. They are given 1 hour extra time, and parents are allowed to write in NAOS. Whereas when they appear from the government schools, it is 1 class below the 10th standard, and those really are finding it difficult, ma'am. So at the
government orders are like it.
Yeah.
Who can be a scribe?
I'm not blaming, ma'am. Actually, I'm only suggesting, because how can you ease the parent? At least whenever a parent visits you, at least tell 2 or 3 activities to improve their communication skill and their cognitive skills. You should tell them simple things at home, what they can do. So that is how I think, and we send to this center with the SRP, School Readiness Program, from where they will get registered into the government schools. So that register is maintained. And from there, they will take you to 8th standard, 10th standard, and if possible to 12th standard. If it is not possible at the level of the 8th standard, they go into the NAOS registration. So I think it's a very good system we have in Tamil Nadu. I want the other systems other states also to follow.
Thank you very much, ma'am. Thank you very much. As a psychotherapist, Dr. Vasudha ma'am can add on it. The vocational programs and the ma'am inclusive education, as you are doing already.
Just to take one sentence of what you have said. Like you said, the moderately functioning and high functioning children can be included, but there is a term called LRE, least restrictive environment. Whatever is least restrictive for the child to be in an educational setting is what parents should choose, eventually, because sometimes the reverse also happens. Children who've been in regular schools find it sensorily very uncomfortable to be there. And also they don't engage well with that kind of environment. Maybe then for them a special school is all right. Everybody has to find their destiny. The path of a child with special needs, that road may be a little different, but they may run parallelly. So I also tell the parents that, you're all going to the same destination. Ultimately, you want your child also to work somewhere, to meet their potential. So if they don't do it through the regular schooling, and regular schooling is also not simple. It's also very complicated for neurotypical children. And children are always inconvenient. Whether they are regular children or children with special needs, they don't come to us to make our lives easy, whatever it is. So children with special needs have a different kind of a challenge. But for parents to accept that if the disability is not suitable for a regular setup, it's all right to put them on another path. I just wanted to add that LRE, least restrictive environment.
Actually, that's a question for all the special educators when they do the course. What is LRE? Isn't it? You have done diploma, yes.
But that's actually useful.
That word is very important. Thank you, ma'am, for reminding me.
Thank you, ma'am. Thank you.
Yeah, and the question to me was about equal rights for employment. Actually, special schools address children up to a certain age. Like many schools stop their programs at 18. After that, after so many years of training, the child or the young adult goes back home. And often parents don't know what to do. And there is a dead end because parents also age,
And they're also tired. What do I do next? Society is not very open and schools are not. So one of our policies is we don't discontinue any adult till they find their next step. We keep, and then we find the next step for them. So our oldest adult may be 50, 53, till we find a way forward. It could be a residential program, or it could be a job, it could be a sheltered employability, whatever it is. Because you can't send them back home, then TV is the only option. And then that is disintegrating, whether it is for us or for people with special needs. So we try to not go that way. We have two options. We divide students into 2-3 groups. So the group which is readiest for employment outside in society, we have a very strong training program for them, which includes every aspect of communication. And then we specialize in 1 or 2 fields so that they can be placed. And then we engage with employers and we tell them these are 2 profiles we have, 2 resumes we have, exactly what do you need from them. And then we work backward according to their needs. So this has worked, and I think we have placed about 35 students with autism before COVID. And when COVID hit, they were the first to leave. They were first to ask to leave. But then the process continues now. We are still continuing that group to be trained, to be placed outside. The second group, we are creating something called sheltered employability, meaning that they will be under the care of special educators or professionals in this field, and they will do what their aptitude is strongest in. So some people are good with craft, some people are good with data, computer related, some people are good with cooking. So we try to create 3, it's very resource intensive, so 3 or 4 streams of work. And then they come and they work on that, and after a probationary period, we try and pay them. So that is the sheltered employability. The third group, which is so none of them is etched in stone. It's all flexible. One group can go into the other group can get trained into the other. The group which is affected the most, then we try and keep them and try to do a lot of vocational, pre-vocational programs within the institution. We also empower the parents to start their own small-scale industry. Or a group of parents, they can start something, a cloud kitchen or some art and craft or something, and then the child is involved in that. And many business families say, train our student in this. So we are able to do that. But yes, everybody has a right to meet their potential. And just because people with autism are not articulate or their expression is not like ours, we cannot doubt their competence. They are extremely competent, and their competence may be very spiked or tilted in one direction or the other. It may not be general, but we have used, like, what is that tire company? MRF. In another country, not in ours, they employed a lot of Asperger's syndrome students, people, and autism for very minute detailing of their tires. So because they have laser beam attention, and as students you will know that people with autism, they have, like our attention, our foreground and background is balanced. Like we are your foreground and you're aware of your background, but you learn from your foreground. People with attention deficit disorder, everything becomes your foreground. So that attention deficit disorder is a misnomer. Actually, it should be attention excessive disorder, because people with attention deficit, ADD, are attending, everything becomes your foreground. But with autism, they have laser beam attention. Like my hair will seem like spaghetti to them. Or in my face, they may be only focusing on my nose. It might seem very bulbous to them. So that they have put to good use by doing minute work, examining tires, anything that's requires so much focus. So I am sure God has not put anyone in this world without having a purpose or a destiny for them. The trick for us as professionals is to build that bridge between them and society, and to see which way the destiny takes them. And that is true for neurotypical people also. All of us struggle to find our destinies. So that's...
Thank you very much, ma'am. From education to employment, you have covered. Thank you, thank you. This is for Tanvi, ma'am. what is the role of judiciary and legal aid in protecting disability rights?
Thanks, ma'am. So I think can we include the next question as well in
Yeah,
this?
no issues. What is the India's progress and future in implementing the UN Convention on Rights of Persons with Disabilities?
Unfortunately, my discussion is going to be slightly more boring because it's going to be about legal
It's a new
structures.
topic for every one of us, ma'am.
So, because at the end of the day, I think one of the biggest differences that has come for us is from the 95 Act to the 2016 Act, is that the nature of understanding of disabilities has changed, which the previous panel had also discussed. Right? We are moving from looking at it as a medical issue, looking at it as a social barriers and how to address the social barriers. Now, I think we have now finished 20 years of the International Convention on Rights of Persons with Disabilities, and we have now finished 10 years of our 2016 Act. So I think in the last 10 years, what we have effectively seen is that the fundamentals of disability law, right, where we are moving from a welfare-based understanding of disability, right, of disability, to a rights-based understanding of disability. It is no longer that பாவமா நாங்க அவங்க கொடுக்குறோம், இது அவங்களோட உரிமை. அந்த உரிமையை காக்கிறதுக்கு நம்ம என்னெல்லாம் முயற்சி செய்யணுமோ அதுதான் நம்ம செய்யணும்னு அந்த மாற்றம். Now that change and that difference in articulation obviously means that now entire government structures now have to be reframed. Because till now we always looked at it as schemes of benefits which had to be given, right? It would just be that we will give them some, they can't take care of themselves, okay, you'll get pension. Or, they would be very easily defined schemes. Whereas now when we are moving into a rights-based administrative model, and which is what the law provides. Ultimately, the law provides for the structure by which government will function. It will say that in this situation, you are required to do X, you should prevent Y. If something happens, this is what you should do, this is what you should not do, and who should do it, most importantly. Right? So now these structures are still in the process of being created. In some places, at least, we have recognized that it needs to be, it first has to exist. We have created those structures. By and large, now in the last 10 years, we are moving into a rights-based model of disability jurisprudence and disability administration. Right? We are no longer saying we need to be heard. We are being heard. Now it is a question about the nitty-gritties of the implementation, I think. So, for example, now we have the Disabilities Commission. Most of our schemes are also changing. Now our identification, our guidelines are also changing. We are being more progressive or more nuanced in our identification processes, in bringing in these concepts of reasonable accommodation. Right? Reasonable accommodation 10 years back is an unheard of concept. But now it has come into the mainstream. All of us will talk about reasonable accommodation whenever we discuss any disability rights or whenever in any specific issue, whether it is joining a school, whether it is in higher education, or whether it is in employment or general society. So we are now moving to say it is a right of reasonable accommodation. So I think in the next 10 years, what I would foresee is now figuring out what does this very nuanced idea of reasonable accommodation, what does it actually mean? Because it, like the previous panels had discussed, it varies from individual to individual. It varies from disability to disability. And now how do we come up with rules, regulations and systems wherein it is no longer left to the individuals who are in those posts doing the best that they can. Because in administration and in law, we seek to establish the minimum standards and the minimum requirements so that it's easy for the general public and for the individuals to demand accountability and transparency in whatever is actually done by the government or by the hospitals or by the, your teachers or by the schools or by the colleges. So right now, I think from moving from just saying, I have a right of reasonable accommodation, I think the next step in the next 10 years would be, what would this idea of reasonable accommodation be in a school for, say, a person with autism? How would it vary for a person with SLD? How would it vary for a person with locomotor disability? How would it vary for a person with any other disabilities, multiple disabilities? And how at every stage of their life, this concept of reasonable accommodation will change. And when we talk about accessibility, the law provides for physical accessibility, informational accessibility, and transport, and accessibility in transport. Now, most of our guidelines are in place. We have our harmonized guidelines, which say, or a ramp pota, in the angle, how high it should be, how it, and things like that. That itself has now taken us, I think, close to 10 years to get those standards standardized, right? Now, the next 10 years would be ensuring implementation of these standards in a more nuanced manner. For example, our harmonized guidelines will talk about ramps. But ramps for children cannot be the same length or the same angle as what has been prescribed in the harmonized guidelines, because that visualizes an adult. So which means in schools, it cannot be the same kind of ramps that we have to use. So right now, for the first 10 years, we've actually been fighting just to say, I need a right to a ramp, which has now come. The next step will be the nuances now. Yes, I have a right to a ramp. But now, and okay, you've also said that the ramp should be at a certain angle with a certain length and that you should have railings and stuff like that. But now there is more nuance to it. So now I think it is the time for us as professionals in this field to help develop and standardize these nuances in our fields, because once you standardize in whether it is in education or medicine or any of the other fields, right? Once you as professionals standardize it, that is where we as lawyers or legal professionals step in that we will then make them rules. So, and once it becomes rules, it becomes standard. It's an easily enforceable right. Those ideas of reasonable accommodation, those ideas of accessibility, how do you implement it? Now if I have a problem, who do I go to? The Disabilities Act is a little bit silent on those things. So in the first 10, if you look at the Disabilities Act, it has given us very important rights, right? It is a recognition of several rights, which is what we had fought for easily more than 20 years. That is going from the convention. The convention itself is predated by about 30 years of activism worldwide. So now that nuance, right? Now we have fought, we have gotten certain rights which are now in our law. The next 10 years is going to be, I think, about ensuring that these rights become as nuanced as our needs are. And I think it is there that we will all have to function. I think in that context, the idea of legal aid, the idea of how the judicial systems can also help in this process is something we can, I can give some input on. If we look at, for example, the judiciary has been quite, it's been a very important tool in the disability field, because it has been judges and it has been a lot of litigation which has forced, it has not forced, it has acted as a force to push all persons, both the individuals and the governments, to start taking action on these issues. So some of the most important interpretations of what is reasonable accommodation, and that disability, even if you have 5% disability, you still are entitled to your rights to be reasonably accommodated for that 5%. That you don't need to have 40% disability for you to get reasonable accommodation. Even if you have 5%, so long as you have some form of disability, you are entitled to accommodation as you are required to. Now these interpretations, if you now have to practically implement from government side, what will it mean? Right now the law has said we recognize it, but its implementation now will come back to the professionals in the field and to the government as to how you're going to actually implement this idea. If a person with 5% or 10% disability should now be protected, what does it mean? Because we are now only looking, in most of our schemes, we are looking at only if you have a disability ID card which is more than 40%. So what happens when it's lesser? By law, you are recognized as a person with disability who is entitled to rights. because we are not looking at only benchmark disability. So practically, how are you going to implement it? So in that way, I think courts, whether it's the High Court or the Supreme Court, have been quite instrumental in developing these rights and developing our understanding of these rights, and now passing the baton on back to the governments and to the various pressure groups to now figure out how actually these rights can now be put into effect. I think, and in one of those ways, I think, is how legal aid has helped. So now the legal aid, which is, there is a national body and a state body. These bodies are there to help persons who may not have easy access to the judicial system. Because as all of you know, வக்கீல் பார்க்குறதே கொஞ்சம் ரொம்ப ஒரு கஷ்டம், அண்ட் நிறையா பேர் தயங்குவாங்க, ஐயோ ஒரு வக்கீலா, கோர்ட்டுக்கு போகணுமா. And so for persons who are already more marginalized, or persons who already are facing other difficulties, it is all the more difficult for you to come to court. Because it is quite a scary process to come to court. So one of the ways that the government and the judiciary has tried to ease it is to provide free legal aid. To say that all disabled persons are entitled to free legal aid, which is, we will give you a lawyer who will argue your case for you for free. Which is actually the biggest problem that all of us face. We all know, ayyo sottu poidum. That is the common joke that we all make. ஒரு கோர்ட்டுக்கு போனால் கடைசியில் லாயருக்கு மாத்திரம் தான் பெனிஃபிட் ஆவாங்க, வேறு யாருக்குமே இல்லை, நம்ம சொத்து தான் அழிச்சிடுவாங்க. ஸோ இன் தட் வே இட் இஸ் அ வெரி குட் protection that the legal aid services provide. It is there at the district level, and it is also there at the High Court level. It is provided for at the Supreme Court level as well. So adukku there is now standardized processes. Neenga application kudukalam, there will be a person who's appointed to you, stuff like that. Now that is in the context of when you are filing the case. But now again, one of the issues which are now arising for discussions in courts and among the legal professionals is, what happens when the disabled is an accused? It is not like a person with disability can never commit a crime. Okay, all disabled, I mean, just like any other able-bodied person, a disabled person can also commit a crime. Now when they do commit a crime, and now they have to go through the process of a trial, they are also entitled to certain rights which should accrue to them because of their disability. How do we protect that? That in fact is now questions which are now being raised in court, because okay, we will say that jail accessible irukano. Okay, neenga jail kulla pogura bodhu there should be a wheelchair, your the physical accessibility parts is easier to address. But the ideas of, for a person with autism or a person with intellectual disability, how do you understand what is a legal process? As you know, able-bodied itself, sometimes we don't understand what is happening. Now, our current jurisprudence is basically how you understand the law. Nama current sattathila, it is very black or white. You can number joke pandra badri, you will say that I'm incapacitated, and unfortunately in law it is still called that. You will say that lunacy is a defense, is still what continues in our law, saying that I was a mental then, that is why I should not be held liable for any action that has happened. That is the only consideration that the law still has. But as we are all looking into ideas of assisted decision making and other such concepts, the same concept should also flow into criminal law. Which means if a person with autism or a person with intellectual disability does commit a crime, it is not such a black and white issue as whether are they fit to go to jail or not. They may be fit. Or how do you understand that fitness should also now change, because part of recognizing I think the rights of the disabled is also saying that they are also persons who you can hold accountable in these issues, right? And I think another important issue, which is something which I've been looking quite deeply into, which is what also the Madras High Court was asking me to look into, is a question of guardianship. That right now our Disabilities Act is very black and white. You can have limited guardianship or no guardianship, or you go for total guardianship under national trust. So, I mean, we leave aside the fact that should a person with autism even have a guardian? That is a different question. Not all persons with autism require a guardian. but the National Trust Act provides for it. Now that is a different issue at all. But in cases where we do need assisted decision making, how are we dealing with it? Is the current problem, I think the current problem that is coming out. Because currently, there is a reason why we moved in the 2016 Act, why we moved to saying that guardianship is not the norm. Because it is the experience of the disabled community across disabilities that guardianship is the most easiest form of institutionalizing abuse of the disabled person. Whether it is mental illness, intellectual disability, or any of the other disabilities. So the highest has been with persons with mental illness and intellectual disabilities. And even maybe because earlier laws only classified like this. It's so easy to say that they are mentally unstable, therefore they should not take any decision. அவங்க சொத்தெல்லாமே என்கிட்ட கொடுத்துருங்க, நானே பார்த்துப்பேன், நான் தான் அவங்களுக்கு முடிவெடுப்பேன். கார்டியன்ஷிப்னா என்ன? அவங்க சார்பில் நான் முடிவெடுப்பேன். இப்போ எப்படி ஒரு அம்மா அப்பா குழந்தைக்கு முடிவெடுக்கிறாங்களோ, ஒரு கார்டியன் அந்த பர்சன் வித் டிசபிலிட்டிக்கு முடிவெடுப்பாங்க. ஸோ it was a worldwide fight over several decades to say that is wrong. When you say a person with disability has a right, it means I have a right to take a decision. When you say I have a right to dignity, I have a right to autonomy. What does autonomy mean? I have a right to take decisions. Now, it is also a fact that persons may need some assistance in decision making. You can provide the assistance, but the right to make the decision cannot be taken away. That is what is enshrined in the United Nations Convention on Rights of Persons with Disabilities. That is what is now coming into Section 14 of our Disabilities Act, which says that you can only have a limited guardian. That is, if you need help in going to the bank, for that banking purpose alone, we will appoint someone to help you with that. But in the rest of your life, where you want to live, how you want to live, where you want to work, all that is your choice. Nobody else can interfere with that. That is the concept of limited guardianship. But again, that is an important right we need to protect. Now we are coming to the nuances of that right. So till now we've been fighting to say, this is a concept, please implement this concept. Now we are coming to, how do you actually implement this concept? Okay, I'll give you limited guardianship. Now a bank has to accept it, no? So those are the other issues. And most importantly, when we come to some of the disabilities that arise due to age, whether it is your chronic neurological conditions, dementia, Alzheimer's, and other disabilities where you may actually still require a guardian. Currently, the Disabilities Act does not provide for appointment of such a guardian who will take over your general needs. Because so there is a reason why Section 14 came and why we had the concept of limited guardianship. But there is also now a nuance that we need to understand, that there is this other subset of disability rights that we need to address. And now we have to figure out a way that one does not negate the other, because they are two different needs and they are two different rights which we have to protect. So I think that may be another issue that, especially for persons with autism, this will be a big issue, because we have now spoken about education. But when you move into higher education and you move on to adult life, they may need assistance. But how do you provide them that assistance without impeding upon their autonomy? And how do you do it in a manner which is legally protected, but also protects the dignity of that individual? Now, this is again the nuance that we will have to develop in the next 10 years, for which I think this room may be the most equipped to. And I think that is the challenge that the government is now seeking to address. Whether it is skilling, after skilling, if you're going in for employment, how do you address that? If you're then aged, how do you deal with that? If you need a home, how do you provide for them? So all of these are issues, I think, where the nuances of these other issues which we could not address because we were fighting just to be recognized that these were problems or that I have a right. Now we have addressed the problem of recognition of the right. So now we are moving on to the next stage, which is implementation of these rights in a manner which we want.
Thank you very much, ma'am. You want to say anything? Thank you, thank you. Thank you very much. She has taken from 2016 to 2026 and again from 2016, next 10 years, what we are going to foresee. Thank you very much. She has given a wide range of things from workplace inclusion of a disabled person in his or her inclusion, from reservation in her employment to a reasonable accommodation. We just now had a case where in the transport department, a spinal cord injured person has had an injury after being employed in the transport department. He was a driver. He wanted to be accommodated somewhere within the department where he needs to continue his service. Is there a rule for him? After surgery, his disability is only 10%. But he has a chance for being accommodated as a conductor. Whether it is true or not, that can be given. All these reasonable accommodation came recently. That is because of this RPWD Act and Section 20 of it. So all these kinds of RPWD Act sections, we may not be knowing, but we are into it and we need to know it. Kindly have a look. We can download it, RPWD Act 2016, you can download, and even the rules, 2018 rules, Tamil Nadu rules, you can download, you can Google it. Thank you very much. Thank you all the panelists for joining this session and giving your inputs. Thank you very much.
Thank you, ma'am. That was an insightful panel discussion on rights and legal protections. As we close today's convention, let's felicitate our final moderator and panelists. I invite Dr. Rama Chandra Mohan to felicitate Dr. Maithili. I also invite Dr. Maithili to felicitate our panelists. Dr. Vijayalakshmi, Dr. Satyaprabha, Ms. N.S. Tanvi, and Dr. Vasudha Prakash. And I also invite Dr. Rama Chandra Mohan to felicitate Ms. Saranya, Assistant Chief Executive Officer. That brings us to the end of a truly enriching Tamil Nadu Autism Convention 2026. On behalf of the
delegates, thank you so much for joining today. Or chinna information, delegates group la vandu we'll be sharing the feedback form. We'll also share the soft copy of all the material used today. All the PPTs and other stuff will be shared today in the delegates group. And we will also share the links to our WhatsApp channel and other social media pages. You could follow them. We are, as our CEO mentioned, we are conducting weekly webinars and we are making many other announcements, many other trainings have been conducted, and all those informations will be shared in the WhatsApp channel and other social